clear for you, right?
Yes.
It's easy. Thank you.
Hi, everybody. Good morning. We're going to chair this session about critical ill patients. As you know, with me, Gabriel Valle from Italy, and I'm Joseph Masip from Spain. And we had some problems with the screen, but fortunately have been solved. And we are going to start with the first presentation. There are 10 minutes for each one, 7 minutes for presentation and 3 minutes for discussion. And the first speaker will be Benjamin Denio from France, and going to talk about DPP3 is a predictor of shock in ICU. Next one, you present, huh?
Okay.
And you present the master lecture.
Thank you for your introduction. My name is Benjamin Denio. I am a critical care physician. I would like to thank you, the Professor Mebaza, to give us the opportunity to present our results. During my PhD, I mainly work on CDPP3 for circulating dipeptidase number 3 as a biomarker of acute cardiovascular condition. I am proud to present you our latest result entitled CDPP3 levels are associated with poor outcomes in shock results from the FROG ICU study. Shock state is a common condition in ICU. It's defined as a life-threatening condition of circulatory failure, leading to an imbalance between delivery and needs of oxygen and leading to tissue hypoxia. The main etiologies of shock are sepsis, cardiogenic shock, and hypovolemic or hemorrhagic shock. It's a frequent disease in ICU, 15 to 20% of ICU admission. This is a very, very severe condition with a mortality near to 20–30%. Unfortunately, no strong prognostic biomarker are available to predict outcome of ICU patient in shock. CDPP3 is a metallopeptidase mainly involved in the cleavage of cardiovascular peptide, namely angiotensin-2. We previously demonstrated that DPP3 is associated with mortality in cardiogenic and septic shock. In 2021, Frigesi et al. Demonstrated in a Swedish cohort of 2,000 patients that CDPP3 levels at admission were associated with the 30-day mortality in septic, cardiac arrest, and traumatic patients, but no data on shock were available. So the objective of the study was to compare the CDPP3 prognostic properties in septic, cardiogenic, and hemorrhagic shock in a prospective multicenter study. The study in question is the FROG ICU study. This is a multicenter and prospective observational study with 2,087 patients included. The criteria of inclusion were the mechanical ventilation for more 24 hours or catecholamine infusion. CDPP3 was measured at 2 time points at inclusion. This is the CDPP3 baseline, and at discharge. After ICU discharge, patients were followed during 1 year. The result, 2,087 patients were admitted in ICU during the study period, and among them, 665 patients were admitted for shock. The main etiologies of shock were septic shock, 64%, cardiogenic shock, 20%, and hemorrhagic shock. The 20-day mortality was 27%, and the 1 year mortality was 47%. Baseline circulating DPP3 levels were higher in shock patients when compared to non-shock patients at admission, 20 versus 70.5. When we analyze by type of shock, we observe on the graph of the left that 20-day non-survivor have higher CDPP3 levels at admission when compared to 20-day survivor. Whatever the type of shock, and we observed that the higher level of DPP3 was observed in hemorrhagic shock. On the left of on the right on the slide, this is a Kaplan-Meier curve representing the proportion of patients surviving according to the time after the ICU admission until 28 days. Patients were categorized by levels of CDPP3, and the red line corresponds to the patient with a higher level of DPP3 above the fifth quintile. We observe that higher the DPP3 levels at admission, higher the mortality. By analyzing by type of shock, in septic, cardiogenic, and hemorrhagic shock, this is the same thing. In red, you have the patient with high CDPP3 levels above the fifth quintile, and in green, this is patient with low DPP3 levels at admission below the fifth quintile. We observe that the mortality is higher in the patient with high CDPP3 level in ICU after admission. On the right of the slide, you have the proportion of patients surviving after ICU discharge, ICU discharge, during the follow-up of 1 year. We observe that the patient with the higher level of DPP3 have more chance to die during the follow-up. And we are interested in the occurrence of organ failure according to levels of DPP3 at admission, and namely acute kidney injury. Among our patients of 665, we observe 64% of patients with acute kidney injury. And in this patient, we observe the high level of DPP3. And interestingly, we saw that the level of DPP3 was associated with the CADIGO stage, so the gravity of the acute kidney injury. So we observe in this study that shock patient with CDPP3 levels at ICU admission, DPP3 is a prognostic marker of 28-day mortality and occurrence of acute kidney injury. At ICU discharge, DPP3 is a prognostic marker of 1 year mortality. We confirmed our previous results in septic and cardiogenic shock patients, but this is the first time where CDPP3 was measured in hemorrhagic shock and all cause of shock in ICU. Prospective studies are needed to confirm this result. Thank you for your attention.
Thank you, Benjamin. It's an excellent presentation. Now it's time for questions. Any question from the floor there? I know she's there. If not, a microphone.
A microphone for
Where's the microphone?
Miss. Okay.
Can you hear me? Oh, good. So every time I do, this is a great paper and really nice results. And every time I've done a paper like this, where I report a single marker of prognosis, I get hammered by the journal who says, what's the improvement of this over the existing markers? So how does this compare to troponin or any other marker that you would think would be valuable?
Sorry, could you repeat your question? I don't understand.
Is this better than troponin?
Ah, yes, this is better than troponin.
You need to show it.
Yeah. All my results are not in the presentation.
And what are you measuring with the DPP3? exactly? Inflammation? Oh,
Actually, we don't know what is the target of this enzyme, DPP3. This is probably mostly a marker of shock, but we don't know what is the target of of this enzyme. This is most a marker of shock.
Do you correlate the DPP3 results with hypoxia or
No, not in this paper.
yeah, because we don't know how it moves.
It's better for example, it's better for if we have a reflection on lactate. It's better than lactate. Either is hypoxia, it's better than lactate.
Yeah, okay. No, but to have some clinical correlated with this increase in your DPP3, I don't know, hypotension, hypoxia, use of catecholamine, that could be
Yes,
interesting.
yes.
Okay, thank you. And let's go on with the second presentation. Elevated plasma galectin-3 is associated with measured adverse kidney events after ECU admission. And Louise Bouton.
So thank you for this introduction. I would like to thank Professor Alexandre Mebaza for this opportunity to work on this project. This is my preliminary result of my PhD that I'm doing right now. And we will talk about acute kidney injury more than heart failure and discover a little bit what is galectin-3 as a biomarker of renal prognosis. First of all, as an introduction, acute kidney injury and kidney damage has a definition which has evolved a lot the last decades. As an ICU physician, creatinine is not enough. It's too late. Patients have a decrease of renal function, and what we want to be able to do is to manage patients before this point. So that's a really point for the use of the biomarkers, and that's the reason why in 2020, Marie Osterman changed a little bit and proposed a new definition in AQI group, which include biomarker for the definition of acute kidney injury. As a matter of fact, here we have a new stage, which is 1S, which define patient with no renal function loss, but kidney damage defined with a biomarker. Now, what is galectin-3? It's an unspecified protein for an unspecified organ. But what is very interesting is that in cardiovascular study, high grade of galectin-3 associated with the incidence of cardiovascular events. Moreover, they find in 2013 that high grade and high level of galectin-3 was associated with heart failure. But it's not enough to talk about acute kidney injury. As a matter of fact, here in this study, in a subgroup of patients with an eGFR under 90 milliliter per minute, we found that high grade of galectin-3 was well associated with the mortality and the prognosis. And even more, we found that the level of galectin-3 was associated with a poor eGFR, moreover, for patients with the severity of patients. So my study want to use galectin-3 in an ICU patient to identify renal prognosis. This is the idea using frog ICU. We took 2,076 patients admitted in frog ICU who has a plasma galectin-3 dosage at admission, and we identify two objectives. The first one was to identify renal prognosis using major adverse kidney events, which combine renal replacement therapy, no renal recovery, and mortality. And the secondary objective was to define the balance between mortality or the kidney damage. Results. Wow, that's good. We found a high level of galectin-3 that was associated with MAKE, and this is what we were expecting. Moreover, after a multivariate analysis and after adjustment on the severity scores and the confounding factor associated with no renal recovery, we found that still associated. The area under the receive operating characteristic curve was 0.76, which is quite interesting. But let's talk a little bit about something. Major adverse kidney events is combine renal injury and mortality, which is a global outcome. So we need to understand what is the balance between the one and the other. That's the reason why we've gone further and we've studied height level of galectin-3 that was associated with, first of all, mortality here, and with the severity of acute kidney injury here defined by CADIGO stage, CADIGO 1, 2, and 3. Moreover, in a multivariate analysis, it remains associated even after adjustment with mortality and acute kidney injury. So this is interesting because this biomarker is a good value for prognostic of mortality, which is global outcome, and acute kidney injury. Moreover, the area under the receive operating characteristic curve was 0.77 for acute kidney injury, and which was better than for mortality, which was 0.70. Finally, let's just open a little the discussion. And I told you that as an ICU physician, we need biomarker to identify one stage, which is A1S stage, acute kidney injury. That's the reason why we use galectin-3 here as a comparison with another kidney biomarker, which is NGAL. NGAL has been known in the literature to be a good biomarker of acute kidney injury, and we correlated with galectin-3. That we found that it was well correlating with 0.63 factor. Moreover, if you define subclinical AKI, which is stage 1S with NGAL, you can find that galectin-3 has a predictive performance of 0.76 for subclinical AKI, which is quite interesting. That's the reason why we're gonna go further, and that the conclusion of this presentation that in ICU, galectin-3 was well associated with the renal prognostic and global prognostic. But here, my PhD is now introduced. Let's go to further studies. And we need to know how GAL3 mediates these deleterious effects, first of all. And second of all, as clinical data, we want to go further into renal phenotyping as specific damage, first of all, and second of all, as subclinical acute kidney injury. I thank you for this presentation. And this is a collaboration between three different entities, mascot, with François Després, Alexandre Mebaza, and Etienne Gaillard, Corakid with Christos Hadjikristos, and in UCSF, Mathieu Legrand. Thank you for your attention.
So if there is some question, Professor Di Somma.
Thank you very much. This is very interesting. I just would like to address last slide that you say what we can do now, right? So do you have an idea what is galactin-3 mirroring? I think that galactin-3 is some way mirroring kidney fibrosis or something like that. So I don't think that there is any way to reverse. It is simply mirroring the fact there is some, probably, I don't know, I ask you, undergoing fibrosis. So the question is, did you measure galactin-3 after the evidence that you have AKI? I don't know, 1 week later, if there is a modulated, because as you say, this will be a target of a therapeutical, but effect of treatment. So do you have an idea what is representing and how can we manage eventually this?
Okay, I'm going to take two angles to answer this question. The first one is, yes, it could be very interesting to evaluate galactin-3 at discharge in ICU of patient, just to monitor the renal remodeling after having an acute kidney injury. As a matter of fact, it has been done. With François, we explored this point. It was associated with the severity of acute kidney injury, but still remain a problem because when patient died, they don't have a renal recovery. That's one point. The other point, more preclinical data. I heard you talked about fibrosis and galactin-3. This is quite true, but there's another fact in the kidney, and galactin-3 is associated with fibrosis, but moreover, it's inside the tubules. And when you have an acute kidney patient, you have a liberation of this galactin-3 inside the renal, and that bring some particular inflammatory cells that will do some remodeling and fibrosis. The interesting point would be to inhibit galactin-3 and to find if we can just limit this renal remodeling and increase patient outcome. Here, it's only for preclinical data. It's my PhD, and it has been to be verified in a clinical cohort, which is very complicated as galectin-3 is not such a specific of kidney, and there's a lot of compounding factors associated with that.
As you have noticed before, and from the question from Frank, this is a troponin club. So most of the people in the room believe that troponin is really a good biomarker. So also for your paper, if you want to convince your readers and audience that for the prediction of death, this signal is of value, you need to play with troponin. That's one suggestion. And the second suggestion, and perhaps a comment from your side, if you have already done so, some of us are really old-fashioned, and you have bashed creatinine and creatinine assessment. However, in your model, you have not dared to compete one-to-one against, for example, eGFR. So consider eGFR, or that would be kind of calculated, estimated glomerular filtration rate based on old-fashioned serum creatinine. And then this would allow you to see whether galactin-3, or because it correlates so strongly with creatinine, is even better than measuring or assessing renal function with eGFR. I think that would be, perhaps you've done so or not, it would be, might be a suggestion.
It's very interesting. We submitted this paper just recently, and in the paper we estimated with CKD EPI the eGFR, and it was well correlated with 0.69 with a raw factor. So we already done that. And in kidney we don't have troponin because it's not kidney, but we have creatinine. And the problem of creatinine is that when you evaluate it and you have an increase of creatinine, it's too late. As an anesthesiologist, for example, in perioperative patient, you will have an increase of creatinine after the surgery, but it's too late. So what we need to do is to identify, and I think somebody told it just yesterday, to identify before the surgery the patient with some risk. And biomarker here can be very interesting. As a matter of fact, there's a notion which is called the several hit, multiple hit. And when you're a young person, you can have one hit, you won't have a decrease of renal function. But after the first hit, which is you get hit by a car, but you will have a second hit, which is a sepsis, and the third hit, which is a cardiogenic shock, and then you will have a decrease of renal function, which is too late. So biomarker can help us to be before this stage. And this is the point of using galectin-3, but it's not enough. Galectin-3 don't have any, is not enough.
Okay, thank you, Louis. It's time for next presentation. It will be Adrien Picot from France. He's going to present prognostic impact of interleukin-6 or CRP in critically ill patients.
Thank you for the introduction, and thank you, Professor Mebaza, for giving me the opportunity to present those results. So my name is Adrien Picot. I'm an anesthesiologist and intensivist in Paris, and currently a PhD student in Alexandre Mebaza's lab. So my talk today is about a study assessing the prognostic impact of IL-6 or C-reactive protein in critically ill patients. So, as you may know, interleukin-6 is a mediator of the inflammatory response to both septic and non-septic aggression. It is the main inductor of C-reactive protein synthesis and release, and it has been implicated in several mechanisms leading to shock, such as vascular leakage, myocardial depression, or vasoplasia. from the literature in critically ill patients, we know that IL-6 is associated with the worst prognosis during sepsis, but in other contexts, data is very limited. Conversely, CRP does not associate with survival, but most studies are small sizes and limited to septic patients. So our objective was to assess the prognostic impact of IL-6 or CRP concentrations on survival and the need for organ support in a large cohort of ICU patients. For that, we use data and blood samples from the frog ICU cohort, which the design of which was already presented by Benjamin and Louis. And we use the first blood sample on inclusion in the study to measure CRP and IL-6. And our main endpoint was 90-day survival. So here are the characteristics of the patients and the 2,076 patients we included in our study. And you can see that these are rather ill patients with a median SAPS-2 of 49, a median SOFA of 8. There is 1/3 women, and a quarter of patients were admitted for septic reasons. The overall mortality was 30%. So the median IL-6 was 100.9 picogram per milliliter, and IL-6 that is higher than median was associated with male sex and comorbidities evaluated by the Charlson Comorbidity Index, the SOFA score on each one of its components, the need for vasopressor inotropes at baseline, ICU length of stay, and day-night mortality. And on the figure, which was supposed to be in color, but believe me, the IL-6 concentration was higher in patients with hemorrhagic shock. For CRP, the median was 143.7 milligram per liter, and in univariate analysis, high CRP was associated with age, male sex. The need for vasopressor inotropes are at baseline and ICU length of stay, and there was only a trend to higher day-night mortality. Concerning survival, you can see on these three figures and the upper panel the Kaplan-Meier curve, and in the lower panel the hazard ratio adjusted on SEPS2. For IL-6, when stratifying on the median in the study, we showed that the median pretty well stratified the survival of patients, and this effect was conserved across patients subgroups, and in particular in septic and non-septic patients. Whereas for CRP, the stratification on the median was significant, but the size of the effect was very low, very small, and the association was lost when considering only septic patients. We next divided our population into 4 subgroups according to the median level of both biomarker, with 2 concordant groups with both low levels of biomarker or high level of biomarker respectively, and 2 discordant groups. And what we can see on the third figure is that there is a significant difference in survival between patients with low and high IL-6, but for one category of IL-6, further stratifying on CRP does not refine the analysis. We then looked at the association between the level of each biomarker as a continuous variable and the probability of day-night death. And we found that there is a a log linear association between IL-6 and death, and translating into a notch ratio of 2.04 per incremental log, decimal log of IL-6, that is for each 10-fold increase. And conversely, the relationship with between CRP and mortality was small but significant, and the incremental risk was minimal. Last, we looked at the need for organ support, and we found that IL-6 was consistently associated with the need for renal replacement therapy and the need for vasopressor inotropes, both when considering all patients, and when considering only patients that were independent from the given support at inclusion in the study, that meaning at the time of the blood sampling. And for CRP, there is no clear association, at least not consistent association between conserve in all patients or in patients independent from the support at baseline. So to summarize, overall IL-6 seems to outperform CRP for patient prognostications. The main strength of our study is that we included a large ICU population, including both septic and non-septic patients. And some limitation could be that the time to blood sampling in the frog ICU was, there was some time between the admission and the inclusion, that is the time of blood sampling, that could have influenced some of the results according to the different kinetics of the two biomarkers. And also we focused on one limited aspect of the host immune response to aggression. And we could have looked at other biomarker, other inflammatory or anti-inflammatory biomarker. So to conclude, when assessing the prognosis of critically ill patients, you should prefer the IL-6 over CRP. Thank you for your attention, and thank you to all collaborators on this study.
Thank you, Adrian, for this excellent presentation. Now it's time for questions from the floor.
Thank you very much for presenting this very interesting data. I was just wondering if maybe you have an idea or can comment on, if I saw correctly, IL-6 as a prognostic factor for renal replacement therapy was not significant in septic patients. And I would have expected that, especially maybe in septic patients where there's a lot of inflammation, there would be a really relevant association between IL-6 and severity of disease or renal replacement therapy. Do you have any explanation why in those patients it's not?
Thank you for this question. You're right. It was a surprising finding that overall the prognostic performance of IL-6 seems to be lower in septic patients. I have no definite explanation, but I have hypothesis, and I think the main hypothesis is that results in the septic population could have been influenced by the timing of the blood sampling. We know from previous paper that in sepsis, IL-6 is higher right on admission, and then it declines rapidly. So as there is a substantial time in our study between the admission and the inclusion in frog ICU, that is at least 24 hours by design, then the lower in the septic population, the level of IL-6 in the septic population could have declined rapidly, and then the association might be lost. That's one hypothesis.
Your time is. Okay, go on with the next presentation. Cardiorenal syndrome, François Depré. Thank you.
Thank you very much. So before starting my presentation, I would like to thank the organizers for their invitation, and specifically Alexandre Mebaza for giving me the opportunity to present this talk. So I won't show you any results or any new results in this presentation, since all my colleagues took all the data, and I will just show you some new project we have, and I think it will give some result to present in the next few years in the great meeting. I'm a conflict of interest. So I'm going to talk about the cardiorenal syndrome, and specifically about the type 3 cardiorenal syndrome, which is cardiac consequences of acute kidney injury. Acute kidney injury is a very frequent syndrome that touches 8 to 30% of hospitalized patients, and it can go up to 50% in ICU populations. And as we know, AKI leads to chronic kidney disease that we know it is associated with an increased morbidity and mortality. But AKI by itself can be associated with a worse outcome without CKD. There are studies to advocate this. There is this cohort study where the author matched more than 30,000 patients with AKI during hospitalization to more than 150,000 patients without AKI. And they followed the patient for 1 year after hospital discharge. And what they showed is that acute kidney injury was associated with a 40% increased risk of developing heart failure in the year after hospital discharge. So there is a real link between acute kidney injury and heart failure. The pathophysiological pathway leading from acute kidney injury to heart failure are very similar to the pathways leading from acute kidney injury to chronic kidney disease and to chronic heart failure. We can see systemic inflammation, immune cell infiltration, renin-angiotensin aldosterone system activation, sympathetic nervous system. All this system seems to be involved in the development of heart failure after acute kidney injury. And this has been very nicely summarized in a recent review published last year in New England Journal of Medicine by Mathieu Legrand and Patrick Rossignol, where they summarize all the pathways potentially involved in cardiovascular consequences of acute kidney injury. They highlight the role of galactin-3, already pointed by Louis. I won't come back on this. And they, of course, highlight the role of renin-angiotensin aldosterone system. And I will talk a bit more about this as a potential target to improve outcome after acute kidney injury. There are a few studies advocating the blockage of this system after acute kidney injury. These studies from Etienne Gaia published in 2018 in Intensive Care Medicine from the FROG ICU cohort. I won't detail the FROG ICU cohort. You already saw many of the paper from this cohort. And so he looked at the patients discharged alive from the ICU who had an AKI during hospitalization. And they compare patients treated with ACE inhibitor or ARB at discharge with patients without blockage of renin-angiotensin aldosterone system at discharge. And what they observed, it was an improvement of the outcome at 1 year in patients treated with ACE inhibitor or ARB after ICU discharge. This result have been also observed in hospitalized patients, not in ICU, in a paper published the same year in JAMA Internal Medicine, where here again, the authors observed an improvement of the outcome when patients were treated at discharge after an AKI with ACE inhibitor or ARB. So this led Mathieu Legrand to design a study which has been granted by the French Ministry of Health and who will start probably at the end of the year or the beginning of next year. In this study, it will compare irbesartan with a placebo at ICU discharge in patients who had acute kidney injury during ICU hospitalization for 1 year. And the primary objective is to evaluate the impact of irbesartan on cardiovascular and global outcome 1 year after ICU discharge. There are many secondary objectives, and just the inclusion criteria are adult patients discharged alive from ICU and who developed an acute kidney injury during ICU stay. Of course, exclusion criteria, it's patients who who were already treated with ACE inhibitor or ARB before ICU admission, or who have a strongly recommended, where in which ACE inhibitor or ARB are strongly recommended according to international guidelines. The primary endpoint will be MACE, major adverse cardiovascular events, which is a composite outcome, including all cause of mortality and all unscheduled hospital admission for cardiovascular events during the year following ACU discharge. And in the secondary endpoint, it's mostly a kidney outcome and safety outcome. The last treatment I would like to talk about, it seems very interesting when we talk about cardio protection after acute kidney injury, is SGLT2 inhibitors. SGLT2 inhibitors, by decreasing glucose and sodium reabsorption, decrease intraglomerular pressure, decrease intrarenal renin-aldosterone angiotensin system activation, decrease hyperfiltration and inflammation in the kidney. And by this, it decreases volemia, arterial stiffness, and therefore it improves cardiac performances by decreasing cardiac preload, afterload, and decreasing cardiac wall stress. Then it leads to cardiorenal protection, and it has been shown in studies now that it improves cardiovascular outcome. It decreases hospitalization for heart failure, and it is associated with the stabilization. It is associated with the stabilization of eGFR. So it seems very interesting to test this molecule after AKI, after ICU admission. So with Alexandre, we designed a study very similar to the START or NOT study to test dapagliflozin after ICU discharge, but not only in patients with acute kidney injury, and we're going to see after the inclusion criteria. Here again, the primary objective is to evaluate the impact of dapagliflozin on cardiovascular, renal, and global outcome 1 year after ICU discharge. And we have also many secondary objectives. The inclusion criteria are the same that in a FROG ICU. It's adult patients who has been admitted and who were under mechanical ventilation and or catecholamine for more than 24 hours during their ICU stay. They are ready to be discharged, but this therapy will be guided with a biomarker, because to be included, you need to have NT-proBNP greater than 800 nanogram per liter, and or an eGFR between 30 and 90 milliliter per minute. So I believe it would be the first study in ICU with a treatment guided with biomarkers at discharge. The primary endpoint is also a composite outcome, including all-cause mortality, unscheduled hospitalization for acute heart failure, decrease of eGFR, and end-stage kidney disease. And we have also many secondary endpoints. So to conclude, AKI is a very frequent syndrome, in particular in ICU patient. It is associated with cardiovascular consequences and short and long-term worse outcome. Many pathways are involved, including renin-angiotensin-aldosterone system, and does the inhibition of these pathways improve patient outcome? Work is in progress, and I hope I will be able to present you some results in the years coming. Thank you very much.
Some question from the audience?
And why did you use irbesartan? You choose irbesartan or not another drug?
Sorry, can you? I didn't.
You presented several studies that are going on, and one is with irbesartan. Why did you choose
that one and not ACE inhibitor?
Or another? Is it a question of sponsorship? Or what?
No. There is no sponsorship. We choose this because it was maybe the most used in France, and we use sartan because there is less side effect than with ACE inhibitor, cough and stuff like this. But it was but it's not sponsored by the industry.
And how will we choose the dosage of these drugs? Because you put two different dosage. One.
Yeah, it will be start at 150, and then after 2 weeks, if there is a good tolerance, it will be increased to 30.
Okay, so you
milligram.
try to reach the maximum dosage possible.
Yeah.
Okay, thank you very much for your presentation. There is a question? Wait.
I seen in your second study, one of your inclusion criteria was an NT-proBNP over 800, and you're testing SGLT2 inhibitor. Is that correct?
Yep.
Is that study not just going to assess the effect of SGLT2 inhibition on heart failure patients rather than cardiorenal patients? And what's the rationale for including that rather than just EGFR?
We decided to include patients with a high NT-proBNP after analysis of the FROG ICU cohort, and we look at the prognosis of patients depending on their NT-proBNP at discharge, EGFR at discharge, and the population with the worst outcome was the patient with high NT-proBNP at discharge and or low EGFR between 30 and 90. That's why we decided and we chose this cutoff to include the patients.
No more. Let's go on with the presentation. Thank you very much. Very nice presentation. So now we have a master lecture. Dr. Luella Wagon will talk about getting better or getting worse, illness trajectory in acutely unwell medical patient. Thank you.
Thank you. Thank you very much for the invitation. It is so lovely to be back here in Rome. So I'm unashamedly saying at the start, there are no biomarkers in this talk. And it's probably a good demonstration of why we need biomarkers. So this is a slightly back to basics talk. So in the United Kingdom, there's been a large push on to recognise patients who have deteriorated in the hospital setting. There have been a whole series of reports from an organisation called NCEPOD, which was solely set up to investigate deaths in hospital. And a consistent result from NCEPOD reports done decades apart was that patients had frequently had physiological deterioration in hospital for hours, if not days, before this was recognised and acted upon, and these patients then went on to die. As a result of this, the United Kingdom has something called the National Early Warning Score, or NEWS, and this has been subsequently been revised to be NEWS 2, which takes into account the differences for patients with COPD and the requirement for oxygen, and the differences in the target SpO2 saturations. I'm going to be talking today about NEWS 1 because the cohort of patients that we looked at predated the introduction of NEWS. But I think the important thing to say is that it's a track and trigger system. So each physiological difference is given a score. This is then added up, and then that gives you a total NEWS score. And then the person who has done the scoring must take action on this. And so part of the whole point of the introduction of this was that it was an auditable system, so that when something went wrong, they could go back and investigate this. So the interesting thing about this, of course, is that this has led to a whole entire flurry of research. And the emphasis in, I think this is quite an important point, the emphasis in the research has shifted from identifying those patients who have already deteriorated to identifying those patients who might deteriorate and might die, and to make decisions based on single time points. So there's been a whole lot of research around. So NEWS is now used for things like in the UK setting, deciding if you're in an ambulance, which hospital you might be taken to. In the emergency department at the point of triage, where you might go to. So do you need to go to resus? Can you go to somewhere else in the hospital, or can you go to an ambulatory unit with the presumption that you are going to be able to be discharged? Now, some of this is completely reasonable because this is what EDs do at triage all of the time anyway. You take a set of observations, and if the patient has really deranged physiology, then it's quite likely that this patient has got something really bad going on with them and they need to be moved. But nonetheless, I think that this kind of slight obsession with the need to prognosticate based on a single time point has completely dominated the research, and we'll come to that in a moment. So John Kellett, who some of you have met, so John Kellett had an insight with the work that he has done. So he has looked at cohorts in Ireland, where he's now retired, where he used to practice, Thunder Bay in Canada, and then in settings in Africa. And his insight with all of this is that actually the notion that if you come in with a high NEWS score, you're at high risk of death, that is true. But if you look at patient trajectories, it's most patients who come in with a high NEWS score, one of two things tends to happen with them. They either tend to die with a high NEWS score or they get better. If you come in with a low NEWS score, so you come in with normal physiology, one of two things happens to you, which is that you either get worse, so your NEWS score goes up, or you go home. And so in fact, the notion that a high NEWS score leads to a worse trajectory is not, in fact, actually, it is partly true, but not completely true. And so the way that we've been thinking about this and saying a single NEWS score is what's important is not quite true. So John's comment was that actually it's change in use. And again, we all know this because that's the whole point of actually repeatedly monitoring a patient and sending them off to ITU and monitoring them moment by moment. But somehow in this particular field of research, this has gotten completely lost. So John has suggested that actually it's only trajectories that matter. And one of his key insights, quite naturally, again, we know this, is that the faster you get sick, the more likely you are to die. And if you get better quickly, then we can kind of stop worrying about you. And I think this is completely true, because if you see a ball, illness is an active dynamic system. And if you take a single snapshot of it and you only have information about position of the patient, you have no idea about speed and direction, you have no idea whether the ball is going up or down. And it's the same with human beings. If I take a single snapshot of you and your illness, I have no idea whether or not you're getting better or you're getting worse. And this is reflected, as I said, in the literature. So this was a piece which was done by Mikkel Bradbrand, who has been to this meeting, and John, and they screened nearly 8,000 references on early warning scoring. And almost all of it is about prognostication based on a single time point. Only 2 studies, one of which was John's own study, were actually found suitable for inclusion in a meta-analysis out of 8,000 papers. So I think that this just shows where the literature is sitting with this. So we decided to make a basic contribution to this research by actually examining a very large cohort of patients and what actually happened to the patients in hospital. And again, if you look at most of this literature, you can't even work out who lived and who died. It's just in a single table, then with a prognostication and a ROC curve. And I must say, we did also end up having to kind of, we were partly forced in, I have to be honest about this, forced into taking this approach. All of these studies which look at outcomes, in order for news to make sense in terms of poor outcomes, you have to use a composite outcome, which is death, ITU admission, or cardiac arrest. And because we had a large cohort across 5 hospitals, the differences in the way that organisations collected data on admission to ITU and cardiac arrest made it impossible for the data, A, for us to be sure about it, B, to make sure it wasn't double counted, and C, to make sure that the information was actually commensurate. So we couldn't actually collect the information that was needed to do a comparative prognostication score. So we used, looked at 4 hospitals which had introduced VitalPack in England. The hospitals were geographically disparate, so it wasn't just from one area in England, in which case you might argue that it was about your local population. They were from disparate populations. The populations were also, we had one hospital in a very, very poor area, poor coastal area, and somewhere that was in a wealthy semi-urban area. The hospitals varied massively in size, which I think is quite helpful. So as I said, we looked at what we just wanted to take was a really basic approach and look at what actually happened to the patients in this large cohort. Oh, sorry, I'm going in the wrong direction. Yep. So nearly 200,000 patients, nearly 6 million data points. This is the largest cohort in the UK, and it's one of the top 5 cohorts looking at risk of death. The average length of stay was nearly 8 days. This is about average for the UK, and the inpatient mortality was about 7%. This is actually slightly high. The inpatient mortality for the UK is usually given at about 6%. And I'm not quite sure what the reason for this disparity is. There were some slight differences in the trust. As I said, one of the trusts was on the coast and had an older population that admitted more older people. So there are some process issues with this. But looking at the populations, we thought they were similar enough to pool, and that's what was done. So this is the basic basic data. As you can see, reasonable male-female split. About 20 to 30% of the patients were aged over 85. Again, this is increasingly typical for all of us. We're seeing older patients. And as I said, the hospital mortality is about, as I said, is just under 7%. Right, so this is the first recorded news died versus survived. So obviously you can see that if you come into hospital with a high news score, that is very abnormal physiology, you are quite likely to die. So, you know, I have no, as I said, no problem with this particular data point. However, it is worth noting that of those patients who came in with completely normal physiology at the point of admission to the system, a substantial number of those people went on to die. So just because you come into hospital with normal physiology does not mean that you are not going to die. And it's very easy to think of situations where patients, if you come in with chest pain, or you come in with your first inkling of a PE, or you've had a bit of a headache, and actually that's the start of your subarachnoid hemorrhage, you may very well come into hospital with normal physiology. So there is an increasing push in the UK to say that patients with a news of 0 do not need to go to a hospital. This is why ED triage symptoms need to take into account other symptomatology and not just actually what your physiology is. So, so this is my favorite slide of the whole thing, and we're getting it out of the way early. And this is to demonstrate that there's an extraordinarily strong interaction with age. When news was introduced, there was a discussion about whether or not age should be introduced. But if you look at this, for every step up in your news by age, this dramatically increases your risk of dying. So if you're over 85 and you come in with near normal physiology, you have a nearly 10% chance of dying during your hospital admission. So you can, that's the kind of risk that you can basically drive a truck through. If you're over 85 and your news score is high, you've got over 50% chance of dying. So that's a coin flip. This is not the case if you are young and presumably reasonably fit and come into hospital, where if you come in, so if you're young and you come into hospital and you've got normal physiology, your risk of dying is less than 1%. Actually, it's about 0.5%. And even if you come in very sick, we're very likely to cart you off to ITU and do things to you, and you've still got a chance of survival. So the interaction with age for this is very strong. And in fact, I think it's so strong that I'm not exactly sure how useful, news is clearly useful in the old, but the notion that we can triage based on it in the elderly, I think it's not that useful at all. Average length of stay by news. Again, there is this presumption that if you come into hospital and your physiology is relatively normal, you can go home fairly quickly. But actually, if you look at this on the far left-hand side, if you come into hospital and you have a low news score and you go on to die, this is the group of patients that has the longest length of stay. And if you think about this retrospectively, it's fairly obvious, because if you come into hospital and you get worse and something bad happens to you, and then you get sick and then you die, you're likely to have a very long hospital stay. So the notion, again, that if you've come into hospital with a news of 0, it meant that you never came into hospital and you're going to have a short length of stay and you can go somewhere that's a short stay area or be triaged into somewhere that's ambulatory care and go home. It's just not true. The patients who tended to have shorter lengths of, and these patients had longer lengths of stay than those patients who came in very sick, went to ITU, and then subsequently were discharged alive. Right. Peak news. So we wanted to have a look at the length of time it took you to get to your peak news if your admission news was 0. And again, those patients who came in who were young, who had news scores of 0 didn't tend to increase their news very much. If you were elderly and came in with a low news score, you were actually more likely to increase your news score, have a high news score, and then go on to die. Days to peak news score. Again, as you might expect, the longer you stay in hospital, the more likely you are to get sick, which means the less useful it was that what your physiology was at your point of presentation. And again, we kind of know that, but that's not the assumption that we make when we use these things to score people at the start and make decisions. The last recorded news, so as you might expect, actually most people who came in with low news scores went home, and so their lowest news score tends to be low. If you look at the people who go on to die, actually a substantial number of people die with in fact, if you look at this, there's not much difference distribution-wise in terms of what the news scores are when you die. So actually, plenty of people die, of those who die, about the same proportion die with relatively normal physiology as who die with very abnormal physiology. So although the change is important, just because your patient is sitting there with normal physiology, even in a hospital bed, doesn't mean that your patient may not, in fact, actually go on to die. Now, there is also what we don't know with this, and we've tried to tease out from the data, is how many of these patients, when they came in, the death was expected. So we can stop taking observations. So if you've got a cancer patient who's coming in at the end of their life and they come in with relatively normal physiology, but you know that they're going to die because, for example, they've got a head full of tumour, you're going to stop the observations. So what we haven't managed to tease out is how much of this is actually unexpected death and how much of this is actually planned death where the patients are then actively palliated. This we need to dig into, we're going to need to dig into a little bit more, which was the difference in initial news score by diagnosis. And as I said, it's already been recognised that the patients who come in with COPD have different news scores from the rest of the population. And actually, the way that they do is different because patients with chronic COPD will come in with lower SpO2 and a higher respiratory rate and are possibly more tachycardic. So they will have a higher news score, but actually do quite well. Oh, I should say this is for the top 3 admission diagnoses. But there's actually quite a big difference in the way that these patients look when they come into hospital. And we've started looking to what happens to these patients when they die. And again, it looks like and again, we instinctively know this, or we know this as doctors, but it's not reflected in the way that we use these scores and the way that we think about these scores, which is that if you have a different illness, the trajectories of illness are different and the point at which you die is going to be different. And that prognosticating using this is probably going to be majorly impacted by illness state. And that those patients who are septic, where you have very deranged physiology, is going to look very different from other types of illness. So some quick conclusions. As I said, this is relatively early work. We've not finished digging all the way through it. But I think it's important that juniors understand news. I think one of the problems in the UK is that it's now become such a monolith and it's become such a stick to beat people into certain type, if anybody who has a news at 12 thinks sepsis, you have to run off and do your sepsis 6, even though it's something else. That actually we've forgotten to teach people around the nuances of physiology and the fact that human physiology is a dynamic system which changes, and it's the change that's just important, and it's the basic underlying interaction with what that human's physiology is like that's equally as important. There is an extremely strong interaction with age. My personal opinion, just looking on this, is that the news score should be completely readjusted for age. And news is not remotely predictive of length of stay. So the use of news in the UK for deciding who should, for example, be treated in an ambulatory care unit, it is not useful for that at all. The patients who have the longest length of stay are the patients who come into hospital with normal physiology and then go on to die. Getting sick later in your admission has a much poorer outcome for you than actually being sick when you come in. And again, we don't know whether this is recognition or whether this is a reflection of patient cohort. So actually, if you're in hospital for a long time, it's because you're old, you're not that well, we can't quite get you out, and then you get a hospital-acquired infection and then you die. So we're not quite sure what's going on there. And there's differences in presentations by disease state. And again, I think there's substantial work that needs to be done about this. And Richard Nowak, who's not here, has been looking in this using alternative forms of physiological measurement. And I think there's probably, this supports Richard's contention that different disease states have very, very different outcomes. That's it. Thank you.
Okay, thank you, Luella. Fantastic presentation. I have two questions. One is, what do you do with this score as a prognostic marker? Do you make decisions when you have a very high score? And my second question, I want to go ahead and.
Oh yeah. So what's supposed to happen is that if you have a very high score, it's supposed to kind of grade the response. So if you have a very high score, basically you're meant to call ITU straight away, and the ITU is meant to come to the patient. If it's a medium high score, it's about, because the people who, part of the problem with the system is that it's aimed at healthcare workers. So taking observations is no longer even a nurse's job, it's a healthcare worker job, because vital pack just means that you just strap on a blood pressure cuff, put the SATS probe on, and the nurse healthcare worker doesn't need to, how can I put this, think about it. And so the work has devolved down. And so this means that the response is extremely simplified. But what we do know is that the same patient repeatedly triggering leads to extinction in the response of the team. So if you know that Mrs. Jones is sick and Mrs. Jones is repeatedly sick and we know Mrs. Jones is sick because she's got COPD and she's getting Ventolin nebs, then actually that mutes the response. And so there's really interesting problems with the use of these systems in hospital, and the fact that the response to it is a prescribed response. And no one has ever demonstrated that putting in track and trigger systems, because of these problems with extinction, actually improves patient outcomes.
And there is a question there.
Thank you very much for the great presentation. I think that's really an important problem in the hospital. And for instance, do you think it would be possible for when the patient is at the ward, because he had the first triage, then he was triaged to go to the ward, and then the score get worse. And we have all this automatic data updated in a computer system. Do you think it would be possible to apply like a background program that when the score is over, I don't know, the threshold, it pops up a warning, for instance, because that would be extremely useful in the surgical world.
That's what's already happening. And frankly, it drives everybody bonkers. So in my hospital, we use a Cerner system. And so every single one of my patients is logged into Cerner. And so every time I log into Cerner, all I get is a screen full of, these are your patients who are sick. And the first thing I do is go, I don't care, because I'm a consultant, and actually mute the screen. And so So I find this really interesting, because it's one of those problems of you've got an automated computer system, which looks like it's going to make your life better. But actually, when it's put into practice, it makes the life of the junior doctors worse. And as I said, despite all of the work that's been put in, no one has ever demonstrated that using a MET system makes your outcomes better because of the problems of behavior and extinction. And you know, there is also, I said, the issue is that if you're really sick and someone does something, there will be a period where you're still sick, where no one needs to do anything, but then you'll get better, or you'll go to ITU. But actually, the patients we don't tend to pay attention to are the patients who come in well, have minor changes, which in an elderly patient might actually represent a really substantial change in their state, but we don't register that because they don't look very sick, and then they die.
Thank you. I think we have no time for more questions because we are out of time. Thank you, Luella, for this excellent presentation. Let's go to the last speaker. A master lecture will be Christian Nickel from Switzerland. He's going to talk about chronologic versus biological age for risk stratification.
Dear chair people, thank you for the kind introduction. Can you hear me okay? Okay. I'm working at the front door, so I'm an emergency clinician, and I have a different perspective on risk stratification than a clinician working in the hospital. Before I start, I helped write a book on geriatric emergencies. a member of Geriatric EM Europe. We brought out some educational material. I will have a QR code at the end of this lecture, and you can check it out. So today, I want to talk about the difference between chronological age and biological age, mention some high-risk presentations in older patients, and want to talk a little bit about traditional versus non-traditional vital signs, and then I'm going to conclude with my ABCs. So I know this is a very interactive group, so I ask you to vote. These two monkeys on the left and the right, they are the same age. In fact, they come from the same breed. What's the difference in their upbringing? Just shout it into the audience. Okay, so physical activity. No, it's not physical activity. I think that would be an interesting experiment. No. The younger one
and the other not. One has illnesses and the other not.
No, this was reproduced multiple times. 30% calorie restrictions. So we're in Italy. It's really tough to restrict calories. So you're saying this is banal and we're free of all of this. And this is the so-called left digit bias. So this is bypass surgery patients 2 weeks before their birthday versus 2 weeks after their birthday. And there's a difference. Oh, the pointer doesn't work. Okay, I marked it for you. They're less frequently operated just based on the number. You are more likely going to buy a product which is $79 versus $80. Again, biological age is not the same as chronological age. He seems to do pretty well too. This is him 2 days ago. Captain Kirk at age 90 is doing pretty well. On the other hand, Mr. Spock at age 83, it's sad to see your heroes. I mean, there are so many young people here, you don't know Mr. Spock probably, to see him frail and old. So obviously, we're talking about frailty. So what is frailty? Frailty is an increased vulnerability towards stressors. And this stressor can be minor, urinary tract infection, for example. So the robust older patient will not decompensate, but a frail older patient will decompensate heavily. So what happens to frailty? You have a stressor event, and frail older patients will react in three distinct ways. Number one would be they will complain of weakness, will have gait instability. Number two, they will fall, or they will develop acute confusional states called delirium. All of these three have very similar outcomes. Simon Conroy, a professor of geriatric, says they hunt in herds: weakness, falls, and delirium. If you have one, look for the other two. So now up to risk stratification. So I'm working at the front door. And what will we do at the front door? We will do vital signs. We will look into higher risk symptoms, and we will use our sixth sense. In fact, the sixth sense is not that bad. If you ask emergency physicians, will you be surprised if this patient dies within 30 days? This is a pretty good predictor of outcome. So patients usually don't present with one single symptom, such as chest pain. They will come with a combination of symptoms. In fact, a median of 2.4 symptoms. But whenever this high-risk presentation comes up, weakness and fatigue, the prognosis is worse. The risk of dying is twofold higher. So weakness and fatigue are danger symptoms. And before I started working in this field, I never thought that these were dangerous symptoms. So I think it's a wolf in sheep's clothing. If we look at triage systems, for example, commonly used triage system, the Manchester triage system, frequently assigns unwell. This is if you can't find another symptom to assign your patient to. And this group has the highest mortality, even if adjusted for age, gender, and triage urgency. This was just published. We use a different system. It's imperfect as well. We found an under triage rate of about 20% for older patients, and we did not recognize high-risk situations and did not interpret vital signs adequately. So now one word about vital signs. Normal can be abnormal, abnormal can be normal. And this is why I agree with Llewellyn Vaughan. News needs to be age adjusted. One example, infection in older patients, the usual cutoff is 100, but the prognosis becomes worse in patients aged 70 and older if you use a cutoff of 120. So in septic older patients or in older patients with infections, 120 is the new 100. A good advice is always compare it with the baseline. A normal gait is a very, very good prognostic marker. So if a patient has a stable, independent gait, it is very unlikely that this patient is going to die. And we have reproduced this on multiple occasions and in different cohorts. If you use this as a non-traditional vital sign at triage, regardless of the triage level, you have a low-risk group. If they walk into your emergency department, it's fantastic. Not always. Conversely, if you look at older patients in the last 2 years of their lives, if bed rest is increasing to 50%, they're likely approaching their last 4 weeks in life. So now, are frail individuals at higher risk from acute illness? Absolutely they are. So there's number one, with increasing degree of frailty on the one hand, that's the one axis, and with increasing disease severity, for example, measured with aggregated vital sign scores, such as NEWS, as Luella showed us. So there are two axes, basically, and maybe a third axis presenting symptoms. Again, the outcomes are very similar: mortality, institutionalization, and length of stay. How do you measure frailty? We use the clinical frailty scale, which is already existing for more than 15 years, and we translated it into German and validated it in our ED at the front door. You have these pictograms and a short vignette, and you will assign the patient a frailty score. And what you could do with this information is that, for example, in mildly frail patients, you would start screening for geriatric syndromes, and severely frail patients will be receiving a more holistic approach. And these are beautiful data, I think. More than 2,000 consecutive patients aged 65 and older. They are stratified beautifully by the clinical frailty scale. CFS 5 is mild frailty and higher. So now to a few examples. Here's CPR. if the CFS is 5 or higher, the prognosis is really bad for CPR. If you suffer from COVID, you can again stratify patients by clinical frailty scale. Another study, I know there are many ACS people in this audience. Frailty is prognostic in ACS as well, and in heart failure and in pneumonia. This is a beautiful score developed by Simon Conroy, the hospital frailty risk score. You just choose certain ICD diagnoses, and the hospital frailty risk score can be calculated with these diagnoses. So maybe we need to think differently. Smoking is a cardiovascular risk factor, absolutely. But for patients who have cognitive impairment, for example, we should think smoking can be a fire hazard and be dangerous. So we're always focusing on diagnosis, but I think we should also consider the prognosis of our patients. So knowledge is knowing what to do, and wisdom is knowing when to do it. So in summary, common triage criteria fail in older patients. Frailty presentation, acute frailty presentation would be weakness, deliriums, and falls. So they hunt in herds. We need to interpret vital signs cautiously. There are non-traditional vital signs such as mobility or mental status, for example. And I suggest to consider frailty status in your studies. It is really prognostic. So here's my promise, the ABCs of geriatric emergency medicine: always begin cautiously and do evaluate frailty. Thank you very much.
Thank you for this excellent presentation. Now it's time for questions. Salvatore.
Thank you, Christian. This is really terrific. Congratulations. I really appreciate it. And also, you gave me the possibility to make the same question I was taking to Luella, but was not because of time. So there are two options now. Either you create a new scale and use for people, I don't know, greater than 70, or what we can do based on your fragility, you can say, okay, this patient is 75 years old, right? So, but it seems to have a low score. Can we adjust only this group of patients? This will be a possibility. Or you, because I think in some way it still works. Also, if it's higher, it still works. Now, the problem is for the patient that have greater than such age, where you see that is normal. So can we adjust just that, or is it too much complicated? What do you prefer?
I think you're on the right track, definitely. I suggest to add additional information. I suggest to add frailty to the new score, or even simpler, we have looked at mobility. And if you do not, if you have a normal independent gait, normal mobility, if you have a normal mental status, if you have a normal news, if you don't have high-risk symptoms such as dyspnea, you're very unlikely to die. Remember, Luella looked at patients who have been considered high risk because they have been hospitalized. So I'm talking about the people that we see at the front door.
Another question there. Back on the floor.
Hello, Christian. Lovely presentation. Super important concept, and I think we probably underappreciate how important this is in practice. My question really is, have you operationalized the clinical frail scale in your emergency department? And if so, what sort of pathways do you have for patients that are frail that differ from other pathways? And forgive me, I may have missed the very beginning of your presentation if you already covered that.
I did not cover that. So two things. Frail older adults are at risk of adverse hospital exposures. For example, delirium, they frequently get a urinary catheter, interesting data by Luella previously. So we try to separate them from the normal workup area to a quieter observation unit, so to prevent delirium. Then we have specialized nurses who start screening for geriatric syndromes. And also we're in, and that's great about Basel, we're closely collaborating with geriatricians. So we have 2 geriatric hospitals nearby, which will receive our patients too.
There's a question. Sorry.
Hello. Can I ask, does identification of frailty early in admission, does that lead to better care or better outcomes or better patient experience if the patients are identified at the front door as frail?
That's a wonderful question. I believe so. I don't have the data to show it to you. But another thing which might connect the 2 questions by Nick and you is, so there's an easy framework called the 5M framework. So that's geriatrics for beginners. And one of these 5 M's are mobility mind is in there and matters most. So what does the patient really want? And we try to apply these 5 M's to our patients and improve their experience, but I don't have the data to prove that to you.
Now, the final question from Luella.
Oh, it's more of a, oh, sorry, it's more of a comment rather than a question. So yes, I would agree that physiological scoring alone is not enough. The question is, what do we use? In terms of the operationalization of frailty, frailty scoring is at the front door is mandatory in England. The problem that we found looking at the data is that for those hospitals that actually do have frailty units, the average number of beds is 10, when the average take of patients who need a frailty unit is 25 to 30. So even when we do it, there is no capacity that's been created to care for these patients appropriately.
That's true. Oh, I'm off. I agree with that, but in England is maybe under a lot of pressure there. We do, you know, the first step is measuring frailty and finding out what's the rate of frailty in your population. So our patients, if we look at our 50,000 patients per year, 1/3 of them is aged 65 and older, and 1/3 of those is frail.
Okay. Thank you, Christian, for this excellent presentation.
Thanks.
Now it's time for coffee, but wait, we will advance a little bit the time of lunch, 15 minutes. We will go to lunch at 11:45, but now it's time for coffee. We will come back at 10:50.
Okay, it's my pleasure and of my colleague Lenka Spiralova from Czech Republic to introduce this session on heart failure. I advise in advance that we have to stay absolutely into time because we have a light lunch that is waiting for us, and at 11:40 we have to finish the session. So I ask to the speakers to be absolutely careful in maintaining the time. If they can, we can't do any discussion for their speeches. And without any delay, if Monica Spirarova is here. Is she here? Okay, so it's your turn, and we are going to speak about prognostic value of new biomarkers in patients with chronic heart failure.
So dear ladies and gentlemen, dear chairman, thank you for being here. And I would like to talk about the prognostic value of new biomarkers in patients with chronic heart failure. I have nothing to declare. These data came from the FAR NHL registry, which is a quite big database of pharmacology and neurohumoral activation in patients with chronic heart failure. It was done by 3 big university hospitals in the Czech Republic by their cardiological departments, and total number of 1,100 patients were included. The inclusion criteria for the patients were a stable systolic chronic heart failure with ejection fraction under 50%. They had to be on the optimal pharmacotherapy and stable at least for 1 month. As you can see, most of the patients were men. They were classified mostly as NIHA 2 or 3, so it was a stable patient. The mean age was about 65 years of age, and the most common etiology was ischemic heart disease, followed by a dilated cardiomyopathy. The primary endpoint in 1 year follow-up was the death in every course, cardiac hospitalization, left ventricle assist device implantation, or orthotopic heart transplantation. Achieving this endpoint in 1 year, we have divided these patients into 2 groups. The group A is the patients who haven't achieved the primary endpoint. It was about 90% of the patients, and the group B that have achieved the primary endpoint in 1 year follow-up. To all the patients was done the basic cardiac examination together with ACG and laboratory, as well as the standard laboratory, standard biomarkers, and some of those also the new biomarkers I'm going to talk about. The first new biomarker was copeptin. Copeptin is a C-terminal fragment of preprovasopressin. It's synthesized by the hypothalamus, and during external transport is proteotically cleaved into vasopressin, neurophysin, and copeptin. So copeptin shows us the level of vasopressin, which we know is important in the fluid management in the patients. But vasopressin is very difficult to determine. Nevertheless, copeptin appears to have much more better stability and is more simple for detection, so it's suitable for laboratory detection. And in our register, we have discovered that the patients who have achieved the primary endpoint in 1 year follow-up had a significantly higher level of the copeptin compared to those who haven't achieved the endpoint. Second of these new biomarkers was mid-regional proadrenomedulin. Adrenomedulin itself is a vasodilatator peptide synthesized by endothelial and vascular smooth muscle cells. Its expression of adrenomedulin is stimulated by volume overload, so it's a marker of the congestion, we can say. And adrenomedulin, same as copeptin or vasopressin, is also derived from a larger precursor peptide called preproadrenomedulin. And mid-regional proadrenomedulin is one part of this precursor and is stable and reliable surrogate for measurement. And in our register, again, we have discovered that patients who have achieved the primary endpoint had a significantly higher level of the mid-regional proadrenomedulin compared to those who haven't achieved the endpoint. Third of these new biomarkers is pentraxin 3. Pentraxin 3 is a member of the pentraxin family, like for example, CRP. This family has the typical pentraxin structure. Sometimes it's also called a tumor necrosis factor. It's released by mononuclear phagocytes, dendrit cells, fibroblasts, and endothelial cells, and behave as a protein of an acute phase, which increase rapidly during endotoxic shock, sepsis, and other inflammatory and infectious conditions. So it's a marker of the inflammation. And the data from our register has shown that the patients with the worst outcome who have achieved the primary endpoint, death, hospitalization, LVAD, or heart transplantation have significantly higher level of pentraxin 3 to those who haven't achieved the endpoint. Two last new biomarkers we have set was SLOX1 and 3-nitrotyrosine. SLOX1 appears to be involved in atherosclerotic peaks, vulnerability, and rupture, and is dramatically elevated in patients with acute coronary syndrome. 3-nitrotyrosine is a product of tyrosine nitration and is identified as an indicator or a marker of cell damage, inflammation, as well as nitric oxide production. So it's a marker of an oxidative stress. And by these two new biomarkers, we haven't discovered the difference between the patients who have achieved the endpoint to those who haven't. So it wasn't statistically significant. So to sum up, high levels of new hormonal substances, copeptin, mid-regional proadrenomedullin, and pentraxin 3 might identify heart failure patients with high risk of adverse outcomes, and they might have a potential role as a part of an integrated approach to the assessment of chronic heart failure. In SLOX1 and 3-nitrotyrosine, we were not find their predictive value of prognosis for stable patients with chronic heart failure. Thank you for your attention.
Thank you. And now the presentation is open for the discussion. And while we wait for any question, I ask you something. I noticed that the last two biomarkers were not significant, but for instance, for LOX1, could you try, but it's more a suggestion than a question, could you try to stratify also for the drugs that patients use at the moment that you perform the analysis? Because for instance, for LOX, if you are using statins or things like that, they could influence your results, for instance.
Yes, that might be a possibility. What we have done, we have divided the patients according to their comorbidities. And by these patients, we have discovered some differences in the significance by these new biomarkers. For example, in patients with lower comorbidities, they have the prognostic value, but in the patients with the higher comorbidities, maybe into more adverse heart failure, they have lost their prognostic value.
Thank you.
I just wanted to ask you, according to your mind, what is the future place for these humoral substances? Could they replace, for example, natriuretic peptides, or what it is?
Well, honestly, I don't think they can replace natriuretic peptides, because in our study, natriuretic peptides were superior to all the new biomarkers, but we think that they may add additional information to the patients. Maybe if we will divide them to other groups according to comorbidities or pharmacotherapy. We can then find the groups with worse prognosis according to these new biomarkers, again together with natriuretic peptides.
Thank you. If you don't have any other question, we can move. We can say thanks again to Monica and move on to Carol Labs as well by chat. She's coming. Okay, then she is speaking about NGAL in chronic heart failure data from the FAR NHL registry. So it's up to you.
So, dear chair people, dear audience, thank you for inviting me. I will continue with the same registry as Dr. Špinarova before me, called FAR NHL, the registry of chronic heart failure with stable patients. And I will focus on NGAL and maybe head score as well. From the whole group of patients, 1,100, we excluded patients without available follow-up data and available biomarker levels, and gets to the final count of 547 patients. We've set the primary endpoint, which was combined with all-cause death left ventricle assist device implantation or autotopic heart transplant. And it was present in 74 patients. That means 13.5%. The death as itself was present in 11%, autotopic heart transplant or LVAD implantation in 2.6%. As we know, neutrophil gelatinase associated lipocalin, or in short, NGAL, is 25 kilodalton epithelial monomeric protein bound to neutrophil gelatinase, and its expression is upregulated in acute kidney injury or many types of inflammation or renal or myocardial ischemia or infection. And NGAL predicts mortality and acts as an overall marker for severity of cardiovascular diseases. Here we can see area under receiver operating characteristic curve for NGAL. It was only 0.64 with low sensitivity and higher specificity. We get cutoff for this value as 90 nanograms per milliliter. And we can see here the survival of NGAL or of patients with higher NGAL than cutoff value or lower. The difference is here 20% between those two groups. Then I want to show you the head score. It was set as the score for acute heart failure patients, and each letter of the name AHEAD means one comorbidity, so it's a comorbidity score, and it reflects the prognosis of acute heart failure patients. A stands for atrial fibrillation, H like hemoglobin, for female less than 150, for male 130 grams per liter. Then E elderly, upper than 70 years, A abnormal renal function with creatinine more than 130, and diabetes mellitus as well present. As I've said, it was acute heart failure comorbidity score, but we then transfer it and try to use it in chronic heart failure as well. And these are the results. Head score 0 or 1 point, the best survival 89%, patients without primary endpoints after 2 years. Then 2 or 3 points, 82%, and the most severe patients with 4 and 5 points, only 63%, even in pairwise comparison. We can see that the distribution of NGAL values are strongly associated with head score. Head score is down 0, 1, 2, 3, 4, 5, and 6, 5. And we can see that the NGAL levels grows when the head score grows as well, from 43 till head 4 and 5 till NGAL level 128. And here is a table of influence of AHEAD comorbidities on NGAL levels. We know that NGAL is its levels are very influenced by these comorbidities that are present in AHEAD score. That means atrial fibrillation, the difference of median of NGAL levels is huge, 13 nanograms per milliliter, or in diabetes, if it is present or not, it's 6 nanograms per milliliter in NGAL. And as well, it acts like that's the level of hemoglobin H or NGAL is mostly renal biomarker, so we can see the huge difference in renal functions. So let me conclude this presentation in stable chronic heart failure registry FAR NHL from Czech Republic. NGAL level is strongly associated with presence of comorbidities. AHEAD and NGAL themselves can predict occurrence events in stable chronic heart failure. And serum NGAL level is significantly higher when AHEAD score comorbidities are present, like atrial fibrillation, low hemoglobin, elderly, abnormal renal function, and diabetes mellitus. Thank you for your attention.
Thank you. And now the presentation is open for any questions. Okay. And I wonder, you showed that the HAD score is dependent on some factors that are it is possible to be modified. For instance, you can control the diabetes, or also you can increase hemoglobin. It's just a curiosity. In the 2-year follow-up, do you believe that modifying the score, because probably taking care of the patient, some of these factors can change, you will modify also the prognosis of the patients and the correlation with your biomarker?
Well, I think so, that modifying the stress factors or the factors that influencing the disease is very important. So we need to treat the patient well and titrate the medication to eliminate or lower the comorbidities as much as possible.
Thank you. Just one point, and I give the speech to Lenka Spiranova, but I have to remember you that at 1 p.m., exactly 1 p.m., we will have the pleasure to have the headmaster of our university, Professor Della Rocca, that is also the dean of the organization of the different schools of specialization in Italy. So I ask you kindly to be present at 1 o'clock precisely in the room, because he has just a short time that he wants to dedicate to us. So after this little announcement, Lenka, it's up to you.
Thank you. So thank you very much for this introduction. And I would like to call to the microphone the authors of the next presentation, Hyponatremia in Acute Heart Failure, Fatima Alieva from Switzerland.
Thank you for your introduction. Dear Professor Spinarova, dear Professor Pignatelli, dear colleagues, I would like to welcome you to my presentation about hyponatremia in acute heart failure. It is well known that acute heart failure is associated with multi-organ dysfunction that often leads to electrolyte disturbances. And the most common electrolyte disturbance found in hospitalized patients is hyponatremia. According to previously published studies, hyponatremia has been shown to be associated with poor clinical outcomes in patients with acute heart failure. However, the value of hyponatremia as a marker of adverse outcome, independently of other predictors, patient characteristics, and the prevalence of hyponatremia in patients with acute heart failure is still largely unknown. For this purpose, we use the Basel V study, Basel V was a prospective multi-center diagnostic study that enrolled adult patients with acute dyspnea presenting to the emergency department. In the current study, we included only patients with a final diagnosis of acute heart failure. Our primary endpoint was all-cause mortality at 180 days post-discharge, and our secondary endpoint was defined as a composite of all-cause mortality and heart failure readmissions at 180 days post-discharge. Patients were categorized into 3 groups according to the baseline serum sodium levels, and namely to hyponatremia, defined as serum sodium level of less than 135 millimole per liter, normonatremia between 135 and 145, and hypernatremia more than 145 millimole per liter. Moving on to the results. After excluding patients with missing values and no follow-up, we had in total 1,499 eligible patients. Among those, 14.3% had hyponatremia, 83.3% had normonatremia, and 2.3% had hypernatremia upon admission. In total, at discharge, there were 9.9% of patients with hyponatremia. And among those presenting with hyponatremia, 4.5%, which makes 1/3 of patients, remained hyponatremic at discharge. You can see the part of the baseline characteristics table on the slide. And results demonstrated that in hyponatremia group, in comparison to normal and hypernatremia groups, there were significantly more female patients, more patients with lower systolic blood pressure, more with chronic liver, prior history of liver disease, but less with chronic kidney disease. Also, the infection as a trigger of acute heart failure episode was also observed more in hyponatremia group, and patients had higher levels of C-reactive protein levels. There were no significant differences between groups in age, in NIHA class, in chronic heart failure, ischemic heart disease, in T-proBNP and GFR levels on admission. Our results showed that patients in the hyponatremia group had significantly longer duration of hospitalization in comparison to normonatremia group, but shorter in comparison to hypernatremia group. And the median length of stay was 12 days for hyponatremia group, 10 days for normonatremia group, and 13 days for hypernatremia group. As you can see from the Kaplan-Meier curve, the all-cause mortality rate at 180 days post-discharge was significantly higher for hyponatremia group in comparison to normal and hypernatremia groups. Event was observed in 25.1% of hyponatremic patients. Moreover, to assess the independent relationship between sodium status and clinical outcome, multivariable Cox regression analysis was performed. Included covariates were age, sex, infection, ischemic heart disease, chronic heart failure, systolic blood pressure on admission, and T-proBNP and glomerular filtration rate on admission. The hazard ratio for mortality in hyponatremia group compared to the reference normonatremia group was 1.62. The composite of all-cause death and heart failure readmission at 180 days as well showed a significantly higher event rate in the hyponatremia group. The event was observed in 36.7% of patients with hyponatremia, and the hazard ratio was 1.49. All the results were statistically significant. Our study had some limitations. First of all, findings are specific to patients who present to the emergency department and are stable enough to give consent. Patients with terminal kidney disease were excluded from our study and cannot be commented on. And lastly, only sodium levels upon admission were included in survival analysis. So in summary, according to our findings, the prevalence of hyponatremia on admission was 14.3%, among which 1/3 remained hyponatremic at discharge. In total, 9.9% of patients had hyponatremia at discharge. Moreover, our study demonstrated that hyponatremia upon admission is associated with higher risk of mortality and heart failure readmission in patients with acute heart failure and should be taken into account for risk prediction as an independent marker of a worse outcome. I would like to add that these are only preliminary results and our research on sodium is still going to expand. Thank you for your attention.
So thank you very much for the presentation, and the paper is open for discussion. There is one question.
Hi there, thank you for an excellent talk. You had said that patients who have hyponatremia are more likely to have infection. Do you think that there could be other causes of hyponatremia other than heart failure, infection, malignancy, other causes of SIADH that could be driving it here rather than just acute heart failure?
Of course, hyponatremia is a multifactorial entity and there could be other causes. I just demonstrated our results and unfortunately cannot say the etiology right now.
Thank you. I would like to ask you, do you have any data about medication of these patients where there are differences, for example, in the usage of loop diuretics in the patients with hyponatremia?
Yes, I have a slide in appendix. Actually, we compared patients by medications on admission and at discharge. And there were no significant differences between groups by loop diuretics, but there was a significant difference on admission. Patients in hyponatremia group had more, took more spironolactone upon admission than two other groups. So that was the only difference.
Yes, thank you very much. There are no more questions. So thank you again for the presentation.
Thank you.
And we are moving to the last topics. Normally, weather is the topic in England, in Great Britain, but the presentation of the various difficulties with weather, climate, and cardiovascular diseases will be presented from the authors from Spain. So, Oscar Miro, it's your time.
Thank you very much, and thank you for inviting me to this conference. It's a pleasure to be here. I have to say this is a new topic for me, at least in part of the respecting to the climate and weather. I'm not an expert, so I have reviewed some concepts and I'm trying to bring you some aspects or concepts that maybe will help in further research. We all are responsible for the climate change, and it's no doubt that the temperature in the planet is increasing during the last years, during the last decades. And this climate change is affecting health in multiple ways, and research have increasing during the last years, as you can see here in the number of papers reporting data on impact on health of climate change. One of the systems that would be will be more affected for this climate change will be cardiovascular system. This is a comment just appeared in Nature Reviews at the beginning of the year, commenting that extreme heat events are now more frequent in many parts of the world as a result of climate change. And the combined effects of heat, air pollution, individual age, socioeconomic, and health status are responsible for avoidable acute events on cardiovascular diseases. So most of us are expert in some of these aspects, but I would like to highlight the aspects of heat and air pollution in my presentation. I'm not going to discuss the multiple ways, the multiple pathophysiological ways by which climate change can affect cardiovascular system. In resume, we have two main fonts of damage for cardiovascular system that can be resumed in air pollutants, pollution, and can be grouped the other part in weather conditions. So let's have a look on these two big effectors of health disturbances caused by climate change. Wow, sorry. Regarding air pollutants, I recovered this paper published in Lancet and led by Nick Miles, practically a decade ago. They reviewed the papers on effects of pollution on heart failure, and as you can see here, these effects, which were measured in terms of hospitalizations or death, in respect with the particulate matters, small and big particulate matters, there was a clear increase in these adverse events for these patients. Overall, and also for the LAX 0, 1, or 2, that means the same day or the day after, or the day or the 2 days after this measurement of particulate matters. With respect to gas components of pollution, here you have the effects of carbon monoxide, dioxide sulfur, dioxide nitric, and ozone. As you can see here, it's clear that carbon monoxide, dioxide of sulfur, nitric dioxide are clearly bad for the cardiovascular systems, and the role of ozone probably is a little bit more conflictive if you see at this slide. Also, I would like to remark, if you see to carbon monoxide here, the side effects are seen the day of the carbon monoxide increasing, but the day after this adverse event disappears, while for the oxide of sulfur or the oxide of nitric, you can see the effects of an increase in these air pollutants, in these gas air pollutants remains for the next 1-2 days in difference with the carbon monoxide. And the particular matters also sometimes contain dust, which is not frequent in certain countries, but as you can see here, exists a dust belt that in certain parts or in certain moments of the year circulate big concentrations of dust, and you have to recall that this dust belt covers more than half of population in the world. Here you have a report that was collected in Canary Islands, which is placed in this dust belt. And as you can see here in this study, the patients with heart failure dying from heart failure, they died the days that this concentration in dust in the particulate matters was increased. Let's go regarding to the weather. This is a couple of examples how the weather can impact to cardiovascular system. As you can see in the left, this paper was recently published in Circulation by a Kuwait team. As you can see here, extreme high temperatures are associated with increasing of mortality, and it's not so clear, at least in Kuwait, for low temperatures, which is placed at the beginning of the curve. On the right, you see a similar study performed in Cyprus. As you can see here, again, high temperatures cause immediate adverse events. If you see here, the increase in mortality the day of high temperatures is high, and this increase progressively decreases on day 1, day 2, or day 4 after this increase in temperature. As if you see here, you see that the cold spills have a delayed adverse events. As you can see here on day 0, there are no effects. And if you go to day 2 or to day 4, it seems that this increase can be clear. So the effects of cold or the effects of heat, it seems to impact differently in terms of cardiovascular diseases or in cardiovascular adverse events. This is an analysis on different reviews published about the temperature, morbidity, and mortality. And as you can see here, after reviewing all these papers published, increase in temperatures are associated with increments in cardiovascular morbidity and mortality. But these delayed effects of cold, the effects are even higher than what is observed with increase in temperature or during the heat waves. So many times for people working in this scenario have defined the harvest concept. The harvest concept is just the suspicion that extreme ambient conditions just anticipate for a few days adverse events that they were close to happen anyway. So this is a concept because when you speak about mortality, sometimes it could be a thought that maybe they are also involving very sick people. So this is an Australian analysis, which in terms, it doesn't focus on mortality, but focus in years of life lost, which is another form to see the impact of heat waves and cold spills. And as you can see here, the effect of heat waves, again, are very quick when they arrive. And after 2 or 3 days, the increase of risk practically disappears. And if you see here, the effect of cold spills are more maintained, is not so clear or so high or so big as the heat effect, but at the end also causes significant increases in years of life lost associated with these weather changes. I have to say that most of the studies published in the literature are time series or case crossover studies, which are ecological studies, and there are very few studies based on cohorts of patients with a specific disease, looking at different outcomes that could help to better understand what is the impact of health on health of the climate change. So I think that here is a great opportunity for a great collaboration. Why? Because most of us, we have a large databases of well-defined cardiovascular diseases or syndromes with very detailed patient information, with very close follow-up with multiple short-term outcomes being recorded. And atmospheric stations are ubiquitous in Europe and worldwide, and reliable weather and pollution data can be obtained for free from national agencies. So I think this is an important thing we have to think in the future, and maybe during the next years we can start a collaboration just looking better at these risk factors, which are not the traditional risk factors we are used to investigate. Here is an example of a couple of things that we have produced during the last 2 months. It's an example with patients with acute heart failure. And we have looked at 2 different outcomes. We have looked at if 2 weather conditions, which are temperature and atmospheric pressure, have any relationship with the severity of the compensation of patients with acute heart failure. And in a second step, we have looked at if these 2 weather conditions have any relationship, these 2 weather conditions at the time of patient discharge could influence during the very early period after discharge. You know that after discharge, there is a vulnerable period when patients are more likely to decompensate and come again, and even to death. We also want to see if the weather at the moment of discharge could have any influence in this regard. We have used the Spanish cohort of patients with acute heart failure, which is a cohort that have been developed during the last decade, and we have more than 18,000 patients with more than 200 variables recorded. And regarding the first aspect, I commented the influence of temperature and atmospheric pressure on the outcome, on the severity of decompensations of patients with acute heart failure. From these 18,000 patients, we enrolled 16,000 patients that came from 16 Spanish cities participating in this study. And at the end of these 16,000 patients, 70% of them required hospitalization, which is a surrogate of severity of the compensation, and 7% had an in-hospital death, which is a more close surrogate outcome of severity of the compensation. Here you can see the characteristics of these patients. I have to remark that these 16 Spanish cities came from 4 different climates, from Mediterranean climates, from continental climate, from oceanic climate, and 2 cities coming from Canary Island from a subtropical climate. This is the distribution of temperatures, of the maximal temperature of the day. As you can see in the previous table, most of patients were recruited on autumn, winter, and spring. We don't have patient recruitment in summer because in summer it's quite difficult due to the vacation of the staff in the emergency department. So these temperatures correspond to these three seasons. As you can see, there are some days up to 40 degrees of maximum temperature, and there are some days with a maximum temperature of 0. Regarding the atmospheric pressure, this has been centered respect to the mean atmospheric pressure of the city, because atmospheric pressure, as you probably know, depends on the how altitude the city is placed, and divided those periods with pressures over the mean, which is anticyclonic days, for this with depression days, which means that with a pressure under the mean pressure of the city. And here you can see the results respect to the need of hospitalization. And if you see up to this graph, you can see on the left, you can see the relationship of temperature respect to need of hospitalization. You can see that low temperatures and high temperatures are related with a higher hospitalization. And respect to atmospheric pressure, you can see that a little bit surprising that the periods with anticyclonic periods with high atmospheric pressure are related with a higher need of hospitalization. I have to say that these graphs and all calculations have been adjusted by age, by sex, by 6 comorbidities, by the season of the year, by the day of the week, by the climate type of the city, and also by temperature and atmospheric pressure by each other. Respect to in-hospital all-cause mortality, here you can see that extreme temperatures are related with higher mortality, while the low temperatures, as found in previous studies, it seems that this has not an immediate effect on in-hospital mortality. Again, atmospheric pressure, it seems that periods with anticyclonic or anticyclonic periods are more related with adverse events in terms of in-hospital all-cause mortality. Here you have the estimates. You can see that for a temperature of 40 degrees compared with 20 degrees, the increase in risk is 65% after adjusting by all these variables I have previously commented. And let me show the last slides respect the other approach that we have did with this database is that the question was, do temperature and atmospheric pressure the day of patient discharge affect to the very short outcomes of patients? Here the approach is quite similar. The number of patients are lower 14,000 because some of them had in-hospital death. So it means that were not discharged, so they cannot have adverse events. And the cities were the same, and collect of the pressure and temperatures were quite similar. Here you can see that the relationship between these outcomes, which were combined outcomes, 7-day combined adverse event consisting on death, need of reconsultation to the emergency department because of acute heart failure, or need of hospitalization because acute heart failure, was quite flat with no big differences. And these curves did not show it any specific, or did not provided any signal of a relationship between weather conditions, the moment of discharge, and the very early adverse events. So as a conclusions, I have to say that temperature and atmospheric pressure are independently associated with severity of heart failure decompensations, with possible different effects on need of hospitalization and in-hospital mortality. On the other hand, temperature and atmospheric pressure, the day of the patient discharge, are not independently associated with the risk of very early adverse events during the vulnerable post-discharge period in patients discharged after an acute heart failure episode. Thank you very much.
Thank you very much for a very nice presentation, and also congratulations to your very exciting own data from your research. And also thank you for keeping the time. So there is a time also for some questions. Professor Mebaza, Alex.
Yeah, I just liked so much. I mean, it's just great. And I saw that the best is between 15 and 25, which is Barcelona. Then I think there is a conflict of interest there. I'm not sure I understood why you removed the patients of the summer, and I'm not sure I got how you recorded the temperature and the pressure. Is it like at the exact hour the patient was admitted, or how was it exactly?
Regarding the first, we have not removed the patients coming on summer. We did not collect patients on summer, because when we planned the spots, we always plan during the autumn, winter, or spring periods, because on summer the investigators are on vacation, and there is it's an organizational problem. So we have not retired. We have not patients on summer. What's the second question?
When you put the temperature and the pressure,
okay,
was it related to the exact time and hour of admission, or how is it done?
We took the maximum atmospheric pressure and temperature of the day before the patient came to the emergency department, because the maximum temperature is always the same in Paris and Barcelona, and everywhere is about 4-5 p.m. So patients, if you took the temperature of the day the patient came, if patient comes at 8 a.m., the maximum temperature of this day cannot affect the severity. So we took the temperature and atmospheric pressure of the day before the patient was included in the database, which was the next day. The reason was this one, to avoid this problem.
Yes, the last question. So the two last questions, Professor Miller.
So you, by taking the maximum temperature, you kind of were focusing on the effect of heat. Would it be, an addition to also take kind of the minimum temperature, perhaps at 7 in the morning or whatever, that could be exposed to the patient to have a possible different finding on the effect of very cold temperatures?
You are right. Some papers are focused on the mean temperature. Some papers focus on the maximum temperature. If you go to the minimum temperature, I think you shift the curve of temperatures just 10 degrees or more or less. But the connection of probably the day of maximum temperature of 0, which is the minimum, was the days with at this part of the tail of the curve. So the relationship should not change very much. But this is just intuitive So we can check for that. Thank you, Christian.
Yes, and the last question, as we are running short of time.
Sorry, I have to stand up. Thank you for this great presentation. I have a strange, but do you have air conditioning in these hospitals, in the wards for this patient? Because I wonder like about the mortality, if the outside temperature, if you don't have air conditioning and the patient is in the normal ward, because sometimes you only have air conditioning in the ICU, if that could influence somehow this mortality effect.
Absolutely right, Daniela. We have air conditioning in every hospital in Spain. This is the rule. But I have to say that it's easy to fight against the heat waves, even to fight against the cold spills, because you can moderate the temperature of your home and you can remain at home for 7 days because outside is -5 or -10. What is not easy to adapt or adjust is the atmospheric pressure. And here we have demonstrated the relationship between atmospheric pressure and need of hospitalization and in-hospital mortality. And you are not able to modify this. The atmospheric pressure is the same in the street or indoor. So the problems with temperature, you can fight if you have money and have air conditioned or a good heat system. But with respect to atmospheric pressure, which are also increasing the level of changes with in last decades, as well as the temperature, it seems to be tougher to fight against them.
So thank you very much for your answers, and I would like to thank very much to all the speakers and all the discussants, to my co-chair, and also to the organizers of this nice block, and to end this block, and gave the word to the organization committee for inviting us to the dinner.
Hello, sorry, just a small communication. Tonight, we will depart directly from here to go to the Vatican. So after the lunch, take your coat, because we will have, after the closing remarks, we will have a small break to eat something, and then we will depart from here. And we must leave at 5. So everything here, and from here to the Vatican. Okay.
Okay. Thank you very much to be in time. I really appreciate that you stopped your lunch because we need to be in time. So I asked Professor Della Rocca, that is the Dean of the Faculty of Medicine and Pharmacy in our University La Sapienza, but also Chairman of the Italian Fellowship Postgraduate School of Medicine, to give a few words on you about the vision of our institution about young people involved in acute disease. Thank you again, Professor Della Rocca, Carlo, to be here and to share with us your vision.
Yeah, actually, I'm not here for sharing the vision. I mean, I just to give greetings for these very important events you are organizing. So good afternoon to everybody, and thanks to Professor Di Somma for inviting me to give institutional greetings to this 14th meeting of the Global Research on Acute Condition team. As Dean of the Faculty of Pharmacy and Medicine of Sapienza University of Roma, I'm really happy to be here. But I have to confess that I didn't know your activities till this moment. And so I can see that anyway, from what Salvatore explained to me, and from the program of the conference, I do not hesitate to say that the acronym GREAT well express what you are doing in this contest. So I am really happy that you are working on this topic. There is an increasing need for discussion on the problem related to treatment of acute disease, both in a strictly scientific sense and on in organizational terms, to give concrete answers to the health needs of civil society, and to fully exploit the new opportunities that technology's development offers us, also in terms of sustainability of our health system all over in the world. In this sense, sharing international guidelines in this area is a fundamental step, and therefore the work of the team is of crucial importance. That's what I think actually of your activities. As the context of the residency program in Italy, we have to look forward in our organization to empower the medicina d'urgenza, and particularly in the emergency context of territorial context. So we are pushing this sense, and so we in some way hopes that the developing of the new expertise in this context will be very important. As a member of the National Committee, we are offering several opportunities to the new schools to develop their networks in the territorial context. And so we hope that even your work can be very useful for our purpose. So I wish you a successful meeting, and I also invite you not to miss the opportunity to enjoy the so-called Ottobrata Romana. As you can see, the beautiful weather we have here. Maybe you brought the weather to us. So good luck for every day, and have a good conference. Thank you very much.
Questo sarà lasciato qua.
Brilliant. Well, I hope everyone had a very enjoyable lunch and you're feeling energetic because we've got a great session planned. So I think this might be the first session for GREAT on chronic coronary syndromes, is my suspicion. I don't know what you all think of this concept or term, but we're used to diagnose patients purely based on their symptoms and doing that for 300 years. Probably it is time to think again. I like the concept of chronic coronary syndrome. It's a condition that's with you for life and it requires active management. So I'm really looking forward to this session. Before I introduce the first speaker, I'd like to introduce my co-chair, Rudolf, who's from one of my favorite towns in the Netherlands, Groningen. Is that right?
Yeah, very good.
Close.
Yeah. No, thanks, Nick. My pleasure to co-chair with you. Yeah, I guess without further ado, we would like to invite the first speaker, who is Ryan Wareski from Scotland. So we have a very Scottish crew here up on the stage. I'd like to remind all speakers, so it's kind of a rapid fire, 7 minutes presentation, 7 slides, and then we have 3 minutes discussion. So if you think of a question, don't sit on it too long, but raise your hand. Okay, Ryan?
Hello, can everyone hear me? Yes, I think you can. So, good morning, or afternoon. My name is Ryan Wareski, one of the clinical research fellows at the University of Edinburgh, who works in Professor Mill's group. And today I'll be presenting some work that we have done on the role of troponin in the chronic coronary syndrome with colleagues from Imperial College in London. My only disclosure is here. So if we think about the diagnosis of angina, it really has changed very little in the past 200 years since first being described by William Heberden in his paper in The Lancet, Some Disorder of the Breast. And although physicians such as Robert Bruce developed the Bruce protocol in the 1960s, all progression in diagnostic techniques have really been focused on the identification of ischemia rather than the identification of patients who are at highest risk of complication. And this is actually despite our developments in our knowledge and our understanding of the physiology and anatomy of coronary disease. Now, with that being said, recently several trials, including Courage, Barry2D, and Ischemia, which I'm sure you're all aware of, have challenged the way that tests for inducible ischemia are used and disrupted decades-old practice of using ischemia to inform management decisions. But really, without an alternative way to risk stratify people, it's become increasingly challenging for clinicians to decide when revascularization might be the best option over medical therapy alone. And many people are now asking, what about biomarkers in stable angina or biomarkers in chronic coronary syndrome? Well, in patients with acute coronary syndromes, we know that biomarkers have a well-recognized and established role in risk stratification and diagnosis, but they're less so used in chronic coronary syndromes. That's despite the fact that research in this area is developing, and we actually know that in patients with stable angina, troponin levels are associated with high-risk plaque features. And we also know that if you stress patients with exercise who've got moderate to severe ischemia, troponin levels also rise. The one major barrier to the rollout of biomarkers in chronic coronary syndromes is a lack of a mechanistic explanation, and it seems a major hurdle. And actually, the phenomenon of troponin release after exercise can actually be seen in people who are healthy without ischemic heart disease as well, suggesting that troponin release is purely not mediated by ischemia. So to try and determine a potential role of troponin in chronic coronary syndrome, we conducted a sub-study of the Orbiter trial. In this, we aimed to evaluate how troponin levels changed before and after exercise, and also before and after revascularization. Now, for those who are not familiar with Orbiter, it was a randomized control trial of 200 patients who were known to have severe coronary disease. These patients were then randomized to intervention with PCI or a sham procedure. And we measured troponins both before and after exercise, both before and after intervention. So in total, we had 198 patients who were included in this analysis, and you can see that they had a high proportion of typical cardiovascular risk factors. We can also see that these patients were what some would call high risk, with the majority having stenosis in the LAD. Now, if we just look at troponin results at baseline before intervention, we can actually see that most patients have quite low troponin. But after exercise, you can see that levels do increase by a small amount, albeit. But if you look at the number who are above the URL and the number below the level of quantification, you can see those levels do actually change quite significantly after exercise. So remember, half these patients were randomized to PCI and half to a sham procedure. So if we look at the patients with the sham procedure, we can see, as we would expect, just like the first set of results, really there's a change after exercise. But then if we look at the intervention arm, we can see again that there isn't really a huge amount of difference in the pre-exercise troponins between these groups, despite the fact they were revascularized. And also after exercise, both groups had troponin elevation. So it seems to be that exercise is increasing troponin, but it was unclear whether it was being influenced by other factors. So to try and provide more information and determine the most important predictors of troponin release, we constructed a Cox model. And you can see here that other than age, the only really significant predictor of troponin release was exercise duration. We can again see that here in this plot, where you can see overlap in PCI and placebo arms, and exercise time contributing the majority to the troponin rise. But what are the three key messages here? Well, first of all, troponin levels are common after exercise in all patients. Second, revascularization and resolution of that ischemic substrate doesn't appear to alter resting troponin levels. And lastly, the level of activity rather than the level of ischemia appears to be driving troponin release. So what does this mean for us as clinicians in clinical practice? Well, we know that troponin is an excellent biomarker of risk, not only in the acute coronary syndromes, but across the spectrum of acute coronary to chronic coronary disease, from whole population risk stratification through to patients who come to hospital with chest pain who do not have an MI, but also potentially in patients with stable angina. And the fact that these levels of this risk stratification marker are unaffected by the presence or absence of ischemia supports the relatively new paradigm that plaque characteristics and dynamic activity within the vasculature is more important in predicting risk than ischemic burden alone. We also recognize that no biomarker would ever be able to determine exact percentage stenosis of coronary disease. Our results raise the idea that rather than using ischemia to stratify patients, troponin could be used as a continuous biomarker of continuous risk to be able to select
the correct patients for the correct test. Troponin results change dynamically, and combining that with risk factor profiles as well as imaging evidence of coronary disease could allow us to select the best patients and reduce the risk of doing invasive procedures. Thank you.
Thank you, Ryan. Bang on time. Right, questions from the audience, please. You've had lunch, you've had coffee. So Christian, straight in there. I was traumatized by these data.
Perhaps I can help you with your trauma, or perhaps the answer that Ryan will provide.
Might make it worse, who knows?
Usually, I'm very jealous if I hear presentations from your group, because you have an enormous size of study population, usually 40,000 sometimes.
48,000.
Now you might have some challenges with your conclusion, because this time you have a very small cohort and you might have overinterpreted the lack of effect of revascularization. Would you like to comment on the power in your study to detect the effect of revascularization or ischemia in general?
Yeah,
and perhaps on other studies that have tried to investigate the impact of ischemia?
I completely agree. With 198 patients, it's not a huge amount, but it's really one of the first studies which have measured biomarkers and tried to establish a role for them in competition with ischemia. And it gives some background and probably some evidence to why trials like FAME2, Courage, ischemia didn't show significant difference in outcomes, because they were basing it on a test that really possibly doesn't matter. I think we also have to be aware as well that the patients who were included in the trial, they don't always necessarily reflect the patients in clinical practice. And most patients, well, all patients in Orbita had single vessel coronary disease, rather than the typical patient we might see in the cath lab who has multi-vessel disease as well. Whilst no firm conclusions can be brought from this, I think that it does raise important questions that need to be investigated further.
Thank you for giving me the reassurance, Christian, that there's still hope. Now, if revascularization, I think we accept, reduces ischemia, but it didn't modify troponin in this population, yet troponin is a phenomenal predictor of cardiovascular events. What do you think troponin is telling us in patients with ischemic heart disease about the future, if it's not to do with the presence of critical proximal LAD disease?
Well, I think there's a couple of messages from the data. Troponin can be released for lots of reasons, and it's probably being released from the vasculature because of oxidative stress, and whether that's through exercise, whether that's through inflammation, or whether that's through ischemia. And it's trying to pick apart all of that information in each individual patient, because clearly in your patient who's got no coronary disease, who's 24, and stressing them, their troponin goes up, well, it's clearly not because there's myocyte necrosis. So we're trying to pick apart that information. And I think that using models or using AI tools that combine risk factor profiles with imaging is probably going to be the way forward.
Okay, thank you, Ryan. I'd love to discuss exercise-induced troponin release with you for the rest of the afternoon, but we have another presentation. Thank you very much.
Next presenter is Melissa Amrein from Switzerland, and she will be talking about TMAO for detecting functionally relevant coronary disease.
Dear Chair, Professor Mills, Professor De Boer, dear colleagues and dear audience, thank you for having me at this great conference, and it is my pleasure to present to you one of my PhD projects that I'm doing in the group of Professor Müller at the University Hospital of Basel on the topic of gut microbiota-dependent trimethylamine N-oxide, in short TMAO, and cardiovascular risk in patients with suspected functionally relevant coronary artery disease. As you all probably know, CAD is the topmost cause of death worldwide, and WHO actually suggests that 75% of major adverse cardiac events related to CAD can be prevented when incorporating the right interventions. Therefore, the early and accurate diagnosis of CAD is one of the most important tasks in modern medicine. And for that, the ESC guidelines 2019 for the management and diagnosis of stable coronary artery disease suggest that imaging, or recommend that imaging is the modality to use with a class 1 recommendation. However, as most of you also know, imaging modalities are expensive, they're not widely available, expert interpretation is needed, and patients are exposed to radiation. Now, biomarkers may combat this issue, and biomarker guidance in the diagnosis of CAD may have substantial medical and economical value. However, the ESC guidelines of 2019 also say that while multiple biomarkers may be useful in prognostication, they do not yet have a role in diagnosing coronary artery disease. Therefore, the search must go on for a suitable biomarker, especially for functional relevant coronary artery disease, the malignant phenotype of CAD that is defined as exercise-induced myocardial ischemia. Now, pilot studies show that TMO is elevated in patients and associated with CAD progression and also with increased risk of myocardial infarction and death. Interestingly, TMO is a product of the gut microbiota's metabolism of betaine, choline, and carnitine, which themselves are derived from the digestion of meat and dairy products. These proteins are suggested to have pro-atherogenic action, whereby the exact mechanism is not known. Also, the clinical utility of these markers for coronary artery disease is not known yet. Therefore, the aim of this study was to evaluate TMO and its precursors for its diagnostic accuracy, for functional relevant CAD, and for its prognostic value on adverse cardiovascular outcomes. For that, we used the Basel 8 studies, where patients were recruited at the University Hospital of Basel and where patients were referred to for myocardial, for stress and rest and stress myocardial perfusion imaging. 1,726 patients had eligible TMO and precursor measurements, and patient had 5-year follow-up data. Blood biomarkers were measured from venous non-fasting blood samples of TMO, choline, betaine, carnitine, as well as high sensitivity cardiac troponin T. And functional relevant CAD was centrally educated by 2 independent cardiologists by expert interpretation of the MPI scan data, as well as coronary angiography data whenever available. Now, to the results, I will focus mainly on TMO. We saw that TMO was significantly elevated in patients with functionally relevant coronary artery disease. And when looking a bit closer at this data, we saw that TMO was significantly elevated, especially in patients without history of CAD. However, when looking at the diagnostic accuracy of TMO and the precursors for functional relevant CAD, we saw that the diagnostic accuracy as measured as area under the receiver operating curve was quite low, with an ASC of around 0.55. And this did not change when looking at the subgroup of patients without history of CAD. When looking at the prognostic value, we saw that patients with a TMO level above the median had higher cumulative events for all-cause death and cardiovascular death. So we went on to combine TMO levels and high sensitivity cardiac troponin T levels with cutoff of the upper reference limit of 40 nanogram per liter. And we observed that patients with a marker level above the cutoffs had highest cumulative events for all-cause death, as well as cardiovascular death, more so than when troponin T alone was elevated. When interpreting these results, however, there are some limitations to be considered. So firstly, we only had a single blood draw at recruitment. Therefore, we have no trajectory of the marker and cannot comment on the biomarker in the follow-up. as we also do not have any dietary information, and this was a single center study. In summary, we can say that TMOO concentrations were significantly elevated in patients with functional relevant CAD, especially in patients without CAD history. But the diagnostic performance of the 4 biomarkers was low, and they had a prognostic value, or TMO especially had a prognostic value for all-cause and cardiovascular death, especially also combined with high sensitivity cardiac troponin T. In conclusion, therefore, we can say that TMO and precursors show prognostic value over a long-term follow-up of 5 years for cardiovascular outcomes, albeit with a low diagnostic value in patients with suspected functionally relevant coronary artery disease. With that, I'm happy to take your questions, and thank you for your attention.
Thank you very much for a clear presentation. Are there any questions? Well, people are... Frank.
So you did a nice job investigating that, and you used the area under the curve, which I think is a terrible way to present how well a marker works, because it requires you to buy sensitivity and specificity. And you don't really need that in real life. When troponin first came out, it was very specific and it was garbage sensitivity. Now they fixed the assay, but it took 20 years. So we now have high sensitivity and pretty good specificity with troponin, but that's not how it came out. And I would suggest that you look like it separates this out pretty good. And if you raise your cut point, you'll do that at the sacrifice of sensitivity, but who cares? Because if you have a highly specific marker, wouldn't that be useful? And have you entertained playing with that at all?
Thank you for your question. So if I understood you correctly, you would raise the cutoff of, are you talking about troponin T in particular, or?
No, raise the, so you have to have a cut point, right?
Yeah.
What's your cut point?
Of TMO?
Yeah.
All right. For this analysis, and because there's no established cut point, we use the median as a cutoff.
Right. So use the 75th percentile. That will make it less sensitive and way more specific.
All right. Yeah. Thank you. Thank you very much for the suggestion.
I have a question. So there's no dietary information, which of course is somewhat of a pity if you think about the microbiome. But medication, I guess there's data on medication. Can you say something? But did you look at there are specific medications that have a profound impact on the microbiome?
Yeah, thank you for this great question as well. So what we did is we looked at the baseline medication in our study cohort, and also as I mentioned in the talk, we observed this elevation of the marker, especially in patients without a history of coronary artery disease. And there we see that patients with a history of coronary artery disease are generally better treated. For example, we observed that I just had a quick look at the numbers. 85% of the patients in this study cohort received statins, and 83% received aspirin. So there's definitely a difference that can be observed in baseline medication that can, of course, lead to this observation.
Thanks. Maybe proton pump inhibitors you can look at.
Yeah,
those
definitely
are
as well.
But Nick.
I have some basic questions because I don't know much about this assay, but does it vary diurnally concentrations, and does fasting influence it? And could these factors have diminished its ability to predict functional core disease?
Thank you also for this great question. So there was actually a paper published not long ago, I believe it was in 2017 by Hyanza, and they did actually take some dietary information into account. However, when looking over the long-term results, there was no significant difference observed.
Okay. Yeah, I think for the sake of time, thank you. Thank you
Thank
very
you very
much for the
much.
presentation and discussion.
Super. Okay, so can I welcome to the stage Andronika, who's going to talk about renal failure and cardiac troponin T. Fascinating topic.
Thank you very much. Can you hear me? Yes, perfect. So Dear Professor De Boer, dear Professor Mills, dear colleagues, it is my pleasure to welcome you to my presentation about renal failure as a non-cardiac source of high-sensitive troponin T. Oops. Okay, perfect. As you're aware of, cardiac troponins are sensitive biomarkers of myocardial injury. However, elevated plasma cardiac troponin concentrations are a common finding in patients with end-stage renal disease undergoing hemodialysis. These elevations add prognostic information to these patients and is strongly associated with increased mortality. With the advent of high-sensitivity assays, cardiac troponins are now detected to a large extent in hemodialysis population, raising more questions about interpretation and clinical relevance. Possible causes of these elevated cardiac troponin levels are reduced renal clearance per se, chronic cardiac disease, and cardiomyocyte injury induced by hemodialysis. Bosbas with this study tried to examine the origin of these elevations after measuring cardiac troponin I with a conventional assay in 34 patients on hemodialysis undergoing renal transplantation. Troponin and creatinine values were measured at baseline, day 1, day 7, and day 13. And as you can see in the results, there was no significant difference in the levels of troponin despite restoration of renal function, suggesting no renal contribution to these elevated levels. Regarding these results, we wanted to examine the effect of changes in renal function after renal transplantation on the levels of troponin T this time, using for first time a high sensitivity troponin assay. We hypothesized that if elevated pre-transplant high sensitive troponin T levels reflect only chronic cardiac disease, these levels should remain substantially elevated after renal transplantation. From Basel PMI study, an ongoing prospective observational study implementing perioperative myocardial injury in patients with increased cardiovascular risk undergoing non-cardiac surgeries in the University Hospital of Basel, we retrospectively selected those undergoing renal transplantation between October 2014 and 2019. From 62 enrolled transplant patients, we excluded those with missing troponin values and acute myocardial infarction after renal transplantation. At the end, 38 patients were assessed. Troponin and creatinine values were measured on the same blood samples, and for troponin, we used the Alexis high-sensitive troponin T assay. Blood samples were taken at baseline and on day 1 and within day 2 to day 7 after renal transplantation. 11 of the 38 patients had also a troponin measurements between day 14 and day 180, where a steady state concerning the renal function was reached. The outcome was the time course of high-sensitive troponin T in the post-transplantation period. Proceeding to the results. On the left side, we have the troponin values, and on the right side, the creatinine values. The red line represents the 99th percentile. At baseline, the median troponin value was 53.5 nanogram per liter, and the median creatinine value was 630 millimole per liter. As you can see, all patients had at baseline troponin values above the 99th percentile, and their median significantly reduced within the first 24 hours without further reduction until steady state. On the other hand, there was a significant reduction between every creatinine measurement. If we focus now on the box plots before renal transplantation and on day 1, we can observe that within the first 24 hours, troponin and creatinine reduced almost in parallel. If we concentrate now on the day 1 and day 2 to day 7, we can see that after day 1, there was almost a flattening in the levels of troponin, whereas creatinine continues to decrease. Additionally, we calculated for each individual patient the time points where creatinine was dropped by 50%. There were 24 patients with troponin values at the same time point. These box plots represent the troponin values of these 24 patients, once at baseline and once at the time point where creatinine was reduced by 50%. As we can see, the median of these values, of the troponin values, between these two time points was decreased by 55%. This suggests that short-term improvement in the renal function leads to reduction of the pre-transplant cardiac troponin levels, suggesting that our initial hypothesis, assuming the chronic cardiac disease to be the only cause of the pre-transplant elevated cardiac troponin levels, to be wrong. Our study had several limitations. We examined a selected population with enriched cardiovascular risk, and we assessed not a large number of patients. Our data are additionally observational from a cohort study. Let me summarize. Our study is the first one examining the effect of changes in renal function after renal transplantation using a high sensitivity troponin assay. The use of a high sensitivity assay can be considered a reason of showing different results in comparison to older published studies. Reversing two of the three factors that could theoretically lead to the increased pre-transplant elevated cardiac troponin levels, namely the impaired renal clearance and the performing of hemodialysis, we observed a significant reduction of the pre-transplant elevated high-sensitive troponin levels within the first 24 hours. These suggest that the underlying cardiac chronic disease can only explain a proportion of these elevations, whereas more than 50% can be attributed to impaired renal function and myocardial strain during the hemodialysis session. The attributable effect of each of these two factors remains though unclear. Finishing, I would like to share with you that these results inspired us to plan a bigger study with more transplant patients, and I really hope to be able to present you our results during the next grade meeting. Thank you very much for your attention.
Fascinating. We're about to start using high-sensitive troponin T next week. So you've got me thinking. So your original hypothesis was wrong. You didn't tell us very specifically what your new hypothesis is now. So could you just tell us what the new hypothesis is based on your results?
Of course, thank you very much. Well, our new hypothesis is that, of course, there is an attributable effect of the chronic cardiac disease that these hemodialysis patients have, but there is also an attributable effect of hemodialysis induced myocardial injury and of impaired renal function. So we hypothesized that that a great part of this elevation can be attributed to also these two factors. And during our next big study, we plan to separately investigate these elevations, separating the patients into those who has previously hemodialysis and those who didn't have, because in this study, only 9 of the patients were patients without hemodialysis before the renal transplantation.
Yeah, I assume there's quite a lot going on in that first 24 hours following transplantation in a patient that was previously dialyzing and then is fasting and then having an operation and then getting all sorts of fluid resuscitation. How confident are you that this isn't a hemodilution effect?
That's something that I'm not that confident actually, and that's why I hypothesized that the hemodialysis induced cardiomyocyte may play a role. But as I said, with this data, we cannot say the attributable effect of each of these two factors, something that we hope to resolve and with our new study with more patients.
There's actually,
can we have a microphone?
There's already holding a microphone.
Or just while we're getting a microphone across, the obvious question, have you also measured troponin I? Because the previous generation studies were done with a contemporary assay that may not be precise enough to
I was expecting this question, actually. Thank you very much. We only measured troponin T because this study is a retrospective study, and in Basel we use as a standard this troponin T assay. The reason of the difference in our results in comparison to the other study can be, as I said, the use of a high sensitivity troponin assay first, but also the use of a troponin T, though there are still studies published years ago using second and third generation of troponin T, showing similar results to the study with troponin I.
Okay, so we shouldn't conclude just yet that there's a renal clearance mechanism because you're going to do some further prospective studies to validate these findings. Is that?
We're still on planning this study, but yes, I think that we are be able to reply to these certain uncertainties with this study. Yes.
Okay. Oscar.
Okay, thank you for sharing this interesting data. It's just a suggestion because dialysis is the most dramatic scenario of kidney injury. Have you planned or could you plan maybe to include patients with acute kidney injury like pre-renal or post-renal kidney injury, which rises creatinine till 9 or 10, and then in just in a few days returning to the normal value? And in this scenario, you have to check if the results are the same with a renal transplantation, because renal transplantation is a big intervention and the other one is a more dynamic one. So maybe because this is an ongoing study, you can try to make a second group, or maybe join all together, see if the performance or if this correlates with these findings. Thank you.
Great suggestion. Thank you very much.
Okay, I think in the interest of time, we'll close this. Thank you very much for that thought-provoking presentation.
Okay. The next speaker is Tobias Zimmermann, again from Switzerland, talking about novel insights into the pathophysiology of cardiac troponins T and I release.
All right. Thank you very much, dear Professor de Boer, dear Professor Mills, and dear colleagues and friends. It is my pleasure to give you, thanks, Christian. It is my pleasure to give you a short presentation today about some very interesting novel insights into the pathophysiology of the release of cardiac troponin T and cardiac troponin I. Just 2 years ago in Edinburgh, I opened up with this slide complaining about the large interest or the little interest that syncope got or gets from cardiologists compared to big topics like acute myocardial infarction and troponin. And now just fast forward 2 years to today, and here I am giving a presentation about cardiac troponin. So sorry, syncope. I'm not going to waste a lot of time giving you another introduction to cardiac troponin. I think you're all by now experts on this topic and on the many applications of cardiac troponin. Now, for quite many of these applications, and especially the diagnosis of acute myocardial infarction, current clinical practice guidelines assume that cardiac troponin T is interchangeable with cardiac troponin I. However, we do not really know if cardiac troponin T or the release of cardiac troponin T and cardiac troponin I really reflect identical pathophysiological mechanisms. And so we thought that maybe with our analysis, we could add something, some new information about potential differences in the release of cardiac troponin T and cardiac troponin I, and add that to the piece of cake of something we do know. And so our hypothesis, based on previously published data and data generated from our own studies, was that normal aging and chronic cardiac disease would result in a higher circulating concentration of cardiac troponin T compared to cardiac troponin I. Whereas in acute cardiac disease, we expected to see a higher level of cardiac troponin I compared to cardiac troponin T. We calculated the cardiac troponin I to cardiac troponin T ratio to put the two troponin values into relation. This was a pooled analysis of 3 large studies, including more than 8,700 patients. The first study was the APACE study that you all know by now. It's a prospective international multicenter study recruiting patients presenting to the emergency department with chest pain. There was the Basel 8 study, which is a prospective diagnostic single center study recruiting consecutive patients referred for cardiac stress testing to the University Hospital Basel. And also there was the Maastricht study, which is a prospective population-based cohort study. And we used a portion of this study, including only healthy patients. Now, very importantly, for all those 3 studies, there was a very detailed patient characterization, and every patient in these studies had a final adjudicated diagnosis of the presenting disorder. We used high sensitivity cardiac troponin assays for this analysis. So for cardiac troponin I, we used the Architect assay by Abbott, and for cardiac troponin T, we used the ELIXIS assay by Roche. Patients with missing cardiac troponin values or values below the LOD of the respective assay were excluded from the analysis. And I would like to go to the results and like to invite you to listen very carefully, because you might be surprised about what you're going to see. Now, this really is a central part of our study or our analysis. So I'm going to explain to you carefully what you're seeing. So on the x-axis, you have the subgroups of patients that were derived from the adjudicated diagnoses of all the 3 included studies. And on the very top, you can see that these groups were further grouped into superordinate groups, which are so healthy patients, no cardiovascular disease. We have chronic cardiac disease and we have acute cardiac disease. On the y-axis, you have the CTNI to CTNT ratio on a log scale. You have the purple dots, which represent the measured troponin medians of cardiac troponin T, and in green for cardiac troponin I. You can see that on the very left-hand side, in the group with no cardiovascular disease, so in healthy patients, they were the patients with the lowest cardiac troponin I to cardiac troponin T ratio. The ratio then slowly rises across the chronic cardiac disease group, and then there's a huge jump towards the acute cardiac disease group, which includes adjudicated diagnoses like NSTEMI, STEMI, and myocarditis. I made a last-minute change to my presentation. First, you can also see, the very bottom, the renal function was very similar between the chronic cardiac disease group and the acute cardiac disease group. So any differences in cardiac troponin I to T ratio that we see between the 2 groups cannot be referred back to renal function. I think that's very important after the last talk. Now, the last minute change I added after yesterday's discussion, and to preempt the question from Professor Mills, there's some data about type 1 and type 2 NSTEMI. So on the very left-hand side, you can see the troponin values at presentation for type 1 NSTEMI, which is the darker red, and the lighter red, the type 2 NSTEMIs. And you can see that also, like in the beginning and across the serial sampling up to 3 hours, the cardiac troponin ratio is higher in patients with type 1 NSTEMI compared to type 2 NSTEMI, and also that the cardiac troponin ratio of the type 2 NSTEMI is more similar to the ratio of chronic cardiac disease compared to the type 1. Now, if I had to put the graph that you saw into words, I would say that we showed that normal aging has the lowest CTNI to CTNT ratio, based on a disproportional increase in cardiac troponin T compared to cardiac troponin I. Acute cardiac disease has the highest CTNI to CTNT ratio, resulting from a disproportional increase in CTNI compared to CTNT. And the chronic cardiac disease group is somewhere in the middle, with relatively more CTNI compared to normal aging, but less compared to acute cardiac disease. This brings me to the conclusion that there might be relevant differences in the release of cardiac troponin I and cardiac troponin T, depending on the underlying mechanism and acuteness of injury. And this also has potential clinical implications, because in fact, there might be distinctive clinical best use settings for cardiac troponin I and cardiac troponin T, meaning that one might be preferable over the other in certain clinical situations. This study, as any other, has some limitations. For example, there's always the risk of misclassifying a small number of patients regarding adjudicated diagnoses or healthy patients. This was an exploratory analysis and a pooled analysis of 3 large studies. So we performed no specific sample size calculation. And also, as with all of these studies, we excluded patients with terminal kidney failure. So we cannot say anything about the troponin I to T ratio in patients on dialysis. I would like to thank my 2 colleagues, Dr. Johan Walter and Dr. Luca Köchlin, who worked with me on this project. I would also like to thank Stephen Meeks and everyone from the Maastricht trial who supplied their data of healthy patients to even further support our study. And I would also like to thank everyone from the CRIP. And last but not least, I would like to thank our great presidents who enable us to have this fantastic meeting year after year and be here and share our interesting research and results with each other. Of course, also Nick, who's not on the picture, and everyone else who's involved in presenting the great meeting. I would like to dedicate this applause to them. Thank you.
I'm glad you've seen the light, and have presented a very interesting paper. You've stolen my question, so I have to come up with another one. So you're challenging us that troponin I and troponin T, these findings might be something to do with differences in release in these different settings. I want to challenge you and say that it's more to do with the way we detect these proteins than it is to do with the release.
Thank you very much for this question. I think it's very interesting that with cardiac troponin I and T, there's always this discussion about like, is there differences in detection and what's with release and reuptake and everything. While I cannot comment specifically on if the detection methods might be so different as to explaining these findings,
yeah, maybe I'll elaborate. So they aren't calibrated.
We also have some questions from the floor.
We have loads of questions to roll.
Yeah.
Okay.
Yeah.
Or maybe we don't.
Yeah, go ahead, please.
Have we a question?
A little in the same way, but in different. Do you think that there is difference in the intracellular organization according to TNT and TNI? So to my knowledge, it's one TNI for one TNT in the cell. So how do you explain that?
Yes.
Based on the intracellular organization.
Thank you very much. This is a very basic science question, and we looked at the cardiac troponin T and I molecular weight and about how they're being detected, and we did some calculations where we found a certain proportion that that the method of how the troponins are detected leads to a certain proportion, and I don't recall the exact numbers, but like you would detect one troponin T molecule for every 2 troponin I molecules. But this is something that we just had a provisionary look at, and I cannot give any conclusive answer to this question.
One more quick one.
Fantastic talk. It was excellent. I had a quick question on the acute side of the graphic. You had patients with acute cardiac disease without coronary artery disease seem to favor troponin T more. Can I ask, first of all, what are the diagnoses in this patient and why do you think that's the case with troponin T?
Yes, thank you very much. Very good observation. So this group was a group that included, for example, patients with sepsis and patients with cardiac arrhythmia who had a raised or elevated level of cardiac troponin, but the serial measurement did not reach significance, or it did not for the respective assay reach the defined threshold levels to be classified as type 2 NSTEMI, for example. So that's how we interpreted this. This is why it's also marked with a little symbol. And because I think this group, we predefined those groups before knowing the ratio, and we thought that this is definitely acute cardiac disease, but we were not or unsure what to expect. And then we saw that it's actually, as you said, more similar to chronic cardiac disease than to acute cardiac disease. But this is probably, again, due to the nature of the injury, as in sepsis or arrhythmia.
Fabulous. Thank you very much for a very stimulating presentation, Tobias. So we're going to move on in the interest of time. Thank you. So Noemi is going to speak next, and she's going to answer the question of whether statins protect against PMI, which I assume is perioperative myocardial injury. Is that right? Yeah. Okay. Thanks.
Thank you. So, dear Professor De Boer and Professor Mills, dear colleagues, thank you very much for the opportunity to be here. And I'm going to talk today about the guidelines adherence to statin therapy and association with major adverse cardiac events and perioperative myocardial injury. As you probably all know, and you can see here on the picture on the right, statins inhibit the HMG coenzyme A reductase and thereby reduce the synthesis of cholesterol in the liver. This leads to an increased expression of LDL receptors on hepatocytes, and LDL uptake from blood is increased and plasma levels is decreased. Statins are widely used for the prevention and of coronary artery disease and associated secondary cardiovascular complications. Now, despite established evidence in acute and chronic
cardiovascular disease, the optimal perioperative use of statins still remains uncertain. And current ESC guidelines, as you can see here on the left on non-cardiac surgery, limit their recommendation to the continuation of an already established statin therapy and to a possible initiation of statin therapy in patients undergoing vascular surgery. Data from pilot studies showed potential beneficial effects of statins on postoperative cardiovascular outcomes. So now, considering the high annual volume of surgery and the high incidence of cardiovascular events after non-cardiac surgery, potential beneficial effect of statins could translate into big improvements in perioperative care and population morbidity. Therefore, with this study, we aim to evaluate the current use of statins in patients undergoing non-cardiac surgery and to evaluate the association of statin intake with the occurrence of cardiac complications after non-cardiac surgery. We included consecutive patients undergoing non-cardiac surgery at the University Hospital in Basel and the Cantonal Hospital Aarau in Switzerland that received surveillance for major cardiac complications and cardiac PMI. Indications for statin use were derived from clinical practice guidelines by the European Society of Cardiology, and we chose to only include class 1 recommendations for this analysis. We defined MACE as a composite of cardiovascular death and spontaneous myocardial infarction within 120 days after surgery. And as our secondary endpoint, we defined PMI due to cardiac causes such as type 1 MI, tachyarrhythmia, acute heart failure, or type 2 MI within 3 days after surgery. For the prognosis analysis of this study, we used inverse probability of treatment weighting to account for differences in measured baseline covariates between statin and non-statin users. This is a propensity score-based method and to reduce the effect of confounding when using observational data to estimate treatment effects. We then performed univariable Cox hazard model with MACE and univariable logistic regression model with cardiac PMI as endpoints. Between 2014 and 2018, we included 8,116 patients for this analysis, of which 4,227 had a class 1 indication for statin therapy. Here on the right, you can see an excerpt of table 1 with only the patient that had a class 1 indication for statin therapy, and they are stratified by their actual statin intake. On the left, you can see patients not taking statins, and on the right, patients that received statin therapy. And you can see that those patients receiving statin therapy were in general a little bit younger and much less frequently female, with only about 30% of female patients receiving appropriate statin therapy. Furthermore, they had more cardiovascular comorbidities, and they were taking more preoperative medication targeting cardiovascular diseases. From the patients that had any class 1 indication for statin therapy, only about 58% received statins preoperatively. As you can see here on the graph, the more indications for statin therapy that were present, the more often patients received statin therapy. Usage was highest in patients with CAD and prior MI, and usage was lowest in patients with chronic kidney disease stage 3 to 5. Now, during our follow-up of 120 days, 161 MACE occurred, and here we can see a cumulative event curve of the composite MACE endpoint. And as you can see, the patients not receiving statin therapy, here in red, despite an indication for statin therapy, reached the endpoint more often than patients receiving statin therapy, here in green. And this resulted in a weighted hazard ratio of 0.66. Furthermore, 562 cardiac PMIs occurred, and despite waiting, patients receiving statin therapy had more cardiac PMI than patients not receiving statin therapy. Albeit
resulting in a weighted odds ratio of 1.12, albeit not significant. And this surprising result might be explained by residual confounding and for sure needs further research. Some limitations need to be considered. We cannot comment on statin indication from primary prevention due to elevated LDL levels. Furthermore, information on the duration of statin intake prior to surgery and the adherence to statin therapy after surgery was not assessed. And this is data from an observational cohort study. So let me summarize the last few minutes. Guideline adherence to class 1 recommended statin therapy was low in our cohort, and it was highest for patients with coronary artery disease and prior MI, and lowest for patients with chronic kidney disease stage 3 to 5. We saw that patients with class 1 indication for statin therapy and receiving statins had less MACE within 120 days, but more cardiac PMI than patients not receiving statin therapy. So we suggest that the need to undergo non-cardiac surgery could provide an optimal checkpoint to screen for appropriate statin therapy in patients. Thank you for your attention.
So, very nice presentation.
Yes, great presentation. I really enjoyed that. Really, of course, coming up on this conclusion that there is an increase in number of myocardial infarction in patients taking statin. Do you think that should possible in this chronic patient take a stand to monitoring some biomarkers? Of course, I'm thinking about high-sensitive troponin as a target that can reverse. So we know that some patients with coronary artery disease, they can have some small increase in circulating high-sensitive troponin. If you add this in the future, should you revert this trend in order to targeting better the treatment of statins on high-sensitive troponin? I know that was not your target, but what do you think about this?
Sorry, can you elaborate more? I didn't understand the question.
So we know that in patients with chronic coronary disease, or like you said, we have a little small increase in high-sensitive troponin that you did analyze in this study. And you found that in these patients, there was nevertheless of using statin, an increase in PMI, right? My question is, should we be targeting high-sensitive troponin as effect positive of statin? If you have not this effect, you should increase statin, and the target will be high-sensitive troponin to prevent myocardial infarction.
I don't.
I think one of the issues that is being raised is reverse causality. So the fact that the group on statins are more likely to have perioperative myocardial injury might just be that they're the highest risk because they've got pre-existing coronary disease and raised troponins as a consequence of that. Do you think that's possible?
For sure, the patients that have PMI, they are usually more sick patients, but actually we adjusted for these comorbidities with the inverse probability of treatment weighting. So I don't really know, maybe there are some other factors that we did not consider yet that play a role in why they had more PMI despite getting statins.
And just a follow-up question about the quality of surgical care in Switzerland. But what's going on here? Why are only 70% of people with known coronary disease on a statin prior to surgery? And I wonder if you could dig into it by looking at the type of operation. Maybe some of your surgeons are more likely to, document or prescribe or make sure patients are on appropriate preventative treatment.
That's a good question. So I don't think we can only look at the surgeons here, because I think there's probably many players that play a role in patients getting statins, or then maybe also I think that patients that probably had an event very long time ago, they probably have less statins, and we actually want to look at this, but we didn't have time yet to look at this. Yeah.
So we shouldn't start statins pre-op just yet, but it's interesting data. Thank you very much. We should, in the interest of time, move on.
Very good. Thank you again. Then we continue with Kaelan Taggart from Scotland, talking about risk score for type 2 myocardial infarction.
Hello, hi, my name is Keelan Taggart. I'm one of the research fellows working with Professor Mill's team in Edinburgh. And my talk is on risk scores in type 2 myocardial infarction. So my declarations are there. And so just a bit of background to start on risk prediction in non-ST elevation ACS. As we know, there's loads of risk scores out there: GRACE, HEART, TIMI, PURSUIT, to name a few. These have all been widely utilized and performed, derived from large trial and registry cohorts. And they're recommended for use by national and international guidelines, such as the ESC and in the UK, NICE. However, I would say that these scores are developed out with or predate the era of high sensitivity troponin and are largely for patients with type 1 myocardial infarction. Now, over the last couple of days, we've had some great talks on type 2 myocardial infarction, some great research is coming to light. We know these patients, it's common that they're in increased risk of cardiovascular events, but we have to keep into consideration that they're a very heterogeneous bunch that require sometimes complex management to think about. But our aim was to derive and validate a risk prediction tool for patients with type 2 myocardial infarction. So the way we went around that is we had our derivation cohort of the high stakes trial, which you've heard a lot about over the last day. This was a trial of 48,000 patients in Scotland who turned up to A&E as suspected ACS, with a fully adjudicated diagnosis of this cohort of 1,121 patients by 2 cardiologists independently and a third if there was disagreement. And we decided to go for a primary outcome of myocardial infarction or cardiovascular death at 1 year, and a secondary, more exploratory option of myocardial infarction or all-cause death at 1 year, because as we know, these patients are increased levels of frailty and things, and it would be interesting to see their overall level of non-cardiovascular death. So we began by doing Cox regression modeling to derive our score. This gave us a linear predictor of our patients, which we then plotted. We then took the expedient of this and multiplied it by the mean survival, subtracted all that from 1 to give us a whole risk of scores between 0 and 1 for each patient. And then what we did was took the median of that risk and took the lower quartile as low risk and the upper quartile as high risk, and everything else in the middle as intermediate groups. So we ended up with 3 groups: low risk, intermediate risk, and high risk. And then we externally validated our model in a Swedish population of 22,589 patients presenting to A&E with chest pain, of which 250 received, again, a doubly adjudicated diagnosis by 2 cardiologists of type 2 myocardial infarction. So this is the variables that we decided to go for. We went for these a priori based on clinical importance, and we feel that these are a good set of variables, as they are common physiological parameters that say how unwell a patient is. They also give good prognostication, such things like troponin and age of how things are going to end up, but also modifiable risk factors, etc., or factors that can be optimized certainly for cardiovascular disease as well. We chose 9 as do not overfit our model. And as you see, if we can compare the 2 populations, they're pretty similar, with slightly more heart failure hospitalization and ischemic heart disease in the Scottish cohort, but otherwise pretty similar. So this is a cumulative incidence plot adjusted for non-cardiovascular death for our primary outcome of MI or cardiovascular death at 1 year. Sorry, of non-cardiovascular death it was adjusted for. And this illustrates the low and intermediate and high risk. And as you can see, after a year, the high risk patients is up to 30%, which kind of gives a cohort if you're in clinic, etc., if you felt this could be used to target and optimize therapies. We also done a cumulative incidence plot. It's not adjusted because it's for all death of MI or all-cause death at 1 year. And you see the high risk here at a year, it can go right up to 50%, so a coin toss really. And I think that's a kind of take-home message of how unwell and how bad the outcomes are in patients with type 2 MI, which I think is really the kind of take-home message of this whole thing, so that we can do some more. We've our models had good discrimination for MI or CV death at 1 year with an AUC of 0.75 and also an AUC of 0.75 for MI or all-cause death, albeit tighter confidence intervals, which we think was driven by a lot more non-cardiovascular events. We validated this in the Swedish cohort, and which showed equivalently good discrimination with an AUC of 0.6 and AUC of 0.81 for all-cause or MI. We performed calibration plots. These are plots that have been done looking at where they bootstrap the sample over time. And us to plot a smooth curve as unlike Kaplan-Meier, which grips the risk. And as you can see, the observed value and the predicted value are pretty similar, and the line crosses as well. So I think the conclusions really is we feel that our stratification tool provides good discrimination for cardiovascular death or MI at 1 year. And our further directions is we would hope that further modeling in this area and populations of type 2 would allow us to target more specifically cardiovascular disease in this cohort, optimize therapy, and overall improve outcomes. And just that, my acknowledgements, and I'd like to thank my team, our colleagues in Sweden, and the people in the Human Genetics Center who helped us with our modeling. Thank you.
Thank you very much. Christian has a question.
So congratulations to your important work on type 2 MI. I have a question on how can you, or could you speculate on the challenges on how to define type 2 MI? Because your cohort was twice as large as the ones from Martin. However, had more than four times the number of type 2 MI, although you both presented patients with suspected ACS. And I'm a bit concerned that you have included heart failure patients, which should be left out, because heart failure is a different cause of, let's say, injury, and usually should not be included in type 2. Could you please comment on this?
Yeah, I suppose when we were comparing our initial populations, yes, it was 2% overall the population was high stakes, and 1% received a diagnosis of type 2 MI. However, the Swedish population was also younger by a significant amount when we took back to the right back to the base, nearly 5 or 6 years. So we do feel that a lot of that discrepancy in diagnosis was due to that. Regarding the adjudication process, the Swedish adjudication process was the same as ours. They had a discussion panel instead of a third cardiologist for independently excluded at the end. But we'd be quite confident that that data set would be reliable and that the type 2 MI is truly type 2 and not heart failure.
Can I ask you, so you created these models for type 2 myocardial infarction, then you validated them in the Swedish cohort, you calibrated them. What if you use your models and let's say apply them to type 1 myocardial infarction or acute heart failure? Do the models perform reasonably well then as well? I mean, how specific is it to type 2?
Yeah, I was playing around. I done it for type 1 myocardial infarction, and they did predict very well. Slightly better actually than the type 2, and I think the reason for it is because it's such a heterogeneous population, and I don't think no matter how many variables you get, you'll always get a curveball with a patient with type 2 that may or may not have a further event, and I think that's something that we have to kind of put on barn door, know that these are really complicated patients, and you're always going to end up with some discrepancy of that.
Yeah. See 2 questions in the back, one over there, and then we probably have to move on. So,
Fantastic talk and very interesting findings. Yes, maybe I haven't seen it, but which variables did you include in your risk score? Was this baseline characteristic, those were the variables in it, first of all? Second, did you give different points? So just to say, if I wanted to use your score tomorrow, how should I use it? Thank you.
So I broke it into risk scores because I thought it might have been more of a better message for clinicians. But if you wanted to use the model, there is a function that we have in our programming where you can put in the variables, and then that'll apply a set of betas and give you an overall risk at 1 year by informing a nomogram. And then from that nomogram, then you'd be able to plug in which risk group the patient is.
So from your question, I guess, I mean, the variables that you used, continuous variables and so on, how did you model them? Because if you need to use a normogram, it's usually because you model them kind of difficulty to use it. You need a calculator, right?
Yeah, exactly. Yeah. So you would make a risk, you'd have to make a tool. We would try and do that by overlaying a Shiny app over the models, and then the betas, and it would do it all for you, and it would give you your score. But in terms of how we use the models, we did use things like cubic splines, but we tried not over deskeratize and kept continuous models as continuous as they could be, just based on good statistical practice. So we try our best for that.
Thank you.
Also, given the time, I propose we move on, because otherwise the General Assembly has to be cancelled. And I don't dare to do so. So thanks again. Final speaker is Doreen Kimenai, again from Scotland, on trajectories of troponin prior to death.
Hello, everyone. It's really, really nice to have a live meeting. I really enjoyed it so far. I think I really would like to start with a huge thank you to the organizers, particularly also to Valeria. I think she has done a huge, great job so far. Well, I'm delighted that I can present my work, Trajectories of Troponin Prior to Death today. It's great that I have an audience that loves cardiac troponin, and I don't have to explain you that we use it now for the diagnosis of myocardial infarction. It is true that with the development of the high sensitivity assays that we have reached a new area, and it's really nice that cardiac troponin measurements in the lower range are now more accurately. And that has the result that it might also be useful to use it for other purposes than a diagnosis of myocardial infarction. And that is in the primary prevention setting. I think the big question now is that it is recently well established that cardiac troponin is being associated with cardiovascular events in the general population, but we struggle how we should add it to current cardiovascular risk scores and how we should use it. And I think a really important thing here is that we should get knowledge on the trajectories of cardiac troponin prior to cardiovascular events, so that would help us to inform us how we should use cardiac troponin in clinical practice. So in our study, we evaluated the trajectories of cardiac troponin in those who died from cardiovascular disease and compared the trajectories to those who survived due to non-cardiovascular causes or who survived or died from non-cardiovascular causes. And secondarily, we have evaluated the serial high sensitivity testing in relation to cardiovascular death. And that is also that I would like to propose a dynamic risk model. What did we do? We used the general population cohort study, and we used data from the Whitehall 2 study. It's a longitudinal cohort study, and we had more than over 20 years of follow-up. In those individuals, we had in most patients 3 troponin measurements available, and we considered the first troponin measurements as baseline. And these troponin measurements were measures over 15 years time periods. So in total, we included 7,293 individuals. And we looked primarily at cardiovascular death as outcome. What we first have done is we constructed the average cardiac troponin trajectories for our primary outcome events. And secondarily, we have explored how we can use serial cardiac troponin testing for cardiovascular risk estimation. We have done that by the use of a joint model, which is basically a combination of a linear mixed effect model and a Cox regression model, and it relates the individual trajectories to the event. In the model, we accounted for competing risk, and we also adjusted for known cardiovascular risk factors. In total, we included 7,293 individuals, and we had, at the end of the follow-up of more than 20 years, we had 280 individuals who died due to cardiovascular causes. What you see is that those who were getting an event, that those were older, had also a higher risk profile, were more likely to have diabetes, and also for medication therapy, they were more prescribed for that. So what you see here is the cardiac troponin trajectories. And for those who are maybe not so familiar with those plots, what you see on the x-axis is the time, and on the right you see the 0. So that is either the end of follow-up or when the individual had the event. And then basically you go back in time, you go to the left till the 20 years before the event. And on the y-axis you do see the cardiac troponin concentration. And the red line is the average trajectory of the individuals who were getting the events. And what you do see is that we can clearly distinguish those individuals from those who died due to non-cardiovascular causes or who survived. We did the same for all-cause death, and what we then observed is a huge overlap. It's also really showing us that cardiac troponin is very cardiac specific. And the next step is that we wanted to go further than only looking at the trajectory. So what we did is we modeled the temporal changes in cardiac troponin in relation to cardiovascular death. And the way how you should look at those models is that there are a couple of parameters that are really important for the interpretation. That is the level, so that the trajectory at any point in time tells us something about the hazard ratio and what the concentration is telling us in terms of prognostic information. Another one is a slope that is a little bit more in the rate of change over time, what it is expressing. And you have the area which is telling us the cumulative effect of cardiac troponin in relation to cardiovascular death. So what we see in those models is that unadjustedly, we really see that cardiac troponin is strongly associated with cardiovascular disease when we are using serial testing. We do see that our data suggests that the slope seems to be less relevant, but even in our adjusted models using other factors we have used, the framing and risk factors, we do observe that cardiac troponin serial testing is really a strong independent risk predictor for cardiovascular disease. So to give you a little bit an idea of how these dynamic risk models can work, because I think showing hazard ratios maybe not so relevant, is that when, for example, when you have a 65-year-old female and her first troponin level is 3 nanograms per liter, her survival probability is 87%. If this woman would be followed up for serial troponin testing and she would have a stable troponin level, then you would see that her survival probability would also remain the same. In her situation, her troponin level increased over time, and this model is really taking advantage of that. It not only takes the first measurements of the second measure, it takes the entire trajectory and also the change over time. And with this information, we showed that her survival probability decreased to with more than 10%. And I think that is also the advantage that this kind of modeling can have over the currently static risk models. And I do think that troponin might be a really useful biomarker for this kind of modeling. So in conclusion, our study shows that cardiac troponin levels increase in those dying from a cardiovascular disease compared to those who survived from other causes over the preceding decades. We showed also with this study that serial cardiac troponin testing is strongly associated with cardiovascular death, and that the joint model principle might be a really elegant technique to dynamically track risk within individuals over time. So thank you very much. And I would like to end also particularly with thanking my collaborators of this study. Thank you.
Thank you. There's a question.
Thank you for the very interesting presentation. I'm sorry, but I have to ask if you still have blood of these patients, because that would be interesting to compare this with troponin T, because there's this hypothesis that troponin T may be related to all-cause mortality and troponin I may be more related to cardiac mortality. So that's just a few.
I'm not sure, because I'm not part of the management team of the VITAL study in itself, but it's definitely worthwhile to ask whether there's serum sample available. And I completely agree that it would be really interesting to also to evaluate the trajectories of cardiac troponin T. Yeah, because we do know that we do observe differences, that troponin T seems to be more strongly associated with all-cause death. And for troponin I and cardiovascular death, it's the other way around. Yeah.
If I interpreted your curves correctly, then the association seemed similar for cardiovascular death and all-cause mortality. So I'm a bit concerned from a clinical perspective that we might not really be able to adjudicate the cause of death appropriately in so many patients. We had so many good presentations on severe sepsis in the ICU. Those patients that die ultimately of cardiovascular causes because the cardiovascular system is not able to achieve survival. And still the patient in most previous cohorts would have been classified as non-cardiovascular. So could you comment on how the adjudication was done for cardiovascular, just to make sure that you are sure that cardiovascular death is the right endpoint for troponin to be predictive of?
Yeah, that's a really good question. And the way how we achieved the endpoints is that we use the NHS registry. So the outcome data is based on the ICD-10 and ICD-9 coding. So it's not adjudicated outcomes that we have used. So I do think that what we have now observed is that still with the data using the clinical outcome data that we can distinguish the cardiovascular deaths in the general population. But I'm not a clinician, so I do find it difficult yeah, it's also from your clinical perspective that you probably have better knowledge in that you can identify those who are died to cardiovascular reasons or not. But the data shows that we could distinguish the cardiovascular deaths from the all-cause death. Yeah.
Doreen, thank you very much. Because we've almost missed the entire great assembly, we're going to draw the session to a close, but thank you for that super presentation, and thanks to all the speakers. Really fabulous session. Now, Christian, are you going to come up here? I think
So I welcome you to the General Assembly. Don't worry, this will be short, so we will likely be able to get back on time. The General Assembly is mandatory for every of our annual meetings, as we are an association, and we as the leadership have to report back to you as the members of the great network, and the great members deserve this report from us. So I very much hope that all of you are members. For those of you who might not have registered, please report to Valeria so that Valeria can send you the form. It's a simple form to sign. We are a non-profit association. There's no kind of financial or any other obligation that you have, but you are entitled again to get the information related to the meeting. And of course, as such, we need to report to you. Ultimately, we have kind of 2 points to report. One is always on the finances, and this will be covered by Salvatore right now. And the second point, again, it's the future, and the most attractive, or one attractive aspect of the future is to consider where we have the next meeting, so the meeting next year. But before discussing the meeting next year, we need to ask Salvatore, how about our financial situation? Will there be a future and money for a next meeting?
Thank you. Yes, Christian, this is of course an important question we have to address. First of all, let me tell you that we have quite good news. I mean, at the end of the day, we start for a good balance at the end of September. This was 2020, not 2020, or 2021, right? Yes, just 1 month ago. So this is because also we received some money from the sponsors that we, compared to the past, we had a little bit more expense this year because we decided to really to give you more time to be hosted for us. And I think it's been a good decision. To be honest, I was a little bit conservative, but Christian was pushing to have this. And I think this is also a good idea to spend all the money in transparency, right? Only for the meeting. And at the end of the day, we have still some positive balance in our, in our pocket. And we are still waiting for some incomes coming from the sponsor. I would like to get the opportunity, Christian, to say very big thank you to the sponsors that I really would like to one by one address. Thank you, Roche, Orthoclinical Diagnostics, Siemens, Adrenomed, MCheck, and I think I just, and there is another one, probably, yes, the Konica Minolta, that I have to say a special thanks because Saito gave to us last year already money for this year. And I think this is really a good balance because of the support of the sponsor that we are using. And we hope that also we have, this was means, Christian, that we have time and the money for organize next year meeting. So you can go forward to announce that we will have the meeting next year.
Okay. Are there questions from one of the members relating to the financial report provided by Salvatore? If not, again, our association is devoted to you, the young members, and to you as research fellows working on the projects. And we want to make sure that our program holistically, not only the scientific content, but also the fun and the sightseeing aspect of meetings is as attractive as possible. So therefore, I wish to get your suggestions within the next couple of days regarding the place where to have the meeting next year. To give you some ideas of what's, it should be a nice city, of course, that we all love to visit. It should be a city that is easy to travel to. So travel logistics are important because all the research groups, of course, all of you, all of us, we have to pay our travel ourselves. So it should be convenient and if possible, inexpensive to travel to the city for most of the attendees. And again, ideally, it should be a city where we have a strong local host, or someone who has been involved with GREAT, does active research, has a research group, and therefore would be a strong person to support kind of us as in the conduct, in the preparation of the meeting. So think about this. We have been to fantastic cities over the last 13, 14 years. We might go back to one of the cities where we've been, but perhaps you might identify a place or that you think is great. So think about it and email me your suggestion. I already now would try to highlight one suggestion that has been made to me. It's a good option, but perhaps you might have an even better one. And one suggestion was to have the meeting next year in Vienna. The reason is Vienna is a fantastic city, enormous attractiveness for cultural aspects. It's easy to travel to, a safe city, and we have representations with the group of Kurt Huber, who has attended the GREAT meeting himself in a couple of last years, and his team members have participated this year. So it's an option, something to consider, that we consider, but again, there's enough time for you to provide your suggestion for alternative options. You have comments or question regarding the options for the meeting next year? Please, Luna.
Sorry, oh gosh, sorry, that woke you all up, didn't it? It was just briefly to say that obviously we're going to have to take into account what the COVID restrictions are. So I actually looked at going to Vienna on holidays, and at the moment you cannot go to Vienna unless you had your immunisation after March of this year, because they're worried about waning immunity. And as someone who was, as a doctor who was vaccinated early, this meant that I had done the right thing, but I couldn't actually go there on holidays. So that will be something that will need to be taken into account.
Very important point, but you know me, I'm very optimistic. Next year, COVID.
You won't be
We will hopefully not necessarily need to care about COVID next year, but we will keep this in the loop. Other comments or suggestions?
Yeah, maybe we should also think on a city where the temperature is high. Well, Oman, I think, is difficult.
but you, I mean, you should have. I mean, we had an outstanding presentation, so the risk was associated with the high temperature. So our desire. I mean, but you're right. Of course, likely again, the same is for the month. For the likely, we stick to October. October is a good month, and realistically, I mean, there are a few cities that can compete with Rome. It's impossible to compete with Salvatore as the host. That's clear. But somehow we need to come up with a good suggestion for next year.
Taormina is in Rome.
Almost province.
I knew it.
I just asking you why we don't go to June or at the beginning of the summer, and not in October, because
very good point. Again, it's open and we can consider it again. We had several meetings in June, so June I think is also a perfect month for meetings. The conflict is in national meetings are in June, so that is the only argument against June. But of course, June is fantastic also, and again. That's something to consider. I think both mid of June as well as mid of October, both, and yeah. But I mean, and ultimately regarding the cities, I mean, that most cities that are nice in June are also nice in October.
Anyway, if we will make October, we are a little bit far away from COVID. This will be one reason, although I hope that this will finish January, this January.
Then again, any other general questions that you have that we should report to you?
Yeah. Maybe Christian, just because usually some people remember that we have a voting on budget, but maybe we should remind them the voting is every other.
Exactly. So the next voting for the president-elect, and that system has to be next year. So that's the reason. So this year there's no voting. We just need to report on the finances. Okay, then thank you very much. And then I think we are nearly back in time again, and we close the General Assembly. And hopefully now, if everything works nicely with technology, we should be able to see and listen to Mucio, who is in a very different area of the world right now, who of course would have enjoyed to be with.
Is it a video or is it online?
Hello, are you seeing us?
We try to check whether it's live or recorded.
Perfect, Mucio. We can hear you well and we can see you well. Fantastic.
Thank you. Thank you very much. Thank you very much. We have here
Alessandro.
So nice to see you, Alex. So nice to see you, Christian. So nice to see you, Salvatore. We are here. Everybody that is here have been once at the great. You can see Bruno. You can see Alexandre, Priscilla, and it's. I'd like to thank you very much for you to giving us the opportunity to appear here and say how sad we are not to being there this year. We try to connect, but the border policy, the border of officers said that Salvatore did not allow a Brazilian to go to Rome. So
I have to work on this.
He was scared for the soccer game.
And everybody that is here, I think you can see, we are all the researchers at Heart Institute. And I'd like to introduce you, Pedro Barros, who is there. He's the leader of cardiology in a network of hospitals in Brazil with a lot of database that we can work in heart failure and chest pain. And also Alexandre is working with emergency, as you know. And I'm missing Bruno here, who works with perioperative, is already working with you. Mariana, by my side here, is a fellow that will work together. And I really, really appreciate the time you did, the time you gave for us. So if anybody want to say something, say hello, please, this is the time.
Yeah, I just, from my side, I just want to give a special kiss and greetings to Daniele Gualandro, that she must be there. And from my side, and this I will say in Italian, un bacione a Roma da parte mia.
Grazie.
Very good. And well, we will still have 30 minutes, right?
Each of you.
Very good, very good. So again, Alex, Salvatore, and Christian, I'd like to say that we'll be back. So hasta la vista, baby.
William Shatner is joining our team from Star Trek.
Okay, so thank you very much, Mucio and the whole team. Greetings to Sao Paulo. So thank you very much. So this was nice to be in contact with Mucio. And Mucio, again, please also send me your suggestion for the place next year. So which one would be more open to have nice guests from Sao Paulo? Hopefully this no burden with COVID. Okay, so this allows us to hand over perfectly in time to Salvatore and Josep as the chairs of the last session.
Thank you, Chris. Yes, we are very happy that we are in time, so that we can really be able to take the bus at 5 o'clock to go to the Vatican Museum, where I can introduce my, co-worker, the Pope, that is waiting for you. So anyway, so I would like, I have the pleasure to introduce a friend, but also a world recognized expert in emergency medicine, that is Professor Frank Peacock. And he's going to give a talk, interesting talk on the potassium binders. Please, Frank.
So thank you, and thanks for having me. It is so nice, like everybody said, to have a real meeting with real people instead of these Zoom calls, which I am so fed up with. So I'm going to be talking about potassium binders. And the reason is we have a bunch of new ones, and I don't know how much global penetration they have, but we've been using them quite a bit in the United States. So this is a patient, you've all seen this guy before. He comes into my ER like every 3 or 4 hours. I get a new hyperkalemia patient, and the reason is that we're on the border of the United States, and if you're there, anybody who is south of us who doesn't have insurance is going to die because they do not provide systemic dialysis. So I get these people. I've done as many as 30 dialysis treatment in a day. So it's a little bit crazy. And they seem to come in the morning, and it's always 1 in the morning. And 36-year-old man comes in and he feels bad, and he is supposed to be getting dialyzed because his kidneys are dead, and he hadn't been dialyzed in a week. And so you know what that spells. And so the first thing you looked at is he's volume overloaded, and he's not. He's got no JVD, his lungs are clear, doesn't have any S3, his SATs are okay. And then I do an EKG. And if you see this EKG, you should sweat, because this guy's going to die probably in the next 20 minutes. And so I got to do something really quick. And we have point of care, iStat is what we use. And I get the potassium at 6.6. And you have to decide, is this pseudo hyperkalemia? Is it spurious because we did lysis, or is this the real deal? That EKG says it's the real deal. The sensitivity and specificity of the EKG is not great. When it is abnormal like this with wide QRS and all, the specificity is really quite good. But when it's normal, the sensitivity is garbage. It's probably 50%. So helpful when positive and useless when negative. This is a study that Adam Singer and I published a couple of years ago. We looked at 100,000 emergency department visits and stratified them by potassium level. And it looks like every curve you've ever seen of hyperkalemia and hypokalemia, there is a sweet spot from 3.5 to 5. And then it goes up, and the higher it gets, the sooner you're more likely to die. And you can see my guy was 6.6. So that puts him up around the 20% going to die. 1 out of 5 chance is not going to make it out of the ER today. And if you're low, that's the other part here, 3.5 or lower, your mortality goes up. So low potassium needs to get fixed. Not as critical as hyperkalemia, but still a problem. And the other point is, if it's above 5, it's got a mortality associated with it. Not as high, but once they get past 6, it starts to get ugly. It starts to look like a myocardial infarction in terms of speed to death. So it's 1:30 in the morning. And what am I going to do? What I'd really like to do is dialyze this guy, because it's the one definitive thing I can remove the potassium. And that's not going to happen because it's 1 in the morning. So I got to come up with a better idea, and I have to buy time, because my nephrologist will be there with an open slot, probably about 7 or 8 in the morning, but I've got to keep the guy alive. And so these are all the things you can do to buy time. And all they do is shift the potassium into the cell for some time, except the last 2, loop diuretics and binding resins. And I'll go through the numbers on these. Calcium, it works great. It doesn't change potassium at all. It stabilizes the myocardial membrane. And it's a beautiful drug, because you give it and the EKG will become normal in front of you. And I love it. It's one of my favorite drugs. And it does absolutely nothing if you don't have EKG changes, except gives risk to the patient, because renal failure patients with high phosphate, you give them calcium, they can precipitate into bad places like their cornea or maybe their AV node. So don't give it unless it's going to help. So no EKG changes, don't give it. EKG changes, absolutely. Works immediately within a minute or 2 and lasts a half an hour. So it buys me 30 minutes. That's all I get. But 30 minutes is a long time. I fix this guy for 30 minutes. I can do something else that buys me more time. Glucose and insulin. This is great. You give them glucose, it will, and insulin will shove the glucose into the cell. It will take potassium with it. And it works pretty quick. Now, I need the time that the calcium got me, because my nurses have to mix this up, and it takes a few minutes to get it into them. And if he's got a sugar, because he's a diabetic, that's 700, you don't need the insulin. You don't need the glucose. But what I usually do is give 5 units I give an amp of glucose and 5 units of insulin. And that's good. It buys me 2 hours. It works pretty quick. And now I have 2 hours. So we're talking 3:30 in the morning. It won't be enough, but it gets me closer to the dialysis time. The other thing that's really nice is beta adrenergic agents. I don't even need an IV. I can stick this in his face and say, breathe this, and it will drop your potassium about 1. So I go from 6.7 to 5.7. That's a miracle. That's a wonderful, I'm done with this. Now, the issue being is that it works pretty quick and it wears off in about 2 hours. So when I have somebody who has life-defining hyperkalemia, they get albuterol, insulin, glucose, and maybe calcium. And the order is calcium first, albuterol second, insulin, glucose third, because that's the quickest way to do these things. And it buys me 2 hours, which means I got to do it again in 2 hours. I got to check the level and do it again. And I have to do it in 2 hours, and I have to do it in 2 hours. And if you quit doing it in 2 hours, then he just dies. So you've got to get it right. You can alkalinize people. Now the data on this is not so great. And the reason is if you're not acidotic, it doesn't do anything. And if they are acidotic, well, that's just great. But how long can you make somebody alkalotic? And the answer is the body hates being alkalotic, and it will fix it for you in about 30 minutes. So what's it buy you? It buys you about half an hour if they're acidotic. And if it's not acidotic, it doesn't do you anything. So the key on that one is, and renal failure patients are usually acidotic. So you can do this blind if you need to, but everybody else, it's not going to help. The next one is loop diuretics. They work pretty cool. They'll start to urinate within about 15 or 20 minutes, and it takes potassium out of the body. There's no shifting. It doesn't wear off. Once they put it into the bag at the end of the bed, it's gone. The problem is renal failure patients don't pee at all. So what does it buy me in this guy? Absolutely nothing. It's useless. So if you can't make urine, diuretics don't get you anywhere. The other problem is that diuretics aren't fast. It will get it done, but not speedy. So you can't use that as first-line therapy. And this is the binding resins, caxylate. It's the only one that existed since 1958. And it works, but if you look at the time, onset 2 to 12 hours. And that is because most of the potassium in your gut is in your colon. So it's got to get to your colon before it has an effect. And it doesn't work very fast. So the makers of it said, well, we're going to put sorbitol in it. So it shoves it down the GI tract really good. But, it's a couple meters to your colon before it starts to work. So you never really know how quick it's going to work. And the other problem with it is it expands remarkably in the bowels. It gets much larger. So it creates diarrhea like you can't believe. So my patients usually don't want to take it. And so this is what you get. Maybe it works in 2 to 12 hours. You're going to need a bedside commode. And my nurse will look like this because they really hate it. My nurses refuse to give this unless I'm pushing them on the elevator to the upstairs floor because they don't want to have the patient do this. It's a profound amount of diarrhea. I had a guy that I sent home once. He defecated all over the inside of his car, and he made me clean his suit. It cost me $35, which I thought was fair. This is caxylate. This is how it became approved because it would never make it today. This was in 1958. The FDA did not exist in 1958. They took 5 patients who were hyperkalemic. They gave it to them. 3 of them died. 2 of them did not. And they said, this worked pretty good. And it got FDA approved because the FDA became in existence a year later. So it grandfathered in. You tell me a drug in the world that got approved on 5 patients that killed 3 of them, and I would be really surprised. Since then, there have been increasing numbers of adverse events associated with it. And this is the scary one. This was in 2013, 58 cases got colonic injury from the caxylate. 33% of them died. So this is a scary drug. If they get colonic necrosis, the chances of them making it is not that great. Besides all the diarrhea and problems, and this is the black box that caxylate carries. So here's the challenge, is that's what we got. So this is a study we did a couple years ago called Reveal, and we asked emergency doctors, what do you do when you have hyperkalemia? And these are all the things they do. There were 144 of them out of 203 patients. So what this means is there's no algorithm. People do everything they want. Some people dialyze them, some give them calcium, some give them beta blockers, some give them both, some give them more. It just went on and on and on. So there was no algorithm, no standard until recently. And literally on the plane coming here, there was a group of us in the US that published an algorithm for the American College of Emergency Physicians. And I'll show you that at the very end. This is the other thing we learned is that when the potassium is 7, patients tend to get 5 therapies. And the lower it gets, they get less therapies. So when you have somebody who's 5.5, you don't need to give a lot of hyperkalemia therapy. But when they're 7, you really should do it. And the problem is you have to do it over and over and over because hyperkalemia is like blood pressure. I can fix all hypertension. The only question is how much do I have to do? How often do I have to do it? Same thing here. So it's a headache for the doctor. These are the adverse events that came out of that same trial. 17% of the patients got hypoglycemic, and it wasn't just a number. It was symptomatically hypoglycemic, like having a seizure. That's never a good thing. And so whereas we used to recommend 10 units of insulin and an amp of glucose. Now it's 5 units and an amp of glucose, because you can always give more insulin later if you need to, but if you make them seize, it's a problem. The other thing that happens is this is the patients who have potassium 6 to 6.5, and that red box is all the complications. There's a lot. Our treatment causes trouble. And you can see the majority of the problem is the top there, the GI disorders. It's profound diarrhea and abdominal pain and cramping and that sort of thing. There were cardiac events more related to the hyperkalemia. So this is the first of the new binders. It's called Patiromer. It's plastic, little fibers. Instead of being sodium potassium exchange, it's a calcium potassium exchange. It starts immediately. Yeah, the most potassium is in the colon, but there is potassium in the small bowel, and this starts as soon as it gets there. The companies for both of the new markers recommend relatively low doses, and we have been pushing this for acute use to up the dose, and I'll show you that a little bit. This is what happens when you give the doses. You can each stratum 1 and stratum 2 is increasing doses of Patiromer. And so when you get to the end in patients based on their hyperkalemia level. So on the right were doses of up to 33.6 milligrams. What I use in the US is 25 grams, or I'm sorry, 25 milligrams, because that seems to be, I'm sorry, it's grams. That seems to be the fastest, safest thing to do. The adverse events with this are really minimal. This is patients who received the drug for a year. So if you can take a drug for a year, it can't have too many adverse effects because patients quit taking it. But a year doesn't help me acutely. But if you look at the first day there, you can see the potassium dropped pretty well from almost 6 down into the 4 range, which is exactly what I want a drug to work like that I'm going to use acutely. And these are the adverse events. They were divided by heart failure and did not heart failure. But what you really want to look is the number of patients who stopped the drug, the third line there, 7%, 6%. This drug is highly well tolerated. 95, 93% of the patients can take it. They took it for a year. So it's not a terribly toxic from the patient experience drug. The other thing to look at is at the bottom there, how many patients became hypoglycemic? 3%. I mean, hypokalemic. It's really hard to make people hypokalemic who start high. So it's not a real issue. It's 3% you have to worry about. This is the trial we did to see if this is an emergency drug. We gave patients 25 grams of Patiromer or blinded placebo on the background of standard care. And this is what you got. At 4 hours, the red line is the Patiromer line. The blue line is the standard of care. Now, unfortunately, this was a small pilot trial. Standard of care started with a higher number because these were not, it was open label. I'm sorry, it was a randomized, but it's only 30 patients. But what you want to look at is the slope here is much higher if you also gave Patiromer on the background of standard care. And that's the one value. The other value is this, is patients who got Patiromer had to have an average of 1 more treatment of insulin and glucose. The patients who got standard care had 11 milligrams of albuterol versus 3.3 for Patiromer and 2 doses of insulin and glucose. So when the patient comes in, you do all your standard care stuff. They get their albuterol, they get insulin and glucose, and you give them the Patiromer right then, and you don't have to do anything for a long time, at least 4 to 8 hours later before you have to redose them. If you don't give them the drug, the binder, you have to do it every 2 hours from then on. This is the other new binder. This is ZS9. It's zirconium. And most of us don't have a lot of experience with the zirconium, but I will tell you that you do, because most deodorants have zirconium in them. So you've been rubbing zirconium on your armpit for the last 22 years, and that's how safe it is. The advantage of zirconium is potassium can bind in this hole it has in it. It's not a covalent, but it's a very high electrostatic charge. It has 125 times the binding efficiency for potassium as compared to caxylate. So it's a very effective binder. This is the same type of trial that the other trial had done. This is a month-long ZS9 trial. Is divided by heart failure again. But what you can see is they started at about 5.6, and over that first few days drops pretty quickly. This was the adverse events associated with it. The adverse events are the same as placebo. So patients with the overall adverse events are on the left. The ones on the right there are in the month long. So this is early phase. Placebo has 10%. That's the green on top. Adverse events. If you look at the 10-gram dose, it's 11.9%. So it looks like placebo in terms of adverse events. There were actually more GI events with placebo than there were the ZS9. This is the data. I got this from the company. They had done analysis of 1,000 patients, followed for a month. And I said, well, how many had high numbers? And they said, oh, 45. I said, I should publish that. I got this published in the New England Journal. It's the first retrospective analysis I ever had done there. If your potassium was greater 6, I looked at who had a dose of 10 grams of ZS9. There was 45 of these patients. And this is what you got, is that by 4 hours, the decrease in potassium was 0.7. Now you take anybody down by 0.7 and you're pretty much done. And they didn't get any other treatment. All they got was ZS9. So what this does is a single agent worked pretty effectively. And this was the first trial we did of this. This is the Energize trial. It's presented a little complicated, but I'll explain it to you. This is how it worked. Patients came in, they got randomized to standard care with placebo, standard care with ZS9. And that was it. They got doses at 4 hours. And if you see the pink line over there, that's the number of patients whose potassium is below 6. You would like to be as high as you can. The blue line was standard of care. And this is exactly what happens is they gave them the standard of care, the potassium went down, and then they stopped the standard of care and the potassium came back up. That doesn't happen with the binder. When you give them the binder, the potassium stays down. So your workload goes down and the patient has a safer ride. How many patients got more therapy? Just like the other trial, 9% of the patients with ZS9 got more therapy. That's SZC, if they changed the name of it. And placebo patients, about a third required more therapy. So once you've got them moved the right direction with the binder, you're pretty much done. This is the algorithm that just came out. I'm sorry it ended up so tiny. I didn't know that would happen. But the bottom line is this. A patient comes in, they're hyperkalemic. If they have EKG changes, give them calcium. If they don't, then it's insulin, glucose, and albuterol and a binder. It doesn't specify which binder. Use whichever binder you like. But I would avoid Caxlate. The general rule being when two agents are the same, but one has a black box, you should avoid the black box. That's Caxlate. I don't use Caxlate ever again. So patiromer and ZS9 are effective at lowering the potassium. Both have very few side effects compared to Caxlate SPS. But its acute use is off-label. And the doses we're talking about are higher than the recommended. Patiromer, they recommend 8 doses. We use 25. We use as much as 30 grams of ZS9. We're using that. So let me wrap it up here. Once again, thanks to the great meeting. This is the Emergency Medicines conferences that I run. You will recognize that the great meeting is on the skiing conference in Park City, Utah. We present abstracts there. They are published every year. This was last year's. We have never missed a meeting. It's the oldest emergency medicine meeting continuously running on the globe. And that's the journal we publish all our abstracts in. So if you come and put an abstract, we'll get it published. And the other issue on that is that you can use repeated abstracts. So if you presented them here or you presented them at AHA or some other meeting, you can repeat them there because we do encores because the way we publish them is as the meeting minutes. All right. Hopefully we'll see you there in March.
Thank you. Thank you, Frank. This is, first of all, a fantastic presentation, but also a fantastic invitation because at the end of the day, I've been in Park City and it's really something that we should take at least once in our life. So the presentation from Professor Piccoli is open for discussion now. Any comments, any question? First of all, meantime, people are thinking, Frank, I think that I really enjoy your first slide presenting EKG, right? So since yesterday afternoon, we had some idea on hemolysis, right? Interfering with the potassium. I think that coupling together the number with some clinical finding is always important to think if there is really hyperpotassemia circulating or is hemolysis. What do you think about this scenario of committing the algorithm, clinical science plus potassium?
Yeah, that's the pretest odds are deciding what you do. So if you have a 25-year-old kid who's there with something else and they draw the blood and the potassium comes back 9, it's probably not real. If they're a dialysis patient, they probably are. And if you're ever worried, you should always repeat it. I mean, because this is a fatal consequence. But pretest odds are a big driver. You know the things that are associated with hyperkalemia, and renal disease is the #1 by far.
Please put together numbers. Yes, please. Identify yourself and ask the question, please.
Hello, everybody. Thanks for the presentation. I'm Paolo Bima, working in Basel at the CRIP. If I got it right, for hyperkalemia, you do like a bolus of insulin plus glucose, right?
Correct.
what do we do in Italy, and we don't get so many hypoglycemia effects, is a continuous infusion of insulin and glucose. So diluted in a large number of, in a larger amount of glucose. So you can control it. What do you think about that? Is still.
Yeah, so if you've got a nurse who can watch the drip, that's fine. My department, especially in the last year when we've been, COVID has just overwhelmed us, is we have tried to develop everything for the least amount of effort as possible. And the advantage of bolus therapy is you give it and you can walk away and not have to be messing with the drip anymore. These people will stay in our intensive care unit area, but we bolus them, give them the oral binder, and then you're pretty much at 2 hours we'll draw again and make sure it's down. And usually if you've given insulin, glucose, and albuterol and a binder, it's down and it will stay down, which means nobody has to mess with that patient anymore. The drip works, and I've used drips frequently, but the bolus strategy is just a less intensive nursing and physician involved strategy.
Yeah, not the polymer results are impressive, really. Thank you.
Thank you.
Frank, I understood that these two new drugs are taken orally. And if the patient is unconscious, you cannot use. And also, my second question is, are they completely compatible with the classical treatment, especially for calcium when you are in an emergency situation?
Yeah, you're right. They have to be oral. So if there's any oral contraindications, so they've got a bowel obstruction or they're unconscious, or if they had a G tube, you could do it. But for the most part, they have to have a functioning mouth and a functioning GI tract. In terms of medications, there are no contraindications to be given simultaneously. When they first came out, they both had a warning which said, don't give them their regular cardiac drugs because they might be bound. So if you gave them DIG, orally, and a beta blocker, and whatever other drugs you were using, the concerns was they would then have a hypertensive crisis or something of that nature. That's turned out not to be true, that these drugs bind potassium, but not other drugs. So it's been absolutely safe. And you don't have to make any kind of adjustments when you've given this orally.
If there is no any other question, you? No? Okay, thank you, Frank, for your excellent presentation. And I think let's move to the next presentation. Will be Velipika Harjula, but I think it will be a connection from him. Hi, Velipika. Hello. Oh. Hello, Velipika.
Now I think you hear
Oh,
me.
yeah. Hello.
Okay.
How are
yeah.
you?
Yeah. Fine, thank you. Things are great here in Helsinki.
Perfect. How is the weather there?
Well, it's great.
Question, please.
Everything is great if you ask. But at the moment, so it looks like autumn. The leaves are yellow, falling down from the trees.
Okay, it's a pleasure to have you here. And he's going to present the high-risk pulmonary embolism. Go ahead. Yes, you should put the presentation on the screen, full screen.
Yeah.
Yes, this.
Is it working now?
I think it's cut. I don't know why. Can we solve this problem? No. Okay, go ahead.
What do you mean? So it's working?
Yes, it is working, but it's not the full screen. We can only read great yes, it is not finished the sentences.
Okay, does anyone with the technical knowledge there know, because it's
Perhaps if you
like full screen here.
If you go out and decrease the yes a little bit more and go ahead.
Yeah.
Yes, go ahead.
Okay, do you like it better like this?
Yes, we can see this. No?
Yeah, now it's okay.
This is better. It is okay.
Okay, we will go on like this. So I'm very happy that I will be now there with you, even with the internet connection. I really would have wanted to be with you in person, but next year I heard maybe in Vienna, which I would also vote for. So let's meet then after 1 year. And my topic is high-risk pulmonary embolism, and my only disclosures are that I've been involved in great network since the beginning, and we held the meeting in Helsinki 7 years ago. I'll start with a patient case, a 56-year-old lady who came more than 1,000 kilometers from northern Finland to Helsinki. She was on hormonal replacement therapy, a smoker, and obese. She had had a plaster cast for 2 months because of Achilles tendon injury, although it was removed already 1.5 months ago. And then she took the 10-hour train trip and was visiting her friend. There she woke up in the night, stood up and felt sudden severe dyspnea. The EMS was called, and when it arrived to site, they found the patient with cold, clammy skin, speaking only short sentences. Her blood pressure was extremely low, 65 millimeters mercury, heart rate elevated 115, breath rate elevated 35 per minute, and oxygen saturation low, 85%. In ECG, sinus tachycardia was present with partial right bundle branch block and S1Q3T3 configuration. So what was done? There obviously were no clear contraindications for thrombolysis, and the patient received bedside a bolus, 50 milligram bolus of tenecteplase together with enoxaparin 30 milligrams IV. So it was similar to STEMI protocol. The patient arrived to CCU. The right lower limb was a bit swollen, but in a lower ultrasound, no thrombus was present. Echo showed right ventricular dilation, which compressed left ventricle, D-dimer highly elevated, but shortly after the thrombolysis, troponin T 246. And in CTPA, so CT scanning, numerous bilateral emboli. After 18 hours, she was transferred to ward with low molecular weight heparins, and later on warfarin was started. So maybe you ask, how can they do it, and is this wise at all? So I will lead you through the risks of high-risk pulmonary embolism. So what about the epidemiology of fatal pulmonary embolism? A colleague from our clinic recently published this data, which was based on death certificate archives in our hospital district, which includes around 1.7 million inhabitants. And the patients who had PE as an immediate or underlying cause of death were analyzed. This consisted 4-year period, 2015 to 2018. 451 patients had PE as the cause of death, and 55% of the cases occurred out of hospital. However, resuscitation was attempted only in 40% of the patients, and only 7 of these 264 patients received thrombolysis during resuscitation. Clear minorities occurred in hospital or in palliative care units for treatment of cancer and similar conditions. And in many patients of the in-hospital cases, the diagnosis was only made post-mortem. The German made an analysis about adverse outcomes in pulmonary embolism in a single center registry. They analyzed either pulmonary embolism related death or cardiopulmonary resuscitation and in-hospital mortality. So regarding these 786 patients, 86, which is 11%, presented with high-risk PE, and they more often had adverse outcomes, which is quite reasonable, and that amount was 43%. Those with cardiac arrest had in-hospital adverse outcomes in almost 80%, and the mortality was high, 60%. And regarding the other presentations of high-risk pulmonary embolism, only obstructive shock was associated with increased all-cause mortality, but not persistent hypertension. So without going through the whole pathophysiological loop, it's true that when you get pulmonary embolism, you increase the right ventricular afterload, which leads to dilation, tricuspid valve insufficiency, RV wall tension, and all kind of deficits in the oxygen delivery and shunting. And by going through shock, at the end, the patient goes to, let's say, to coffin if or not treated in a proper way. The ESC guidelines were presented 2 years ago. I was participating the task force, which was very intelligent group, and was happy to be following the work and contributing especially to the high risk management. And I will lead you through these and also some scientific evidence. So the recommendations for diagnosis rely on bedside echocardiography as soon as there is suspicion of high risk PE. It has very important value when it shows the RV dilation, and it has also differential diagnostic value by showing other causes of shock. Emergency CTPA is of course an option, but quite often it's not so quickly available that you may need to go to the treatment just by having the echo results. You should have IV anticoagulation without delay in these patients if you consider that they first should go to, for example, to CT scan, and it's only like mild hypotension. These echo findings are common to all kinds of RV failure, and I think they are quite easy for everyone who does echocardiograms: tricuspid regurgitation, TAPSE, RV dilation. You could also assess RV fractional area change, but not, I think, in the immediate emergency type of bedside echo. And then you see the deltoid shape of the septum when the RV is dilated. You can also quickly assess RA pressure, atrial pressure by checking the vena cava. So what actually is a high-risk PE? It is a PE which is characterized by hemodynamic instability associated with RV dysfunction on either echocardiogram or CT pulmonary angiography. Of course, there are all these signs of PE severity present, but they are not needed for the diagnosis. Likewise, the cardiac troponins are not needed for the management. So in that way, it's equal to, let's say, for example, ST elevation, where we should not wait for the biomarkers. We have these other classes, intermediate, high, intermediate, low, and low risk populations. And to recognize all these different populations, you then choose or choose the management strategies, even to early discharge to home from ED or after short observation in hospital. The definition of hemodynamic instability ranges from cardiac arrest to obstructive shock and persistent hypotension, which we could say is the mildest form of this high-risk population. And now I would like to ask, what is most likely the smallest landmark study? So you will there need to think about it for a while. Most likely you think it's about pulmonary embolism, maybe diagnosis, maybe management, but let's go through the guidelines. So it's recommended that the rescue thrombolytic therapy is done as soon as patient has hemodynamic deterioration. So in all these high-risk population. However, surgical embolectomy or catheter-directed treatment should be considered as alternatives for those patients who deteriorate hemodynamically, but thrombolysis is contraindicated, or actually if it's not working well enough. ECMO may be considered, and of course, ECMO resuscitation is one sort of option to carry on the patient alive until the thrombolytic or catheter or surgical therapies work. And more importantly, you should have a clear multidisciplinary team in order to go through and make decisions of all these specific therapies. So to go back to the smallest landmark study, so it was performed by these colleagues, Jerjes Sanchez et al. 1995, and it compared streptokinase kinase against heparin alone in massive pulmonary embolism. They had 4 patients in one group and 4 in the other. And in the streptokinase group, no one of the patients died, whereas in the control group, no one survived. So this is like 0 against 100. And then when we look at the meta-analysis and studies, including high-risk PE, starting from 1970, 78, 79, Jerjes Sanchez 1995. So actually, the odds ratio in their study was 0.0, and the overall odds ratio after this fixed effect model was 0.48. But without their study, maybe this wouldn't become significant either. So that's the way we do real clinical trials, very effective. What about the trends in thrombolytic treatment? So do we give our patients enough adequate treatments? So in Germany, they have a huge registry of almost 900,000 patients. And they analyzed this during that 11-year period. Of those, 9% were hemodynamically unstable, 91% stable. And those who were unstable, most underwent cardiopulmonary resuscitation, and a minority was in shock. But in hospital, death was 84% in those with CPR, and only 25% of them underwent systemic thrombolysis. In those with shock, in hospital death rate was less, a bit like in a cardiogenic shock as a whole. It was 47%, and again, only 15% were given thrombolysis. And then in the hemodynamically stable patients, the in-hospital death was 11%. And on the other hand, even in that population, 18,000 patients received thrombolysis, which actually is not a recommended therapy. And there was clear survival benefit in those patients who got thrombolysis. We have also been analyzing our hospital patient data. My daughter Johanna presented some of this data already years ago in great meeting in Barcelona, and got a lot of good advice how to improve the paper. And we went through all those patients in the EMS and hospital registry who had been given thrombolysis, and out of them found out the diagnosis of pulmonary embolism. So this was actually a thrombolysis registry, and out of them we found 22 patients with high-risk PE, and 17 of them were in cardiac arrest, five of them in cardiogenic shock. And without going through this busy algorithm, survival rate was 45% as a whole, 59% in cardiac arrest, and 100% in cardiogenic shock. So even though this is a very small population, you can see that the mortality rate is much better than in the German registry if we look at as a whole, and only few fatal complications. You use either RTPA or streptokinase, typically a 2-hour infusion of RTPA. We are feared about fatal bleeding. We are feared about fatal embolism. So we need to have a balance. And we need to know the absolute contraindications for fibrinolysis. Regarding the other supportive therapies, vasoactives, ventilatory support, ECMO, I suggest you go and visit this paper, in which, for example, Alex has been participating, and Stavros Konstantinidis had a very important role. And I would finish with this conclusion slide. So high-risk PE is defined as PE with cardiac arrest, obstructive shock, or persistent arterial hypotension. There is very high risk of death, particularly during the first hours or after admission, or actually presentation. There is substantive out-hospital mortality, and to diagnose, you should use clinical prediction, immediate bedside echo, or then CTPA if very urgently available. The mainstay of therapy is reperfusion therapy with thrombolysis. Alternatively, and depending on local facilities, you can use surgery or catheter techniques. You need hemodynamic and respiratory support, and role of ECMO needs to be further studied. So, ladies and gentlemen, remember lysis both at home and at work. So Mr. Muscle helps at home, where the obstruction can be relieved within 1 hour, according to the product descriptions. And after 1 hour, the RV is again free and happy. Thank you.
Thank you, Veronica, for this review. Now it's time for questions from the audience.
Yeah, if I can, Joseph. Hey, Veripek, how are you? Everything's fine. It seems you have a really good opportunity to give a great talk to us, and we are happy about that. Just one question. We, spent 2 days to see the value of high-sensitive troponin that are recommended to be detected, as you said, so only in high-risk patients. Is that no risk that you are sending at home patients with low risk without performing high-sensitive troponin that can develop some consequence? I mean, do you think there is room for, prescription of high-sensitive troponin all the patients with pulmonary embolism? Of course, this is a provocative question, my friend.
Yeah, thank you very much, Sal. And yes, I'm doing fine. And I would say that it's not actually provocative in most of the patients with acute dyspnea or acute chest pain, which is the common symptoms. Troponin is taken anyway because of the differential diagnostics. And we, of course, should not forget in a patient who has elevated troponins that there are several options for the reason. But if you see elevated troponins, the patient is in intermediate risk. And if there are other signs together with troponin elevation, which means RV dysfunction, the patient needs to be observed in a CCU type unit. If the patient is in intermediate low setting with only one of these two positive, the patient needs to be observed and treated in a regular ward. And if none of these are positive, the patient is in low risk and could be discharged early. And in these low risk patients where the symptoms typically are minimal, you are not required to take troponin. So that is one way to think this. So not needed in everyone, but if taken, if positive, so then it's a sign to hospitalize the patient.
Listen, we are still using streptokinase or RTPA because the trials were using these two drugs, but perhaps are any trial, small trial using tenecteplase, which is a more quick action in very urgent situation, an emergency situation. And do you have any information about this?
Yes, thank you. That was a very good and important question. So tenecteplase has been studied in a pathos study by Kui Meyer and Stavros Konstantidides. It was a multicenter study which was focusing in patients who I think fulfill the intermediate high risk criteria as considered today. I think it was published 2017, and they found, let's say, early benefit, but on the other hand, they found that the bleeding risk was too high. So regarding the small benefit, which was, let's say, less worsening of these patients and less need for subsequent thrombolysis. So that meant that they considered that the harm is higher than the benefit. And actually, when they did also a long-term study, they didn't find benefit in long-term follow-up regarding the risk of chronic thromboembolic pulmonary hypertension or their physical activity or physical performance, and so on. So at the moment, there is no studies regarding high-risk pulmonary embolism and tenecteplase, but in our local practices, we need to use those thrombolytics which are available. And for example, in the pre-hospital care, they would then have either reteplase or tenecteplase. but not TPA.
And any difference when we use thrombolysis with catheter, pulmonary catheter or systemic?
Sure, yes. If you can do the catheter therapies fully without any thrombolytics, so just mechanically with aspiration, with fragmentation, or if you use local thrombolysis via the catheter, the amount of thrombolytic is minimal compared with the dose given peripherally. And we also have had available the ultrasound enhanced therapy echoes, but there are no real data either with that showing that echoes would give any specific benefit in high risk population. It has been only studied in intermediate risk patients.
Okay, if there are no more questions, it's time to say goodbye. Willy Pika, thank you very much for your intervention. I hope to see you next year physically.
Yes, see you.
Okay, bye-bye.
Thank you. And now I have the pleasure to invite again to the podium Nick Mills. He's going to give an important talk, especially for young fellows here, right? Tips and tricks on implementation studies. I think will be really appreciated for young fellow. This is a really interesting lecture. Thanks, Nick.
Thank you. Okay, wonderful. Slides are there. Excellent. So thank you for asking me to speak this afternoon. I've absolutely loved the meeting, and it's just been great to have these interactions and discussions with you all again. So I was asked this time to talk about implementation research. So I had to do a bit of thinking about what that meant. And I'm, our research group is interested in diagnostic approaches and how they impact patients and outcomes once we introduce them into clinical practice. So rather than dwell on the results, I'm going to talk a little bit about the approach methodologically to evaluate the diagnostic test into practice. It's what the advantages and disadvantages of different study designs are and what we've learned from doing these. And I'd like, if you don't mind, to humor you by starting with a wee lesson from the past. So this is our hospital where I started my training 20 years ago, the Royal Infirmary in Edinburgh, and it's played a really important role in heart disease care worldwide, and I want to tell you why. So for those of you that are doing your first bit of research or presenting cases, then there's hope, because this is a case report from a clinical fellow or trainee from published 60 years ago yesterday. I would ask if you ever have like 10 spare minutes and want to read a really interesting paper, that you read this. He basically published 5 cases of patients that he'd attempted to resuscitate in this wonderful old hospital. And he back then struggled. 4 didn't make it, 1 survived. And the one who did survive had significant brain injury, unfortunately. But he notes in the paper that he could still play golf 6 months later, which is a very important outcome in Scotland. So there was hope. And in the discussion of these cases, he made the point that it would make sense for patients with heart attacks to be grouped together in the hospital to enable cardiac monitoring and to facilitate quicker resuscitation, because defibrillation required open thoracotomy back in the 1960s. And so it wasn't quite so easy just to organize. So quite an important, and he made the case for the creation of the coronary care unit. Now, he then implemented that idea into clinical practice, and this was his follow-up paper 6 years later in The Lancet, where he reported the first outcomes from patients before and after introducing a coronary care unit. And he had 400 patients, and the absolute mortality was 7% lower after the implementation of a coronary care unit into clinical practice. And this was the first coronary care unit in the world. And I love this photograph because I actually did work in this unit and it looked pretty much the same. Although our ECG machine was just 1 model later, I think, than that one. Really interesting. So implementation research, what is it? It's quite a new kind of field of research. I don't know how to define it, so I made up a definition, so I can find one. which is that it's the evaluation systematically of the uptake of evidence-based interventions to determine their effectiveness and safety in clinical practice. And there are a whole range of different designs that you can do of studies to look at implementation. And these are just some that we have tried with various success. So the first time we did this was 10 years ago, and we used a study design called a controlled before and after study. Now, it's not that far removed from a quality improvement project, which is an uncontrolled before and after study, but the controlled element is quite important. So what we did was, when a new sensitive troponin test came along, was we measured it and didn't report the results to clinicians below the threshold that they were used to using for diagnosing myocardial infarction. And we observed that this group of patients had terrible outcomes. And we thought, well, maybe we should report them. And then we implemented the new threshold in practice. These are staggering thresholds in modern times, like 200 nanograms per liter, and repeated the exercise the following year, and demonstrated that this group of patients who had previously undisclosed troponin concentrations did better because they got more treatment. Quite simple. But there are all sorts of challenges with before and after studies. This one was quite good, though, for a number of reasons. So, or I think it was quite good. First of all, it allows you to evaluate the test in everyone whom clinician requests the test. So it's consecutive patients. Secondly, we're able to control the study by measuring it in the background during the validation phase. So it was very clear which group of patients before and after the test was introduced would actually potentially benefit. Thirdly, we had a control group of patients who had low troponins and high troponins, and whose care did not change before and after we introduced the lower threshold. And that gives you a degree of control that avoids time bias. And then lastly, we had calendar matching to avoid seasonal bias. But of course, there could be other time varying factors that have influenced care. That means that's not directly as a result of lowering troponin threshold. And it was single center with limited generalizability as a consequence. So when we tried to do this again, this time with a high sensitivity test, we used a different trial design. We went for a step wedge cluster randomized trial. And there were various reasons why. We implemented the universal definition recommendations. So this was already guideline recommended. So it seems reasonable to introduce it into clinical practice. We did it without individual patient consent because we wanted to include everybody. And we randomized centers to delayed or early adoption of this test rather than individual patients, and looked at their outcomes. And we took elements from the before and after study into the trial. So in everyone, before we introduced the test, we measured in the background, and vice versa when we switched it into clinical practice. And that ensured that we were able to identify this group in the middle that might plausibly benefit. Now, unlike the first study, we didn't demonstrate any improvement in outcomes, at least at 1 year following the intervention. And the first observation is that outcomes were substantially better 8 years later than they were in 2010, generally. But there were a number of reasons, I think, why we didn't improve care. Although I'm a super optimist, and we have got a pre-specified 3- and 5-year outcome of this trial coming, so we'll see. But I still think it was the right trial design, and I think it was because it would have been completely impractical to randomize individual patients to use one test or another test side by side in the same unit. So cluster randomization was essential. Again, it allowed us to include consecutive patients, and it contains a couple of different features in the design. So both within site, before and after components, as well as across site parallel group comparisons. And that reduces your risk of time varying biases. It also generated a large number of outcome events, which made it well powered, but it was a little cheaper to do than an individual patient randomized trial. But the power is driven not necessarily by the number of patients, but the number of sites. And there's this difficult calculation called an intracluster coefficient, correlation coefficient, which is difficult to measure in order to plan your trial. And if there's variability in care or outcomes between the sites, then it is difficult to be certain what your power is. And also when you do a trial like this, the data quality is variable and it varies from all the different centers, and therefore you really need very robust adjudication to try and standardize the data. And it's pretty difficult to do in terms of a governance perspective. So some challenges, but as you've heard, it generates lots of interesting data that enable observational analyses beyond the original primary question. And I think, as Matthew showed yesterday, that it is difficult to improve outcomes in acute coronary syndrome in our complex aging population, where many patients with small troponin rises have other illnesses other than myocardial infarction. And so we've still got a lot to learn. But the one thing we did learn is that although high sensitive troponin didn't improve the diagnosis of myocardial infarction and care, we did learn how to rule out myocardial infarction quicker and better. And I think we learned that there probably is no optimal rule-in threshold to try and make the diagnosis that works for every patient because of the heterogeneity in patients. So not put off, we had another go at a step-wedge cluster randomized trial. This time randomizing the implementation date of the pathway. And we enrolled 31,000 patients in this trial. We had co-primary outcomes of length, duration of stay as our effectiveness outcome, and a safety outcome, which was whether they, after discharge, had a myocardial infarction or died from heart disease. And we had co-primary outcomes with sequential hypothesis testing, not because we didn't think we would change length of stay, but we had to convince ourselves that people actually followed the pathway before we then could go on and evaluate safety. So we met the primary outcome for effectiveness. Length of stay was reduced by just over 3 hours, and pleasingly, we increased discharges directly from the emergency department by just over 50%. So that ultimately around 3 out of every 4 patients went directly home, which I thought was really impressive adherence. We didn't meet our safety endpoint. We found there were a very small number of events at 30 days, just 113 across the trial population. And although the event rate was 0.3% after the rule-out pathway is adopted and 0.4% in standard care, because these events were spread out over a 2-year period, it was extremely difficult to model a non-inferiority endpoint. So with very wide confidence intervals. But I think you would agree, looking at the Kaplan-Meier curves and the 1-year event rates, that there was really no evidence of harm in terms of safety. But we've thought a lot about the trial design and whether this was the right design. And I don't think I would do another step-wedge cluster randomized trial for a non-inferiority outcome, particularly with a very low safety event rate. Because if you actually look at the individual monthly event rates that we tried to then model across the trial, there were some months where there were no events at any site. And it's extremely difficult to model that. It's also very vulnerable to events that occur during the parallel running phase, where there are sites that are running both pathways. And it was quite short, that period in our trial. So I'm not sure I would do it again for that particular design. Another important tool in implementation research is mixed method designs where we combine qualitative and quantitative research. And this is some ongoing work that I'm sure we'll present properly at some point. But we're trying to dig into adherence and what factors led to better adherence of the pathway in practice. And we looked at over-testing and under-testing. And I was very pleased that with the rule-out threshold of less than 5, 81% of people didn't repeat the test. They were confident to rule out at that threshold. But in terms of under-testing, those who are in the observe zone that Pedro was discussing before, with neither ruled out or ruled in, just 65% of people did the second test that the protocol mandated. And the other thing we learned is that if you look at the months following implementation, there was an improvement in adherence over time, although I would argue that it was perhaps waning at 9 months and started to increase again, which reinforces it's not just education at the time of implementing the pathway. Because doctors move around every 6 to 12 months in hospitals, you need to continue to maintain that education. But actually what I really wanted to talk to you about was the value of mixed methods, which is we did semi-structured interviews with staff before and after introducing the new pathway into clinical practice. And we found a number of factors that came out of those interviews that I think are relevant. The pathway itself, I think there were some issues with. The healthcare system, patient factors, healthcare professional factors, and whether people believed in the science. And I'm going to give you 3 quotes. One's from a consultant, one's from an advanced nurse practitioner, one's from a junior doctor. And I'm going to ask Christian to tell me which is which. So Christian, here's the first quote for you. I suppose I probably apply it pragmatically. So if you've had pain for 6 hours and your first troponin is less than 4, I do another one in a period of time. It's not necessarily what the guideline says, but it seems like a sensible approach versus if you stick to it rigidly. So is this our junior doctor, our consultant, or our advanced nurse practitioner doing? Consultant. It's very consultant speak, isn't it? Yeah, pragmatic. Yes, the consultant. Okay, next we have, I find it comforting because we know that you're doing something that is kind of approved. And it means that you don't need to ask as many questions. I thought that was quite a good quote. I mean, there are tons of amazing quotes in the transcriptions that I could be here all day. So is this the junior doctor or the advanced nurse practitioner? Oh, close. No, junior this time. Now here, the final quote. Some people will get really rigid with the guidelines and some people move the goalposts to suit. But I think to some degree, you have to take that the patient is an individual and see what works out for them. At last, the voice of reason from the advanced nurse practitioner. So really interesting. And I mean, we're still digging through all the information from it. It's really fascinating. Anyway, sometimes it's not possible to randomize the date of implementation of a new pathway or test because of various health service factors. And so our next trial design is actually an interrupted time series analysis, which the changeover day is next week. I'm getting quite tense about it because I'm in Rome. But yeah, this is a trial of switching between high-sensitive cardiac troponin I to high-sensitive cardiac troponin T. And it's a quasi-experimental approach. It's not as robust as a randomized study, but you can use, and Doreen will correct me if I've got this wrong, segmented logistic and linear regression models that allow you to evaluate, I think, hopefully some fairly pragmatic outcomes on a monthly basis before and after implementing the test across all these sites at the same time. And the absolute change in these outcomes should reflect the intervention, whereas the slope that will reflect time varying changes in practice over time. And you can account for these in the trial design. We'll come back and tell you whether that was, how we get on, whether we were more successful than last time with this trial design. But then sometimes you just need individual patient randomization for implementation research. So this is some work that we talked about a little bit yesterday, where we've been looking at the role of CT in the observed zone. And what we find is that if you ask a patient whether they've got symptoms that sound like angina or not, and CT them all, then whether you think they've got angina or they don't have angina actually doesn't help you when it comes to identifying those who've got coronary disease. Whereas if you look at those with intermediate troponin concentrations, they're 3 times more likely to have coronary disease than those below the rule-out threshold. But of course, we know CT is a good test. Why don't we just use it? It's a great diagnostic test. The question is, how do we use it? In what patient population? And what impact does that have on care? And that's why we're doing a randomized trial. And unfortunately, when your intervention involves contrast and ionizing radiation, individual patient consent is mandatory. And so this trial is randomizing individual patients to troponin-guided CT after the exclusion of myocardial infarction to determine what impact it has on survival. But based on, I added one more trial design in based on the case presentation from yesterday, and that is a self-controlled case series design. Now, COVID vaccination has been evaluated in large randomized trials. There was not a single case of myocarditis in either the control or the vaccine groups in any of the randomized trials. So there are situations where individual patient randomized trials are not good enough to evaluate your health outcome. And that is particularly with very rare events like vaccine-induced myocarditis. And since the first case, there have been over 1,000 case reports of myocarditis that is temporally associated with vaccination. we saw the data yesterday here demonstrating in Israel in 54 patients of myocarditis, a temporal association with the second vaccine dose with the Pfizer vaccine. But are these observed cases of myocarditis that are temporally associated with vaccination causally related? And I think that remains an important unanswered question. So the self-controlled case series design is an interesting method. It looks at the temporal association between a transient exposure, vaccine, and an event, myocarditis. Unlike most epidemiological designs, we have a case control design. There are no controls. Everyone's vaccinated. You know, 3/4 of the world have received a vaccine now, certainly in the UK. And those that haven't received a vaccine are quite different in lots of difficult to explain ways between those who have received a vaccine. So it's a case-only method, and it compares the incidence of adverse events during a pre-specified time period versus the incidence events during the other time. So the individual acts as their own control, if you like. So time invariant confounding is completely eliminated. Now, we looked at 3 vaccines, and we did this with 3 outcomes: myocarditis, pericarditis, or cardiac arrhythmia in 28 days following first or second dose. And we included a control event, which was a positive test with SARS-CoV-2. And we did it in just over 38 million individuals, and this is essentially everyone who's had a vaccine in the UK. And these are the data. So difficult to dig into it all, but it looks at the increase in incident rate at these time intervals after the first and second dose of vaccine. And what we found, we had 1,615 cases of myocarditis, and about the same for pericarditis, and we had 250,000 arrhythmias. And there was no association with pericarditis or arrhythmia, but there was an excess of myocarditis. And interestingly, it was present after all 3 vaccines. And what we did was we turned these increased incident ratios into absolute numbers of events per million persons. So following the Oxford vaccine, there is an increase of 2 per million events in the 28 days following vaccination. Following Pfizer, it's 1, and it happens to be after the second dose. Following the Moderna vaccine, it's 6. Interestingly, following the second Moderna vaccine, it's 10 per million. But to put it into some context, we had a variety of control endpoints, but this is the one that I think is important. The risk of having myocarditis following a positive COVID test is 40 per million, so substantially higher than the risk associated with vaccination. And I find those data reassuring. But it'll be interesting to discuss. Anyway, that was all I was going to talk about. I'd be delighted to take any questions.
Thank you. Really fantastic presentation. I think is for sure opening a new door in this field. And but this is really something that we should do together. Any questions from the audience?
Or not, because we are waiting. The Pope is waiting for us. So.
I think that high-sensitive troponin is going to be a big breakthrough in our clinical assessment. And I think this is something that we really, as a group, should put as a kind of a model, right, to change our future mind in many decisions, clinical practice. So this is a kind of, say, necessary effort that we have to do as a group. What do you think? Oh, Frank, if you can just
go ahead. I do think just on the general point about how we should evaluate new diagnostic tests, whether it's a point of care, ultrasound, or whatever it is, we should think carefully about the way we implement them into practice, because these trials often come for free. The intervention is something we want to do. They're often paid for by the healthcare provider because they want to introduce the test. And there's an opportunity to provide a little bit of rigor about how you introduce it in order to understand whether it was helpful. If it wasn't, how could we target it more effectively to make it more helpful? So I don't think it matters whether it's troponin or a different diagnostic test. I think there is value in the kind of implementation research methodology to try and improve practice.
Right.
So in the United States, we have vaccine crazy people, and I routinely see patients come to the ER with complaints that are I think they're mostly psychiatric, and the number one is arrhythmia. And so what did you call arrhythmia? Because I've never even seen one. I do an EKG, I get a troponin, I get a chest X-ray, I go, goodbye.
So first of all, that's the most difficult data because there are we did 6 subgroups of arrhythmias. So atrial fibrillation, flutter, ventricular tachycardia, heart block, everything, and tons of data. And I don't know how reliably it's coded by hospitals in terms of individual rhythms, but we found no signal associated with vaccination with any. In fact, if anything, there looked like there was a reduction in risk of presenting to hospital with arrhythmia on the day of vaccine. And that almost certainly is a healthy vaccine effect that, if you have palpitations or, and if you think about it, most of the rhythm disturbance in this sort of population, hospitalized arrhythmias, are atrial fibrillation or serious rhythm disturbances. And they're not the first presentation. You develop a chest infection and then you go into atrial fibrillation, for example. So they don't go and attend for their vaccine. So there's actually a little dip in risk of arrhythmia, which is probably a healthy vaccine effect. But there was certainly no evidence of risk of vaccine-associated arrhythmia at all in any of those different subgroups. And we did look at it specifically by rhythm.
I think that we can. Thank you again.
Thank you. Let's move to the next presentation. And I think John is not here, no? We will connect him. Hello, John, how are you?
From Athens. It's raining.
We cannot hear you.
Nice to see you.
Oh, yes, perfect. Okay, John is going to talk about novelties in cardiogenic shock. Welcome.
Thank you. First of all, I'd like to thank organizing committee for this kind invitation. It's great pleasure for me and my team to participate in this important meeting. And in the next minutes, I will speak about the new concepts in the management of cardiogenic shock, focusing especially in the role of cardiogenic shock teams at centers. I think that cardiogenic shock is a specific entity with a wide spectrum of manifestations involving peripheral organ dysfunction due to low cardiac output and hypoperfusion. But if you see here from cardioshock trial, the mean ejection fraction in cardioshock trial was 33 in patients with cardiogenic shock. It is absolutely higher ejection fraction than many of the patients with advanced heart failure. And this means that the pathophysiology is something different, involving also acute cardiocirculatory collapse in these patients, acute systemic inflammatory response, and alterations in microcirculation. The etiology remains mainly an acute coronary syndrome in 80%, but it's very interesting to see that 11% of patients with advanced heart failure had as a main feature a cardiogenic shock. And finally, some other causes like myocarditis and Takotsubo cardiomyopathy are also causes of cardiogenic shock. The mortality is very high, still very high. Looking at the European Society Cardiology long-term registry, the hospital mortality was 36%, while 1 year after the presentation of symptoms, patients had also very high mortality, 54%. It is absolutely different, this mortality, than the classical hypotensive acute heart failure patients. If you see here, the mortality in these patients was 26% at the wet and cold patient, the classical wet and cold patient. Again, I will say that the pathophysiology is something unique, is different from the classical advanced heart failure patients or the acute hypotensive heart failure.
John, yes? We don't see your slides. We don't see your slides.
I have shared. Sorry. Here? No? No?
Even don't hear your voice.
Here? Sorry.
Now it
okay.
Now, yes.
Was interference from Finland, I think.
Here is okay. You can see?
Yes.
Okay.
We can see you.
I will continue from the cardioshock trial mortality. In a cardioshock trial also, the cardiogenic shock with an acute coronary syndrome had higher mortality than the other causes of cardiogenic shock. There was also a very nice card shock risk score, including also, except the clinical characteristics at left ventricular ejection fraction, the serum lactate, eGFR, and also brain injury in these patients. And this score is validated, it's very useful in clinical practice. But I think a main advantage in the classification at definition of cardiogenic shock is the new classification in 5 stages, A, B, C, D, E. From the A, that are patients at risk, to B, with the beginning of the shock, with hypotension or tachycardia without hypoperfusion, to C, the classical shock, to deteriorating at the extremes. It's very crucial also from the transition from the one stage to the other stage, the advanced stages, the role of treatment. If there is resistance to classical inotropic therapy, there is the D, deteriorating shock, and there is a need for mechanical circulatory support, and also the role of serum lactate at over 2 is potentially the classic shock, over 5 is deteriorating shock. At these stages of shock, related very well with the mortality. You can see here from the A with low mortality to B with mortality near to 10%, there is high mortality in patients with stage C and D, especially in stage D, the mortality exceeded to 50 to 60%. The stage G extremes has also very high mortality, about 70, 80%. The serum lactate remains a very good prognostic marker. According to the findings of cardioshock trial, we can see here the relationship of serum lactate with a high mortality in these patients at the various stages of the shock. But also there are some new biomarkers like adrenomedulin, which is very good marker of hypoperfusion. After 48 hours in this very nice sub-analysis of cardioshock trial from helitopinin, you can see here that has a good prognostic value, better than classical serum lactate. Another important and new biomarker is the circulating dipeptidase 3 marker, which is also related with high mortality. It reflects potentially the peripheral hypoperfusion is also a factor that can cause further hemodynamic deterioration, exerting negative inotropic action into injured myocardium. The role of peripheral organ dysfunction is also very essential. The number of failing systems can be related with the mortality, over 1 to 2, 3, and 5, and 4 organs, from 30% mortality with one organ dysfunction to over 80% mortality if there is disease in more than 5 organs. Actually, we have now a very practical algorithm in the new guidelines 2021 with a management of cardiogenic shock, beginning from the initial evaluation of etiology of the shock. If there is an acute coronary syndrome, there is need for emergency PCI or surgical treatment. If there is other cause, the next step is to consider oxygen on ventilatory support, at inotropic at vasopressor therapy, and finally consider short-term mechanical support in refractory shock. And if there is improvement of hypoperfusion, the next step is the weaning from inotropes and vasopressors, and to continue etiological treatment at chronic medical therapy optimization. If there is no improvement, the next step is to consider long-term mechanical support or renal replacement therapy, or consider palliative care. But the real practice is not so promising. You can see here that from European Society, also long-term registry, except the use of inotropes, all the other treatments are used in very low percentages. You can see here, for example, that PCI performed in only 25% of patients, while we know that the main etiology of cardiogenic shock is an acute coronary syndrome. Also, the use of intra-aortic balloon was about 15%, also the right heart catheterization in 3% of the patients. That means in the real clinical practice, the cardiogenic shock is really undertreated. I think that a main approach the last year that improved the mortality was the use of team-based care for cardiogenic shock based on specific cardiogenic shock teams at centers. You can see here a trial published in recently in JACC that the use of these teams in specific cardiogenic shock centers can improve the mortality, and the survival of these patients exceeded from 60% the previous years to 82% the recent years after the use of cardiogenic shock teams for both patients with an acute coronary syndrome or patients without with other cause of cardiogenic shock. Actually, there are 4 published trials involving cardiogenic shock teams: the National Cardiogenic Shock Initiative, the Innova Heart Vascular approach, the University of Utah Health approach, and University of Ottawa. You can see here that in these 4 centers with specific cardiogenic shock teams, there is improvement of mortality and cardiovascular outcomes short and long term for these patients. They use also specific services in centers with cardiogenic shock teams can improve also then mortality in these patients. Thus, the transfer to the hub hospital, this is a very recent published paper in European Journal of Heart Failure from the US Registry of Cardiogenic Shock, comparing the transfer to hub hospital in comparison to directly admitted to spoke hospitals or hub hospitals. You can see here that patients transferred to hub hospitals from spoke hospitals had a lower mortality, and also in these cases there is an increase of use of mechanical temporary mechanical circulatory support in these patients. Also, the use of reperfusion strategies was very high, and the mortality, as mentioned previously, was lower. These teams can use extensively the echo services, the first-line echo diagnosis in ED or pre-hospital setting will be useful, identify the type of shock, the obstructive, the distributive, the cardiogenic, the etiology of cardiogenic shock, estimating also the pulmonary congestion with B lines or peripheral congestion or IVC diameter collapsibility index. And the second line echo diagnosis is the more comprehensive evaluation of echo in order to see more hemodynamic parameters. I think that there is also space for right heart catheterization. In cardiac trial, there was no difference in mortality between the patients used right heart catheterization versus patients without the using of right heart catheterization, but there is also a prognostic value for some indexes derived from the right heart catheterization in this trial. But I think that except the classical indications for Swan-Ganz catheter in cardiogenic shock, there is space for a new indication to guide the selection of proper temporary mechanical cardiac support in these patients. In the setting of acute PCI, I think that after culprit trial, it's clear that the message to intervene only in culprit lesion and not to correct or to treat the other significant stenosis in these patients. Regarding the inotropes, there is also a 2B indication, weak indication, because in the majority of trials there was negative correlation of inotropes with the mortality in these patients. And also there is a negative trial with the use of epinephrine. Epinephrine is harmful factor in these patients, and we prefer mainly norepinephrine in these patients for the treatment of cardiogenic shock. Actually, there is also a very recent randomized trial comparing milrinone versus dobutamine cardiogenic shock. There was no significant difference between the two groups regarding the primary endpoint, But if you see a specific sub-analysis, it's interesting to report that patients with beta blocker therapy, pretreated with beta blocker therapy, 24 hours before the presentation of cardiogenic shock, had fewer deaths in the early resuscitation period, suggesting a paradoxically protective effects of beta blocking patients with cardiogenic shock. And this is also in the same way with the SURVIVE trial, that the use of levosimendan in these patients combining with beta blockers had beneficial effect in hospital mortality in patients with acute severe heart failure. The use of inotropes is beneficial if there is early use, not delayed use. This is also data from Frank Peacock, that the early use in a time lower than 10 hours from initial presentation of the shock can be related with benefits in the use of inotropes. And there is also a step-up diagnostic algorithm from our department regarding the use of inotropes in these patients, beginning from the ominous cardiogenic shock with permissive volume resuscitation to compensated cardiogenic shock with the use of dobutamine initially or levosimendan, especially if there is RV dysfunction with high pulmonary artery pressure. In overcardiogenic shock, to combine norepinephrine and dobutamine or alternative levosimendan and norepinephrine. In refractory cardiogenic shock, 3 factors: norepinephrine, dobutamine, and possibly vasopressin, and consider mechanical support. And finally, in circulatory collapse, there is space for adrenaline and mechanical support. The next step is the hemodynamic support with short-term mechanical support systems. You can see here some of them: the Impella for right ventricular support, Tandem Heart for right atrial ventricular support, VE ECMO, intra-aortic balloon, Impera for left ventricular support, and final Tandem Heart for left ventricular support. But I think there is, it's very important, the selection of proper system for the hemodynamic support of these patients. And there is now here a role for cardiac right heart catheterization, because the use of these 2 parameters, the CPO and also PAPI, are 2 important parameters for the selection of these systems. CPO is the mean arterial pressure with cardiac output, and PAPI is an index, the ratio of difference between systolic pulmonary artery pressure to diastolic pulmonary artery pressure to right atrial pressure. If there is only high PAPI at high CPO without high PAPI, there is no need for hemodynamic support. There are some other combinations with low CPO, low PAPI, with that needs biventricular support, low CPO, high PAPI, only LV ventricular support. If there is low PAPI with low CPO, also right ventricular dominant cardiogenic shock support. Contraindications for mechanical support is this anoxic brain injury, irreversible head organ failure, no good vascular access, and also DNR. I will close my presentation with the last 2 slides. I think there is a need in the national health system for a well-structured, well-organized network for cardiogenic shock from level 3 hospitals to transfer without services of mechanical support or PCI, to transfer these patients to level 2 initially for PCI facilities, or level 1 cardiogenic shock centers with hemodynamic support and PCI also facilities. I believe that this network is very important in order to improve further the outcomes in cardiogenic shock. And these centers have specific teams involving interventional cardiology, ICU physician, or emergency physician, or cardiac surgeon, or nurse, and also heart failure specialist. And we need also a multidisciplinary team approach from other doctors in order to support this approach. In my conclusion, I think the cardiogenic shock is a complicated clinical entity with complex pathophysiology that leads to impaired organ function at life-threatening multi-system organ failure. It has an elevated morbidity and mortality despite the use of advanced medical therapies. Cardiogenic systems of care that include multidisciplinary teams have shown improvement of short and long-term outcomes, including quality of life and survival. I think this is the future for the treatment of cardiogenic shock despite the advances in pharmacological and also mechanical therapies. Thank you for your attention.
Thank you, John, for this fantastic review. Now it's time for questions. It seems clear that we need networks for cardiogenic shock and with cardiogenic shock centers. But in clinical practice, many times there are patients that are very old with a lot of comorbidities or have in a very advanced situation of mechanical complications and are not admitted in the cardiogenic shock centers, and or perhaps they are for palliative care. Do you think that we need some scores or some way to identify these patients that will not be feasible for entry in the network?
Yeah, it's a good point, that because there is no space for all these patients to improve the facilities of hemodynamic support or intervention procedures, that we need also palliative care. I think the multiple organ failure evaluation, if there is irreversible multiple organ failure, is also a factor in order to select a palliative care. Also, if there is a neurological improvement after the initial treatment in this patient. Also, patients with a lot of comorbidities without potential benefit for mechanical intervention also can be excluded from this approach. But I think it's very crucial to evaluate the patient step by step and to see all the parameters, to create also the scores, potentially also hemodynamic parameters with right heart catheterization are useful, as presented some data with markers like CPO or PAPI are markers also used for long-term mechanical support in advanced heart failure. And I believe that also scores like MELD score, that is score for advanced heart failure, including bilirubin, also creatinine, reflecting multiple organ dysfunction, MELD score modified can be also useful for these patients, because a very crucial point in the evaluation is also right ventricular dysfunction. If there is right ventricular dysfunction, there is need for biventricular systems, and the mortality is very high, and the morbidity is very high, and the complications are very high.
Any other question? If not, thank you, John, for this excellent presentation. I hope to see you soon.
Next year, I will be the next year in the meeting.
Of course. Bye-bye.
Bye.
Okay. At this point, it's supposed to be the presentation from Professor David Brennan from San Diego, that unfortunately has been stuck in San Diego, and this will arrive only tomorrow. So he has a clip that we can put on our website, or we can send to everyone that is interested to have this presentation from San Diego multidisciplinary approach in COVID-19. So at this point, I think we can have the conclusion remark. I will ask Christian and Alex to join me to the podium. Thank you, Joseph, for the co-sharing. And I think, Christian, we can start. So we can have, what is good that we are in time. That's unbelievable. Having said that we have 35 young fellow presentation plus 10 lectures and 2 from industry. So it has been long sessions, but also very fruitful. What do you think?
Absolutely. So I think I again wish to take the opportunity to congratulate you. This is it was impressive to see the quality of both the research and the presentation skills that you as the young faculty had during the last 2 days. Again, outstanding performance. And again, so this congratulation goes to you and to your research teams and your support that you have received in obtaining the skills and providing such outstanding presentations. We have thought of what we can offer to you as additional recognition and reward for your outstanding presentations. And we are in the process, together with the fantastic technical team in the background, to prepare short video clips. So the whole sequence will be put on the web. So that's for sure. And we will invest in post-processing so that every one of you, each person of the young research fellow, you will get a video clip with you on stage, with the discussion, so that you have this and you can share it with your friends, with your family, and have every reason to be proud of the fantastic performance that you have. So again, I think it was absolutely impressive to see the great networking, the fantastic quality of your research, and particularly also your presentation skills.
Yeah, this is a great idea. Like, you know, sometimes when you ski, they do a video of you so you can improve your skiing. Also, it's also a good way for people to improve. This is really great. Thank you, Christian. This is something I was not aware, but I'm very happy to have it. So, moreover, let me tell you that this is really it's been special to see that during the 2 days, almost 85% of the room was full. I think is really an important commitment that is everyone interested to be here. And Alex, you can join us, or you want to be out of the group? I don't think so. So also we would like to have some remarks from your side. Yeah, this is also important. I see that everyone from this special position, you can really have an idea how much was the attention for each presentation. And I think the topic that we addressed makes the future of our group even more important, because we really had so high quality research feedback that is really something that encourage us to maintain this standard and to go forward. And again, I don't want to say again, but I think the support of industries is very important. I really appreciate that they will never conditionate any kind of presentation. This is also something that I would to really appreciate, because I mean, all the support that we received again from all the sponsors, Roche, Orthoclinical Diagnostics, Siemens, Konica Minolta, Adrenomed, MCheck, has been really not with any conflict of this presentation. I really would like to appreciate this. And I would like also to make a big thank you to organizing, to Valeria, and all the staff that has been working with her. Alex?
Yeah, thank you very much. The first spirit, 14 years ago now, was three main aims. First, outside the classical organization, political organization, we love them, we are part of them, we're a member of them, but we thought to stay outside of them. Two, we said fellows first. Now, I'm not helping here the median age in this room, showing that really the median age of this room is very, very low. And this is really the important point. And third, for those who were, I think most of you in the General Assembly earlier, is totally transparent for the budget. And you know the budget is to pay the visit that we are going to have in a few minutes, to have a better impact factor for great publications. Then the money is for hotels, food, we pay the travel. And from day one, this was the spirit, to have people motivated to come. And we see that 14 years later, the spirit is still there, and we're really right to structure great around those 3 topics. And again, bravo to all the young guys. And I couldn't wait to see who won the award later on. I don't know why. I'm sure like every year, the jury would say, Salvatore, Alex, Christian, are you sure we cannot give 1 or 2 additional prize? And we will be always happy, because you are doing a so great job, and some presentations just were so much eye-opening. Really, we are, the 3 of us, we are enjoying so much, and bravo to all of you.
There's one particular thing that I want to add at this point in time. I want to really thank the fantastic team, the technical team in the back, and please give your applause for the people in the back. The quality of the images and the sound was phenomenal. So I have received many positive feedbacks, and likely the 2 of you also from our colleagues who were following on the YouTube channel. So it was really exceptional quality. And I think it's this professional, I think, quality that we need to have the appropriate recognition also to the research fellows, that the quality of the transmission back home and also in the room was outstanding. So thank you very much. And the last thing is to those of you who are online, whether you are in Sao Paulo or in France or in Switzerland or somewhere else in the world, thank you very much for joining the meeting. Thank you for staying online. And I think it's a great opportunity for whatever reason you were not able to join us physically, to still be part of this fantastic group.
Just last thing, we are missing the photo this year. So this is really something that we have to do.
Oh, we can do it in the Vatican, huh? With your
my friend.
With your friend.
Yeah, with the German in white.
But so everybody.
Can you tell him to stop putting white thing? Maybe?
Yeah, I will do this. So everybody is coming to the Vatican. Okay, so we make the photo there. It's a great idea, because we really need to have a day photo, right? Otherwise, that will be a little bit.
Be a nice
okay.
Photo.
Prepare for the photo.
And tomorrow there are photo and the soccer game.
Soccer is a good topic. So according to well-informed persons, so this guy has worked hard to establish an outstanding Italian team for tomorrow morning. And we have to acknowledge, of course, that Italy is the defending European champion, and so we know that it will be extremely tough for the international team tomorrow morning. Therefore, I need your help, all of you. So please, all of you, the international participants, please join us tomorrow morning for the football game. We need you. So it's always, we don't know who has brought the football shoes and the equipment, but we need all of you in order to be trying to be competitive versus the acting European champions.
And this is even more challenging because we have 7 women from our Italian team that will play tomorrow. So you need really to be even much prepared. Okay. Okay, thank you again. Thank you, and see you in the bus in the Vatican. Thank you again to participate to the great meeting.